వచ్చేసి
జడిసిపోయా కదన్నా నేను. అయిపోయా ఎలా అంటే వేరే వాళ్ళది కదా కెమెరా. నేను చెప్తున్నా ఫినిష్ క్లోజింగ్ 2 గంటలుగా 2 కార్డు చాలు కదా. 64 ఇది 2
ఎంత పెట్టాడు?
50 ఐకే ఉంది.
అది ఎంతలో ఉంది?
1850 ఐ.
అది ఇదెంత పెట్టాడు? 12 సాలిడ్
2 కార్డు వస్తుంది కదా.
ఒక కార్డులో ముగిసిపోతుంది. 12 3 అవర్లు వస్తుందా? చాలు.
ಚೆಕ್ ಬರ್ತಾ ಇದೆ. ಚೆಕ್ ಕಮ್ಮಿ ಮಾಡ್ಸೋಣ. ಚೆಕ್ ಚೆಕ್ ಚೆಕ್. ಹಲೋ ಅಲ್ಲೋ ಒಂದು ಎಕ್ಸ್ ಆರ್ ಕೇಬಲ್ ಒಂದು ಆಕ್ಸ್ ಕೇಬಲ್ ತಗೋ. ಚೆಕ್. ಹಲೋ ಹಂಗೆ ಹಂಗೆ. ಚೆಕ್ ಚೆಕ್ ಚೆಕ್.
talking encyclopedia ना ये this trial this many patients this इतना ये इतना वो
First session of the morning. The session is on nuclear medicine. The program director is Dr. Ishita Sen. She is the director for nuclear medicine from Fortis Gurugram. Welcome, Dr. Ishita. And Dr. Gayana, she is a consultant nuclear medicine in Fortis Bangalore, Banerghatta. The first topic is for the day is radiomolecular therapeutics translation into clinical practice. The panelists for the session are our Senior Director, Urology, Uro-Oncology, Dr. Mohan Keshamurthy from Fortis BG, Dr. M.C. Uttappa, Dr. P.S. Sridhar, Dr. Poonam Patil, Dr. Pramukh Kulkarni, Dr. Mary Ann Joseph, Dr. Ranadhir Gupta from Hyderabad, Dr. Dharmender Malik from Gurugram, and Dr. Murali Nadik from Bangalore. So I welcome you all to please start the session.
Good morning and welcome panelists. We are indeed privileged to have such an esteemed set of panelists here, all stalwarts in their own field. Get some more insights into the use of radiotheranostics in medical oncology and in oncology practice as such. So I think we've split some of the cases. So we have 5 cases which we hope to go through quickly during the next 45 minutes. And I'll hand over to Gayana for the first case.
I thank all the panelists for joining us for this discussion. We are going to discuss basically directed cases, and we would need your expert opinion for all the clinical conundrum that we face in our day-to-day clinical practice. This is a case of a 62-year-old male diagnosed with metastatic carcinoma prostate. The patient has been treated with hormonal therapy and has received 6 cycles of docetaxel, and the last cycle was in May 2023. Now the patient is on tablet enzalutamide 160 milligram per day, and the patient has serum PSA level which is progressing, and the gallium PSMA scan done in August 2023 compared to that done in February 2022 showed a progressive disease pattern. So this is the scan which was done in February 2022, and this was in August 2023. As we can clearly see, the lesion in the prostate has progressed along with the appearance of the lymph nodes and a few skeletal lesions which are all tracer avid, and on the MIP itself we can make out that the tracer avidity is more than that of liver and spleen. So in this case, as we can see, the lesion in the prostate is now infiltrating the bladder compared to the prior study, and it is involving the bilateral VUJ, causing bilateral hydroureteronephrosis, right more than left. So this patient underwent DTPA renogram. Here we can see that the function of the left kidney is reduced, and it is around 29%, and there is hydroureteronephrosis with delayed clearance of both the kidneys. So my first question to Mohan Keshamurthy sir, in this patient with hydroureteronephrosis, before considering any further treatment, how would you want to intervene?
That's a typical scene which is difficult to manage. Depends on the how well preserved the patient is and how motivated the patient or family to pursue further treatment. We will have to find what is the baseline creatinine and then possibly antegrade stenting if the creatinine is elevated. If the creatinine isn't elevated, then it should be managed as a part of the treatment for the primary. If the creatinine is elevated, that takes the first clinical focus. So retrograde stenting may be attempted, but 90% of the time you won't find the orifice, and you will, because the disease is behind the bladder and is infiltrating from behind towards the bladder. So it's very difficult to antegrade TCN plus or minus stenting, or antegrade TCN followed by stenting a week later. And once the creat comes to normal, then the patient returns to baseline. In this particular setting, I would use silicone stents, anticipating that the stent will be there between 6 and 12 months. So that's how.
This patient visited you, sir, and you did the standing for him. So this question is to Dr. Sridhar P.S. What is the role of radiotherapy in metastatic carcinoma prostate, especially when it is in a hormone-resistant scenario?
So, classical HRPC patients and as a multidisciplinary team approach is the key here. And we are still looking for a long-term control of the disease, and patient is not going to die in, like the survival benefit is still there. So definitely I would like to go, the number matters. That old scan, what you show, some of them is not the one what I want. Exact numbers matters for us. So up to 5-6 lesions here, like definitely is a candidate for SBRT for the prostate, including the bladder infiltration once the bladder part of things is already taken care. And the number of, and all the metastatic sites. Here I'm seeing only the lymph nodes are there and only 2 bony metastases. We can irradiate all the bony metastases. And we have seen the survival advantage in our own series. We have published our data. So like still the patients will reach a double digit. So that is important.
So
Is it?
I'm
Can I?
sorry. So would you like to irradiate all the lesions? I mean, would it be with a curative intent rather than with a palliative intent?
Absolutely. I don't see there's a palliative intent to be considered in this. Only problem it may occur is the patient may have a perforation, like the bladder, the perforation, so that if it goes very well. So it's a slow growing tumor. It does not happen in one day. So it may happen around 2 years or though if the disease goes off completely. So I'm ready for that.
So the nuclear medicine people, do you have anything to
Yes, sir.
counter?
One, that whatever Dr. Sridhar is saying, I accept if it was a oligometastatic, pre-treated metastatic CRPC. This is a hormone or at least CRPC, not, I don't know about hormone refractoriness.
It is HRPC, yeah.
Castration. Is there any trial showing that in a treated case, whatever you are saying holds good for a oligometastatic prostate
It is
cancer?
oligometastasis.
Yes, but that is not pre-treatment. It is post-treatment, post-docetaxel and this thing.
No, that doesn't matter. It is not
Which trial you are
See,
putting?
oligometastasis,
Which
when
trial you are
the
putting?
definitions, we are opening a Pandora box now, actually. So, when you consider in a prostate cancer, especially that if you're seeing a oligometastasis upfront, not done anything, that is where the radiation is used. I don't agree with that point at all. When we talked about the trials also, the oligometastatic settings, the HRPCs is one of the main indications. You can add on systemic treatment in terms of PSMA therapy, but in terms of drugs and the control of the disease, definitely this patient is a candidate for SBRT.
Which trial, sir?
Trial part of it, it's very like the Sunday morning, if you ask for the trial, it's very difficult for me to tell.
No, sir,
So,
we are talking.
Okay,
Would you-
so I'm telling
No,
you,
my
I'm
wife
doing
is
for
a radiation
15 to
oncologist.
14 years. 14 years. My own, this one, like even the Stampede trial, if you want the name of the trial, the Stampede trial did
Stampede
everything.
trial is
So
prior
everything-
treatment, pre-docetaxel.
No, it has done 11 arms, including the patients who received the docetaxels post-treatment as oligometastasis progressive, has done they have done only the metastatic side. Treating the primary is also important. So here in this case, the patient has not received the radiation in the past. It's only the hormone treatment.
Stampede trial, the overall survival was not very high in at least this group. I can definitely say, and I'll urge that it is whatever you are saying holds
In the
good.
prostate
Pre-treated.
cancer, the survival, what you want to add, in urology form, I told that in a prostate, are you making a patient immortal? 2 years, double digit, if the patient is reaching 10 years with a metastatic setup, I am happy.
So would you think that by giving so much radiation, this patient has got scattered mets? Would you?
That's what I told, the
Yeah.
number matters.
So you have a
Fine.
large. You're going to irradiate the pelvis, which is
No.
Okay.
No,
Only
that's
the
what
prostate.
I'm talking about. I'm not talking about the normal radiation here. It's a SBRT,
SBRT.
stereotactic body radiotherapy. I use cyberknife, 5 lesions, no margins are given.
Okay.
Whatever the tumor, in fact, like when sir told that the stenting is an issue, so sometimes we do SBRT first and then do this stenting, and then consider for systemic chemotherapy or the next line chemotherapy.
So, in a situation where we would be we are obviously thinking of lutetium PSMA as a modality.
No issues
in this.
about that.
So,
We can still
what
consider.
would you like to schedule? What would be the schedule of the therapies? So, would you like to do the lutetium PSMA and then do a salvage radiotherapy, or would you like to do the
In
radiotherapy
this
and then?
particular case, I see 4 to 5 lesions, apart from the prostate and the lymph node. Can you go back?
Image.
Image. That's what, and in case
Sir,
of the
this
report,
case,
what you said.
this case is clearly more than 5 lesions, so this will
Well-
not qualify as
So
oligometastatic.
that numbers, in terms of what you have shown here, apart
Yeah.
from the bladder and the direct
There are a
prostate
few
and-
lymph nodes. The lymph
Yeah.
node number
So lymph
itself
nodes
crosses
is not an issue
5.
for me. I can leave that.
Yeah.
The bony lesions and the bigger lesions.
Sir, then we are not treating it with a curative intent, right?
It is a curative intent.
If we are leaving out the lymph nodes.
The systemic treatment is a multimodality treatment. Is the one what we are looking at.
Okay.
So, would you like to do the PSMA first to get a systemic control, or do the radiation first and then follow it up with?
See, PSMA, what the sequence is, if it is less than 5 lesions, we do SBRT alone and then go for systemic. If it is more than 5 lesions, we go for PSMA.
PSMA and then for SBRT. Okay.
Even here, actually, the prostate and the bladder is going to be a problem in this case. So even if you do PSMA therapy, usually after 2 months, we do primary prostate and the bladder infiltration.
Would you agree, sir? Would you agree to this?
Basic issue is I'll bring reality into practice. What happens is, unfortunately, in our part of the world, this comes to the uro-oncologist first and then goes across. If I was still in North America, I would have been a consultant who would have been referred a patient like this. So we are not still a radiation dominant or a nuclear medicine dominant program. Theranostics, it takes a lot of effort to tell my colleagues what exactly is theranostics. So we have still not arrived there. So what happens if the patient is mine? There are 3 important considerations, as I said at the beginning. How fit is the patient? How much anticipated disease-free, pain-free survival, or pain-free survival with controlled disease do you anticipate? Is it at least 5 years? So that's the first thing. Second, him and the family, whoever is supporting him. Typically in our scenario, if the patient can afford the therapy, we're all discussing, the kids won't be here. So that's this, who is the caregiver? Because there'll be multiple visits to the hospital. Having put these 2 points and then we go ahead, then I would involve, the cost becomes the next important. So here, if for me, radiotherapy is an inexpensive choice. Lutetium or actinium, when available, is an expensive choice. And again, if you're going to sequence it, I would always sequence the more, if there is a curative. Again, if it is three bony sites, I wouldn't go till 5. I would go till 3. I would prefer a radiotherapy, SBRT, short course. Again, that's important because not multiple visits to the hospital. Although the amount of side effects may be high, we can keep the patient in-house. But again, spreading it over 6 weeks and then a systemic therapy is going to be a problem. So I'll put it this way: is the patient fit for combined modality treatment? Number one, can the patient afford it? Does he have social support to bring him to the hospital and take him back in case there's an adverse event? And is he insurance supported? All of this put together, then I would, if there's three sites, I would go ahead with radiotherapy with a possibility that whatever is left over will be treated by theranostics. If it is more than 3, and if the patient can afford, we'd go with PSMA. Lutetium is what we use at this point, and then whatever is left over goes to SBRT. At all points, you should remember this patient can go into retention. The volume of the disease that is there, and then we'll be forced to do a channel TB at that point in time. And post radiotherapy, at least in our practice, 1 in 5 patients comes with a difficult stricture. At some point, they'll end up with a perineal urethrostomy or a suprapubic cath, so or a condom cath if nothing can be done. So you have to remember there is this possibility. The more aggressive we are with radiotherapy with curative intent, greater is the possibility this patient will come to ER mid-post treatment with retention and with this volume of disease. So all of this will involve cost, and that I think, practically speaking, of course, in an academic forum we shouldn't bring cost in. But having said that, is 3 sites, we'd go with radiotherapy. More than 3, would sit down with the multimodality tumor board and then see what is the overall cost, overall time period, and then sequence it up.
Poonam Patel, ma'am, you want to add something to it?
Yeah,
This is a case definitely for MDT treatment. I would not take the decision alone here. And if you ask my opinion, I feel we need to keep all our modalities of treatment in reserve. So I would probably use lutetium PSMA first, because right now the cells are displaying the PSMA receptors, and over a period of time when they lose the receptors, that time the therapy is unlikely to be effective. So maybe that time I might keep radiation as an option when the PSMA receptors are lost.
Ma'am, would you re-biopsy this lesion at this point
For
to
what?
look for any next generation sequencing, or to look for any whether there's any option for PARP inhibitors or
Yeah,
anything?
certainly. But that is something totally different aspect altogether. Yes, totally different discussion.
That's an interesting question about rebiopsy, and I was asking in the Euro-Onc forum yesterday, what is a rebiopsy? If the testosterone level is castration level, and two values a month apart show castration level, and there is no PSMA uptake, in areas there was PSMA uptake, clinically I would think there is neuroendocrine transmission, and I would think Dr. Patil would be the person, in the sense that the med-onc would be the person to go to. But if there is PSMA uptake, and it is still between castration, 40 nanograms to say 60, I would still go with, as she rightly said, PSMA sensitive, because that is what may possibly give you the maximum systemic input, and then go across. If the castration level is reached and there is no PSMA uptake, and the disease does show progression symptomatically, I would do a FDG PET to confirm it as neuroendocrine, and then go ahead and get a chemo consult, shrink the disease, and then go forward. So the rebiopsy is only in that situation. But again, 2 points. 2 points there. Would you rebiopsy the primary, or you would rebiopsy the one with the maximum SUV? If you want to rebiopsy the one with maximum SUV, is it accessible? Not accessible. So this is again an issue. And in a patient who is as sick, the possibility of ventilatory support even for a day, the family won't accept. So atta patient walking in, you're going to biopsy just for a biopsy, let me possibly suggest. So anything above the diaphragm, very, very hesitant to biopsy.
Would you re-biopsy the most PSMA avid or the least PSMA?
I would have take the least PSMA on the primary. If the primary has shown progression, we'll do the primary. If the primary has shown no progression, then the one which is least avid is what I would.
Yeah.
Because
Makes
obviously,
sense. Obviously,
it
the
is
more
FDG,
the
it'll show up on FDG,
de-differentiated
not on
area.
In this very unusual days, you told us clinic max.
No, sir. We were comparing the splenic uptake. Whenever we are considering a patient for therapy, we'll take it as a baseline.
I prefer both the dialysis, primary and
Okay. So, ma'am, this question is for you. Lutetium PSMA therapy before docetaxel. So, we have a clear-cut recommendation. We just want to...
Yeah, as of now, there is no
recommendations
of lutetium-177 before docetaxel. The recommendation is post-androgen receptor pathway inhibition and docetaxel.
So, any of the nuclear medicine people would like to tell us about the PSMA-4
pro-PSMA trial,
PSMA
therapy trial?
Therapy, it compares with cabazitaxel in metastatic CRPC patients. In comparison to the cabazitaxel arm, it is equal in overall survival, but had better quality of life and better progression-free survival. And comparison to the upfront trial, where they are directly giving before, that is called, another name of that is 4. They are giving, they have shown, it is still analyzing, the data is still analyzing, accumulating, and it is directly in metastatic CRPCs. Upfront PSMA therapy is the one which is being tried upon, but the results are, complete results are yet to be published.
Ma'am, patients with multiple comorbidities who is not fit to receive chemotherapy, in such patients who is taxane naive, would you recommend lutetium PSMA in a taxane naive patient in such scenarios?
I would probably go on with lower doses chemotherapy, weekly chemotherapy, and try out that option first before going for this.
Practically what we do.
As far as the quality of life is considered, I think lutetium has better quality. One study by the PGI Chandigarh also that proved that
non-inferiority study. Basically, the response rate of lutetium PSMA therapy are better as compared to the docetaxel, 60% versus 40%. And right now in the November, they have published the long-term median follow-up of 34 months also. So overall, the median progression-free survival is more as compared to the docetaxel. So that study stand out that lutetium PSMA therapy is a better in care of quality of response as well as the response rate or quality of life as compared to the docetaxel.
But both in AUA and EUA guidelines, I'm coming from the Euro-onc side, I'm not coming from the nuclear medicine side. The pathway, as Dr. Poonam said, is only after docetaxel, it's not before. So only on exhausted docetaxel, you possibly space it over a longer period of time, dose it lower per meter square, and do it more often. So you possibly would look at smaller exposure, but over a greater period of time. And when you have exhausted that, that is when you would know it. In the Indian scenario, the cost remains a huge factor. Because unless, to get IRD approval, for example, if you want to do this kind of therapy, I'll just digress for a minute, you will need to prove that it is as good or better than the pre-existing, and the cost should be lower. The cost can't be higher. That's the problem we face with lab versus robotic surgery every day. So for diagnostics to be accepted, nuclear medicine clinicians as a lobby will have to get IRDA to look at it, and only then you will find an academic discussion. Actually, that's the topic. Clinically translation, how much ever we decide, the guidelines have to change from the Euro-onc point of view. And because the boys who we train with, they will do what I do. They will not do anything new for 5 years till they have volume. And the second point is, there has to be insurance support. Otherwise, it's going to be very difficult to translate cost of the factor. Academic thought process, even if correct, has validity only when you can apply it practically.
But may I know, what is the cost difference between weekly docetaxel?
Huge.
Weekly docetaxel costs about 8.5 to 13,000 rupees, correct me, and this will cost between 2.6 lakhs.
But it is at 3 monthly intervals.
Correct. The point is,
It doesn't add up.
Life is today. So you're projecting 2.6 into 6. You're giving him 15 lakhs over 18 months, and you're talking of 1.5 lakhs over 6 months.
No, I think the 2.6 lakhs is for the German
Interesting.
lutetium.
Indian
Lutetium is just about a lakh.
That is the other part. There is a lot of opaqueness of what it costs. I mean, I have learned about lutetium because there's a girl standing next to you who is educated. Even in our own set, we really don't know what is the cost. And when we don't know as a clinician who is referring, as I said, usually it comes from us to you. It is very difficult to conduct that, and you should take it in the context that this is multimodality treatment. And there is also life support system that is going, right from nutrition to transport to our facility. In Bangalore, transport takes a lot of effort and time. So overall, I feel cost is something that will put in practical efficacy. I agree. In a year's time, as data approves, as the gentleman was saying, you will find that possibly lutetium is a better choice or a primary choice.
So not even a year, sir, even 3 months intervals.
And transport.
The data coming in a year.
The problem for data is in Europe and US, the cost difference is even huge.
Correct. And that is
In
why
India-
we are getting co-opted into most of the trials by most of the companies to bring the volume back into focus.
Yeah.
But if we have a UA or a AUA guideline change in favor of lutetium, then you will find
Sir, we had the vision trial results out where the cost-effective analysis was also published, and with respect to treating a patient post-taxane and post-first cycle of hormonal therapy, the cost-effective analysis also proved that lutetium PSMA therapy was superior to the other forms, that is the best supportive care. But we are talking it prior
The number of
to
hospital
vaccine.
visits also is very less with
Yes.
lutetium.
that is exactly from the last month I've been campaigning for Dr. Gaina to come and address all my postgraduates of the benefit of theranostics. I have been
Yes.
campaigning for the last month because unless you get a young uro-oncologist mind captured into an alternative treatment, you're not going to get referral. So that's why I'm campaigning. For the last month, I'm telling, please come present for 45 minutes, your referral will improve.
The number of hospital visits is very much less compared to any docetaxel or whatever.
So this is the vision trial results. We can see that the OS and PFS benefit both in these patients, and now it has been approved post first line of taxane. So, ma'am, this question is for you. Cabazitaxel versus lutetium PSMA. What do you prefer and why?
So just now we discussed about it, that I would prefer lutetium PSMA over cabazitaxel, and we discussed the reasons.
Okay. So this is the therapy trial which states the results for the same, and this is a question to nuclear medicine physician. So what is the current evidence for lutetium 177 PSMA therapy, strictly going by guidelines?
Strictly going by guidelines, I think it is being referred only after failure of two types of treatment, androgen therapy and at least one line of chemotherapy. But I think most of the guidelines, the lutetium has been reserved as the last case and as a waste basket cases. So there really you cannot give evidence.
I'll counter that part. I don't look at it as a waste basket. I will tell you, when I came back from Canada, I used to see, say, 100 patients of cancer prostate a year. Most of them referred for surgery. Today, in the last year, we saw 880 patients of cancer prostate. And 2/3 were inoperable. So there is a significant difference. The reasons are two. Indian men are living longer. Both of us will live much longer than our forefathers on an average. And second, access to treatment is better. PSA is more freely available, and therapeutic options and multimodality treatment is more often done in the last year than it was done in my entire career. I attended more MDT for cancer prostate in 2023 than I have done in the 20 years prior. So there is a considered approach that both quantity and quality of life is equally important. And there is also an acceptance, as I said, if a patient has 5 years of good quality life, then the best single option or the best multimodal option should be offered to him, and whatever is consensually accepted between the family and us. So I won't take it as a waste paper basket, but I would take it as an option beyond all the other modalities failing, because it is like the Bahubali formula. What none of us can achieve with surgery, chemotherapy or radiotherapy comes to you. You should look at it as the Achhe Din Aayenge rather than.
So I have,
So,
very well taken, but I have just one point. By doing a PSMA PET, by calculating the disease burden, I think lutetium PSMA may be a better considerate treatment option than even chemotherapy, is what I feel.
So coming to the other end of the spectrum,
And,
there is a growing body of evidence which is still very small, but which is talking about using lutetium PSMA prior to hormonal therapy, in a situation where you have oligometastatic disease, to use it as a modality to defer hormonal therapy. So the premise being that you are actually giving the patient many more years of good quality of life by deferring hormonal therapy. So can I ask the nuclear medicine people, anyone has a experience on this?
I don't have an experience, but I have, there is a thought process that hormone treatment will induce resistance. It will induce de-differentiation from low grade to higher grade. Therefore, lutetium PSMA, see, every time I don't go by only evidence generating, logic and rationale are equally important. So, based on logic and rationale, if the hormones hormonal alteration is going to induce de-differentiation or more aggressiveness, then why not use that as a later reserve? That is my question.
There is a contrary evidence saying that enzalutamide and abiraterone increase PSMA expression. There is a contrary, and coming to the current evidence of PSMA, now they are not, the medical oncologists have become more radical. They are not only using hormonal therapy, they are using novel androgen inhibitors and docetaxel as a first line. They are, yes or no, madam? Everything they are using in first line. So post first line, second line is PSMA, there is no doubt.
No, I'm talking about first line.
Now coming, when we want to come to the first line, there are many problems, which including, I disagree with my counterpart itself that there are two schools of thought. One, hormone causes de-differentiation. There are other school of thought that hormone inhibitors increase PSMA expression. So that's why it's a, do I agree with him most of the time?
Short-term and long-term exposure to hormones, which a short-term exposure to hormones may increase the PSMA, whereas a long-term exposure to hormones will actually reduce the PSMA expression till it becomes more resistant. Biology of the disease.
See, that's here we are talking about the metastatic disease. Less than 5 lesions, definitely PSMA therapy has no role. that is what the clinically what we want to do it. Why I want to tell you, with the existing one, our failure rate in a metastatic setup is single digit, 9 to 10% over 5 years. So why we are not liking that, as we are not telling that it is a waste basket. We are using sequentially in such a time when it is really required. In the same patient, if it is only 3 metastases, where we wanted to give local treatment and we want to keep it as a reserve. You want to use it as an early patient, then we have sent the patient. See, I am using with the PSMA therapy for last decade. 10 years I am in HCG with Kallur and we started as a first one. Even if the lesions is a metastatic upfront less than 5 lesions, we ask for. So when there is a clear-cut double-digit improvement in the normal things, so I really don't want to be exposed early, and it is not probably the one what we are looking at. If you prove it, only PSMA therapy is enough for like in a metastatic setup, it may come into the one, then there is no role of 3 lines we use it upfront. Forget about that, you are talking about a 1 line. 3 combination treatment in a metastatic setup of low volume, darolutamide, a triple therapy, we call it as hormone treatment, and the docetaxel, which has shown a very good benefit, and that is the standard of treatment. You are comparing with a Ferrari versus a Maruti. So please remember that.
No, they are the 2 studies that show the lutetium PSMA in oligometastatic cancer performance is better as compared to the widespread one, and we are able to achieve more PFS as compared to. Although there is no direct comparison with the radiotherapy.
See, another thing is, although I'm a radiation oncologist is left behind actually. But in right now, when you see that we have struggled with the surgeons to say that, okay, local treatment is good enough to do
Sir,
one.
but we will need a data to support that, sir. I mean, oligometastatic, providing the, oligometastatic disease or in a metastatic disease,
I'll send you the data.
providing the survival of almost 90% for a 9 or 10 years, for that we will have to need.
No, I'm not talking about in a metastatic setup of an oligometastasis. I'm not talking about radiation alone.
Yeah.
Please understand that there is no need to prove one over the above the others when a multimodality treatment is required. In combination of the chemotherapy, using the like SBRT to the area when it progresses, there is a clear-cut evidence that is a sequential. I'm not talking about I'll do only radiation, don't want to give hormones or the chemotherapy. No. Maintenance treatment is necessary in case of prostate cancer. So if you see 3 cycles of lutetium therapy, you want to give it and wait and watch, I have my concerns.
Okay, so I'd just like to add a few points. Firstly, apologies for the delay. I like to make a grand entrance, but about the Ferrari, sir. Data is insufficient on using lutetium PSMA as a first-line treatment, but one thing I'd like to point out, in a metastatic setup, agreed.
So that's what you were talking.
Yes, low volume metastatic disease. However, one thing I should like to point out is that a few things. One is cost, we have to factor in, which is not going in our favor as nuclear medicine. But we're talking about a Ferrari, right? So we're talking about the Ferrari. I can't afford the Ferrari. But a patient's tolerance to lutetium PSMA therapy on the first line front might be better as opposed to after 3 lines of treatment, because the patient will be relatively robust, better tolerable. The treatment might be better tolerable. So we have to also factor that into account. Like I said, since we're talking about something that may not be incorporated into the guidelines for the next maybe 5 to 6 years, that's one point I just like to add.
For want of time, we would go to the next case. But the conclusion of this case is we have Brahmastra, and we all agree that we have Brahmastra, and we are reserving it to the end of Mahabharata, unless there is some other Mahabharata where we can probably second line.
So
the question is why we are reserving it to the end? Why not on the prior? Why we are reserving it to the
why
last?
are we? I mean, that is our question. Hopefully, we will have answer for that question in
Probably
the coming 10 years. Probably, we'll have
you're
enough data
trying to
on that.
compete. I prefer you should not compete. You should add on.
Sir.
So use the PSMA therapy in a sequential. Probably use PSMA therapy first and continue with the chemotherapy and local side, and reassess after 3 to 6 months to give the second dose if the lesions are increased. So combination may be a better option, because that is also radiation. Don't tell that, okay, it is not radiation.
So we'll move to the next case. 24, here probably we'll have less of controversies, more of data backup. So a 24-year-old female diagnosed with metastatic neuroendocrine tumor of pancreas with Ki-67 index of 3 to 4%. Patient was on LAR for almost 5 years. Now the patient has disease progression and she has symptoms like loose stools and flushing. So the diagnosis of whenever we diagnose a neuroendocrine tumor, what are the investigations to consider? This question is for you, ma'am.
So biopsy first with the complete histopathology and immunohistochemistry, which will tell us about the Ki-67 also, mitotic count also, to classify it into low grade, intermediate grade or high grade neuroendocrine malignancy. Second would be of course the DOTA scan. And if the somatostatin receptors are present, then it tells me that yes, it is a neuroendocrine tumor and it is likely to respond to somatostatin receptor directed therapy.
Ma'am, would you consider doing any serum biomarkers, chromogranin?
So serum
SIA?
chromogranin is not a very great biomarker,
Yes.
and it has got many false positive and false negative implications. I may not do it.
What about an FDG PET scan, ma'am? Would you like to do it as a baseline? Or that question also is for my nuclear medicine physicians.
We will definitely do it as a baseline, because whatever you are doing biopsy, it is having a what you call sampling error. If you are taking from the sample which is having high mitotic index or low mitotic index, you will get that. But combination of FDG and DOTA will give you a proper net PET score of all the lesions, and that will direct me to proper therapy.
Even in grade 1 tumors?
Yes, it is grade 1 which you have biopsied. We don't know about the other lesions.
I will probably.
What is the cost implication with respect to this?
Very high compared to the.
You will do complementary.
Now you can do for less than 10,000.
The cost is never a factor in FDG. Other at least acts.
I agree. Yeah. So most of the time, the moment diagnosis is occurred, we do the FDG first, and then if there is a suspicious and the biopsy comes NET, then only we'll go for the one. So I think the combination is always there.
But it may not be replicable at every place, and the patient may not accept many a times. So I agree, ideal situation or desirable situation is to do both the scans. But if the patient has some reserves on radiation exposure, whatever, for cost may not be huge. Even if I am doing complementary, many times patients don't agree. So I will see the scan. If all the lesions are taking up tracer, then I will probably do away with FDG.
If we were to do, ma'am, I mean this is for you, in a patient where you've biopsy proven that this is a grade 1, grade 2 neuroendocrine tumor, and we do a FDG PET scan and we do see some FDG uptake and net PET score which says that there may be some degree of de-differentiation or in vivo heterogeneous differentiation, would that change your management?
Yes, it would definitely change the prognosis also.
So this patient had a 2.7 into 4.7 centimeter lesion in the pancreas, multiple peripancreatic lymph nodes, multiple liver lesions and lung nodules. These are the MIP images. As we can see, she has multiple, this is a lesion in the tail of the pancreas, multiple liver lesions and lymph nodes and a few lung nodules which were tracer-avid as well. So PRRT versus LAR, and this question is for you. So in this case, the patient was diagnosed with neuroendocrine tumor when she was 19 years old and she was put on LAR for almost 5 years. And now, since the disease was progressing, they have referred for PRRT. So what are your thoughts? Do you concur with it or with the evidence
No,
emerging?
I would concur with it. If it is a functional tumor, definitely, or even a non-functional one, I would go ahead with the LAR preparation of sandostatin. And PRRT, also we can go give PRRT along with LAR as well. So there are studies which have given LAR along with PRRT also.
Now the question is clear with the netter 2. There is no
Not
debate at all.
No, I wanted to bring up Netter 2 because the Netter 2 results are not out. It has been it has been just results published in ASCO. So we are waiting for the full articles to be published. And with Netter 2, they are telling that grade 2, grade 3 tumors upfront PRRT versus PRRT with or without LAR versus
No,
with LAR.
See,
Yeah.
always the netter shows with LAR.
So, ma'am, this question is again for you. Would you prefer only PRRT or is it PRRT plus? You want to give CAPTEM along with PRRT, or in a selective subset of patient, would you choose to give CAPTEM?
I would prefer giving sequential,
Okay.
not both
Ma'am,
together.
how do you want to time it?
PRRT first and probably CAPTEM later.
Okay.
Any nuclear medicine person who
Grade 1, I don't think CAPTEM is going to change is different.
let's talk about grade 2.
Grade 2, again plus or minus, I think we can decide based on the scan and SUV values. So, and grade 3 again based on FDG or uptake and SUV values we can decide.
If
Grade 3, the results are favorable. Grade 2 is again.
NetPet score 1, no class. It is only PRRT. NetPet score 2 and 3, I'll give CAPTEM. Sequential or concurrent depends on the what do you call the performance status of the individual. And there is another clause whether temozolomide increases the hematotoxicity of PRRT. That's the reason whether we'll do it sequential or concurrent. I prefer concurrent, but my medical oncologist prefers sequential. So it's there is no definite comparison whether concurrent or sequential.
I just would like to add on here. So we do like concurrent, and I'm very happy with the results. So like many patients, what we are seeing, they respond well. And you are lucky that you have a patients who are going to live longer, even with the small ear things. So even with the prostate, even with the NET.
We choose like that.
Choose your patient.
We are waiting to encroach the area with FAPI therapy in pancreas. So probably a long way to go still, but we'll be dealing those subset of patients as well, possibly in future. Sir, this question is for you, Dr. Uthappa. Role of intra-arterial PRRT in case of well-differentiated NET.
Yeah, so I have very limited experience with this, but whatever, I was just sort of sharing this with somebody else before the meeting. So intraarterial PRRT we tend to offer in patients who are liver dominant and who haven't shown a very good response to a standard IV PRRT protocol. So that's the main, and if they're symptomatic. So liver dominant disease, and if they are not had good response.
I think HCG is a major component of intra-arterial.
Yes. So, yeah, we have done a lot of patients for intra-arterial, with both the combination. Some of the doses given intra-arterial, some and the systemic. So, which works out better. That's what I was telling, that some of my patients we have really seen they're doing good. The lesions may be seen there, but they're doing fine. Intra-arterial, yes, it's possible, and we are doing it.
So one of the advantages that from at least limited experience against probably about 6 cases that I've been involved in the previous hospital and currently at Manipal, what is rewarding is that symptomatically they are very happy with that intra-arterial protocol that we tend to do. Obviously, I think based on that experience reported by many centers, the next trial is, the LUTI trial is up and running, so we'll have to wait for that. Once the trial results are out, my suspicion, gut feeling is that intra-arterial PRRT for liver-dominant disease will become the first line.
So we, at our center, we are also a big proponent of intra-arterial therapy, and we did a dosimetry study, and we actually were able to define that the uptake in the liver increases when you give intra-arterial. Although, I mean, the people who are non-believers in intra-arterial, they say it is non-embolic. It's anyways going to go away. But the first pass extraction is definitely higher if you deliver it intra-arterially. So,
This we have already discussed.
so for the proponents of PRRT along with CAPTEM, would you think that since these are patients who would tend to live longer, by giving an alkylating chemotherapy along with PRRT, you're increasing their potential risk of developing myelodysplastic
Yes.
syndrome?
So
going
I didn't tell you the full story. Actually, we have seen 2 patients of myelodysplastic syndrome. Disease is fine. After 5 years, actually, we lost one of our patients because of myelodysplastic syndrome. That's a risk, and because here there is no end. So because the captum is given continuously 6 cycles or even in the maintenance, and you are giving a systemic radiation. So both will actually accentuate. It is not only because of chemotherapy, I feel, because I give temozolomide for 5 years minimum in brain tumors, nothing has happened. But in case of NET, because of the systemic radiation, so I think the risk is high. I agree.
But younger patients, that's why I prefer to see the SU values and no FDG uptake, and based on that we can do away with. Even to
Personally, when we see a patient of developing MDS and secondary AMLs, I don't think so we have the confidence to ever give them both together.
Yeah. Yeah, but it is overrated. I have in this big center they have seen 2 myelodysplastic syndrome. They are treating since 10 years. I am treating since.
NET maybe more than 10 years.
Yeah, so they have seen 2 myelodysplastic syndrome. I have practiced since 7 years. At least I haven't seen a myelodysplastic syndrome. That is overrated. And yes, if it is there,
I won't say
MDS because of the
they are surviving.
PRRT. PRRT does not just a thought process.
See, we are giving Captem since 3 years along with PRRT, and only PRRT since 7 years. I haven't seen MDS.
I won't say overrated. Time catches up with
Maybe.
everyone.
younger patients, I don't think it's worth. As
I
such,
think,
any cancer.
I would partly.
But even in the trials, madam, only very few MDS are.
Agreed. But when it
Theoretically
occurs,
speaking.
that one patient,
I think
It's quite low as well.
I mean, the literature says that there's only 1% MDS, but I think in actual reality it is little more than that. We do see it. I mean, I've been practicing this for I don't know how many years, and we do see MDS. We see MDS from other hospitals as well, and probably patients who've received chemotherapy along with systemic therapy, as doctor said, those are the patients who are more at risk for developing MDS. Simple PRRT probably does not cause MDS so much as a combination of alkylating chemotherapy, whether done sequentially or whether done concurrently, they do increase. And as patients live longer, their chances of developing secondary malignancies obviously goes up. Yes.
Just a brief, this is for our nuclear medicine physicians. PRRT in patients with renal functional impairment, how do you proceed? I mean, what do you take as an absolute cutoff of GFR below which you are not going to give lutetium dotatate therapy?
So I suppose this is the most boring of all the questions. Let's debate. We will use the eGFR of 30 ml per minute per body surface area as the cutoff. Creatinine of about 1.7. We have to factor a few things. It's not just about the cutoff of these values. A, patient's comorbidities, age, diabetic status, that comorbidities will include diabetic status, his hypertension.
No, let's keep it simple. GFR, we have elevated creatinine, we have a patient. Would we proceed with PRRT or would we not?
Okay, so a few questions before I answer that is you need to tell me the eGFR of the patient, age of the patient.
That's what I'm asking from you. What is the cutoff level where you would not consider a patient for PRRT, or is there something like there is no cutoff and you can still go ahead with PRRT?
So we use a cutoff of 30 ml as the eGFR. In such a patient where the eGFR is less than 30 ml, there are 2 options. First and foremost, that's not an option, get the nephrologist involved. The second thing is we can opt for dose reduction and then escalate over the next couple of cycles.
Ma'am, what is your experience, ma'am?
Typically PRRT does not cause too much renal dysfunction. We keep a eGFR of about 50 ml as the cutoff. Having said that, in a patient who is already dialysis dependent, this question does not arise because you can continue doing PRRT and continue his dialysis. But in patients who are kind of on the borderline, you have to see the risk-benefit ratio, as to what is the risk of him going into a permanent dialysis dependent state versus a slight derangement of renal function. So as a rule of thumb, we do keep 50 ml as the kind of cutoff, but it may vary.
So 30 to 50 ml is considered, some studies say 30 ml, some studies say 50 ml. The studies which have 30 ml have younger patients with lesser comorbidities. So we have to remember that this is depends on each patient, and we cannot underestimate the fact that we have younger diabetics in India now. So comorbidities actually play a bigger role in how they tolerate and the risk of ending up on a dialysis.
Patients with deranged LFT, how do you tailor the treatment in them?
When you expect a patient with who will go for hepatotoxicity, the pre-treatment scans, the PET-CT scan will definitely show the extent of liver involvement, and in neuroendocrine tumors are known to have big hepatic metastasis, and we'll have to classify the patient once the PET-CT scan is done, depending on the extent of liver involvement, 25%, 25 to 50%, and more than 50%. And also we'll have to go, think of whether we'll go with the intravenous route or the intra-arterial route. Definitely when you're expecting a patient to end up with hepatotoxicity, we don't opt for intra-arterial route, and get a baseline LFT done, RFT and a CBC done. And as you go ahead with the treatment, on the day of treatment, it's very important to maintain good hydration and amino acid infusion. Once this treatment is done, you will have the post-therapy scan that shows us how the uptake is. And for the week thereafter, after this cycle of PRRT, we'll have to ensure good hydration.
Right. So we'll jump to the third case, which is a 46-year-old gentleman with an alcoholic-induced hepatitis and that related CLD, with a Child-Pugh score of 7. 7, the ascites being the score which is critical. Patient has multicentric bilobar HCC with PVTT, and the serum alpha-fetoprotein is 678 nanograms per ml. So, coming to Dr. Uttappa, what are your typical indications of tear, and where would you prefer it over TACE?
So the typical indications for tear, as we are, currently would be, number one would be, in Indian scenario, chemorefractory would definitely be on the top of the list. So they've had, let's say, 1 or 2 TACEs before and they've not responded. So chemorefractory would be one. The second would be depending on the strategy of the local hospital. I think this is very important as to what is the clear indication that you're offering the tear. So if it is to bridge to transplant, then clearly it becomes much about TACE, because there are a lot of trials out there which tell that tear is better than TACE. If the tumor is large and has the portal vein involvement, then again tear would be preferred over TACE. So yeah, one is the strategy of the hospital as to what is the final outcome for the patient.
So as a bridge to transplant, you would prefer TACE rather than tear?
Tear, yeah.
You would prefer tear?
Yeah, yeah.
Okay. And
it's again based on all the evidence and our own experience.
And why would you prefer tear over TACE as a bridge to transplant?
One is that for a large tumor, you would get a tumor kill with one sitting. Mm-hmm. The second thing is that your toxicity profile is far better. Like a post-embolization syndrome in TACE is far higher. Again, depending on the case specific, but in general, those are the two main reasons.
So when we talk about as a bridge to transplant in a patient with PVTT, would you combine it with radiotherapy to the portal vein?
Yeah. Now I think that's the way to go. Again, I think Indian study from Medanta itself is a good one to refer to. But there are other trials which have also shown in terms of sequencing and bridging it. So I think when you got a large tumor for the parenchymal disease, tear works very well. But we've got a PVT, let's say VP3 or VP4 with a large volume. Then I think bridging or combining with radiotherapy would be the way forward.
Sir, would you like
So I'm so happy that Dr. Uttappa didn't had anything to tell about this particular one, because of the PVTT is one of the things we always have the restriction. So here the plan of action makes a lot of difference. If he is an young guy, and we are definitely looking for a transplant in a later date, and we need to still looking in a curative intent. So it should not be put it as nothing can be done. You have a combination. I can do all the three multicentric lesions along with the PVTT with the SBRT alone, versus the combination of TACE was the combination, like the SBRT only to PVTT. So here I prefer to do all the three because easy for me to do. You don't have to combine more than one modality of treatment. And definitely the systemic treatment may be also have a role in this particular case. So this size is not a problem for in HCC for me. PVTT is not an issue, and any of the other thrombus and the other part of it is not a problem.
So between using SBRT and using TARE, where would you use what? What are your clear indications of TARE for this and SBRT for this?
So in
I'm
this
not talking about PVTT, I'm talking about the parenchymal disease. PVTT, I think SBRT works much better than TARE. So
it acts for both.
Yeah.
So now also that you are asking for an evidence, like, see, I prefer where it goes is the one which makes the most of the difference. So in terms of SBRT for that, even if you give a smaller lesion, it will be more accurate, even up to the size of more than 8 to 10 centimeter. SBRT works, and it's even into the like in terms of bridging for the transplant and stand alone. So I don't see any combination of TARE versus RT. No. TACE versus RT is okay for me. Both are radiation.
okay. No, so when we talk about TARE and we combine it with RT for the PVTT, do you think that's a good strategy?
I don't agree with that.
Okay. You want to do SBRT for the
All the three
parenchymal
lesions.
as well as for the...
Yeah, because I prefer single mode of treatment
Okay.
rather than a combination, because both are radiations.
Okay.
So
So what is your contraindication for SBRT? Let me put it. I mean, nowadays we find that there are
no
barely
contraindication
there is
for
no
SBRT.
contraindication.
Patient should be alive, that's the only thing. See, actually, the size limit is not as long as probably the 20% of volume. We told that 80% of volume liver reserve is required. So one lobe, it's actually, Raju is not here for for a change. So the surgeon's criteria of one part of the liver if is healthy is actually enough for me to the regeneration of that compensatory regeneration. So otherwise the size is actually not a contraindication anymore.
Dr. Uttappa, would you like to respond to that?
I think, personal experience, we've had many interactions before. I think if you want to, in an academic forum, there is no good evidence to back up what Sridhar is telling. Because when we want to achieve what you call an ablative dose, which are complemented by, explant studies, yttrium 90 or a TARE of any description has proven, time of TARE. And so if you look at based on guidelines, then you'll obviously look at evidence, then you'll get. So in terms of tumor kill, so what they've shown is that when you have a tumor kill where you can get about 400 grays and above, then you have less chance of a recurrence when you bridge them to transplant, or even if you take them to resection. So I think you have to look at studies for that. But I think it is very much possible to treat large tumors also, as long as you have healthy liver. So finally, it again case specific. You've got enough healthy liver that you can actually do a lot of toxic things to the abnormal part. So it's possible. So I think there's no head-on trial between the two.
So there's a correction here. So you asked for SBRT size criteria versus the transplantable case. So the patients who are looking for a transplant, that's what the roadmap is very important. So the question is actually in this particular patient, standalone or one mode of treatment is my first choice. In terms of size criteria for a transplant to be done, if the size is big, we don't do the transplant. So in case of HCC, like overall program, if you see, we are in the actually 40 to 60% of the cases. Actually, even if it is localized or bridge to transplant, or even in the size of the criteria is more, even in a metastatic and oligometastatic, it can be used. Even in a recurrence or a residual lesions after the systemic treatment can be used. I am talking about the SBRT, the size criteria, where we are not looking for a transplantable patients. The size is not as long as the LD liver is able to regenerate. That's what I meant.
The nuclear medicine people, would you use FDG PET CT for a risk stratification of HCC?
Yes.
You would?
Yes.
So how would you use that?
For prognostication, more than anything else, prognostication. The higher the FDG, the poorer the prognosis and the overall survival in comparison to the non-FDG avid tumors.
So would that change your management in any way?
No.
No. Okay.
So in the contrary, actually, you people doesn't promote FDG PET scan for HCC. So even in our study of more than 200 patients for radiotherapy planning, I've always done the FDG. More than 90%. Dr. Kallur doesn't agree with that. That's what they say. People say. But 90% of the time, the FDG uptake is there, and it is to be used as a prognostic marker. So I prefer FDG PET scan. Now anyway, glypican scan is already
So
there.
would you boost the area which is?
I
showing
treat
FDG?
only that area.
You treat only that area.
Yeah. So I SBRT only to that area.
This is a very important question because at least for people who are dealing with HCC, because we have had a shift even from all the meetings we've attended, and at least what I've attended in India, there was a time when we would say only focus on the livers, do a triple phase CT or an MR, and then you would make a decision. But I think risk stratification for HCC, I think FDG PET should become probably mandatory because not only in terms of prognostication, well, partly prognosis, but actually for patient selection also. So the entity will need this more and more because extrahepatic disease clearly shifts the focus in how do you, give the end result to that particular patient.
So, of course, as somebody mentioned, we now have glypican, which of course is still a experimental and a trial molecule, but it does show up the HCC. About 85-90% patients of HCC will express the GPC3 receptors, and you get some really spectacular images with glypican. I think Dharminder has been with me as part of the trial with glypican, so if you can.
Yes, I think we have performed around 20 patients with both comparison with the FDG as well as the glypican, and glypican scan has performed consistently well above the FDG. In case of FDG PET, it shows the variable uptake depending on the tumor heterogeneity and the differentiation status. But GPC is performing quite well, and apart from that, we are able to localize the additional lesion. In 20 patients, the number of lesion localized are more in case of glypican scan as compared to the FDG. And the interesting thing we observed with glypican was that we are able to differentiate the tumor thrombus, the portal vein thrombus or the bland thrombus, because the GPC3 show uptake in the tumor thrombus while it was not seen in the bland thrombus, while FDG PET was showing both uptake in the both. So it's a new kid in the block with the number of data, number of patients. Definitely GPC3 is here to stay, and I think it can be specific as like a PSMA scan for the prostate cancer in future. And this data will be presenting in the ESCO 2024. We are looking forward to it.
Just a question for you. How easy to procure it, and is there a cost implication? Is it quite straightforward?
It's not straightforward. It's only the trial basis. We have the agreement with the company, and we are getting the supply limited
So it
to
is
the
still a trial,
multi-centric study basis.
but I think it'll come into the market in a period of time.
Yeah, they are the
No, they
three
are also part of a trial only, same
part
trial.
of the SAG
It's the
also
same
a part
trial.
of the
They are
trial.
Dr. Kallur's center and.
AIMS, SAG, and the Fortis. We are.
So I think quickly, since since we are running out of time, ma'am, immunotherapy, we hear of atezolizumab, bevacizumab in every patient versus the liver-directed therapy. Or is it a combination of both?
So immunotherapy, it depends on what is the type of patient that we are seeing. If the patient has chronic liver disease, varices, then the varices should be controlled before we go on with the immunotherapy duo combination. Because the combination consists of bevacizumab and atezolizumab. Bevacizumab is contraindicated when there is an active variceal bleed. So we have to select our patients, and targeted therapy is most of the times with lenvatinib now as compared to sorafenib, which was used earlier.
No, I'm talking about in a patient with locally advanced hepatocellular carcinoma, would you consider liver-directed therapy or would you consider immunotherapy? And what would be the factors which would push you on either side.
So, are you considering transplant at a later date?
No, we are
Are
talking
you
about-
considering surgery at a later date? If no, if none of these local therapies are planned, then I would go with immunotherapy first.
Close. Yeah, so there's a lot of trials on using immunotherapy, in fact, using radiation in whatever form, whether it is SBRT or TARE, as a, as an adjunct to immunotherapy. So time will tell where these strategies fit into the management of HCC. So are we out of time now? Okay. All right. So I think, thank you panelists. It was really wonderful having you all. And thank you audience also for being part of this journey of theranostics. So I think with time, theranostics is slowly creeping into the mainstream oncology, and we'll see more applications of it as we go along. Thank you so much. Thank you. Thanks, Gaurav.
So thank you so much to all the panelists for this really exciting discussion early in the morning on a Sunday. So now we move on to the second session of the day. That is the oncopathology session. The session director is Dr. Kunal Sharma. Dr. Kunal Sharma is the associate director and head of the lab of Center of Excellence. So let me introduce my session director.
So I would just expect everybody now to kindly settle down. We are running a little, late already. So over to Dr. Suneet now.
So I think a lot of excitement in the hall. The session director for the Oncopath session is Dr. Kunal Sharma. Dr. Kunal Sharma is Associate Director and Head of the Histopathology Services and Center of Excellence Lab, Agilus Diagnostic Labs in Mumbai. He also leads our digital and AI division of histopathology for Agilus Labs. So I will just request Dr. Kunal to please give a short introduction for the session. Dr. Kunal, please.
So first of all, I think apologies to all those who have been eagerly waiting for this session. There are things which are not entirely in our control, and we should, we can sometimes have room for variables. With that, I would like to extend a very heartful warm welcome to all of you who have come here and been a part of the Fortis Cancer Summit. We have really tried hard to make sure that all domains of oncology, including oncopathology, get their due. And we have some really fantastic scientific sessions lined ahead, and speakers would be whom we all know, national and international experts in their respective domains. We all know that we've moved far ahead from the era of broad spectrum chemotherapy into an era of targeted treatment and immunotherapy, which is very heavily dependent upon the diagnosis that we make and the genetic makeup of the cancer that we provide to our oncologists. So we are, we are at the center and we are at the pivot of hardcore absolute bedside oncology management. I often like to say that we are no less than the chefs who prepare the sumptuous meal, who probably never get in touch with the people who visit the restaurant, but you can never undermine what we bring to the table. So I think with that, I would hand over to Dr. Suneet, who heads our labs very ably in South, for the progress of the session. Thank you, Dr. Suneet.
Thank you so much, Dr. Kunal. So we begin with the first session speaker in the morning. So there's no need for me to introduce him. Dr. Rajendra Singh is a co-founder of Path Presenter, a very eminent personality in the field of AI and digital pathology. He works with the Summit Health as Director of Dermatopathology and Digital Pathology. He has served as the chair of American Society of Dermatopathology. There are numerous apps and AI platforms which are credited to him. So I would request Dr. Rajendra Prasad to please come on the dais. The topic for today on which he's going to speak is evolution of AI in healthcare. The session will be chaired by Dr. Kunal and myself. To just give a short introduction, I head the Agilus Labs for the South in Bangalore. And over to you, Dr. Rajendra Prasad, to start the session.
Thank you very much for the introduction, and thank you, Kunal and Dr. Suneet, for the warm welcome, and thank you to everybody at Fortis for the incredible hospitality that we have given, that has been given for all the faculty within the system. So let's try this in a better way. So today I'm going to talk about evolution of AI in healthcare. It's a topic that could take an entire day, so we'll try to see how much we can cover in 30 minutes. So as a disclosure, it has already been mentioned that I'm the founder of Path Presenter, but we are not going to talk about Path Presenter today. So to artificial intelligence, so we all are in the phase where now pathology is moving from analog to digital pathology. Every institution around the country, every organization around the country either is in the process of moving or at least in the they are planning how to move from analog to digital pathology. And we have gone through a lot of these meetings where they have talked about all the advantages of digital pathology, like the ability to sign remotely. I can easily show a case to anybody around the world. I can easily pull out previous cases. There's a lot of streamlined workflows that come with digital pathology. And I can easily communicate with the clinicians. So a lot of big advantages that are very obvious when you start using digital pathology. And obviously, as Kunal was talking, we are the people that provide the diagnosis, but pathology has never received the benefits of being the main people about providing the diagnosis, and maybe digital pathology is going to provide that respect to the pathology field, that they are actually the big people that provide the diagnosis. Because now with digital pathology, you're not only providing diagnosis, you can also help the clinician in prognostication, in deciding the treatment, in deciding whether the companion diagnostic drugs will work or not. So definitely there is a big role that now pathology will start playing even more in patient care, and that is going to happen with digital pathology. But just because we are going to move from analog to digital pathology doesn't mean that things are going to change. The main reason things are going to change because of artificial intelligence. We can now implement artificial intelligence when we move to digital pathology. Not just signing out cases, digital is going to make the difference. So it is the importance of the artificial intelligence use that is going to bring the transformation that pathology is currently seeing all around the world. So now that gives us an introduction to why we are talking about artificial intelligence. So when I think about artificial intelligence and machine learning, like I try to think of what will artificial intelligence do to my work basically. So there are multiple different ways. It will help increase the accuracy definitely, bring in more efficiencies into my workflow. And then there is a lot of things that we would not be able to do with glass slides, but we can do with digital slides, because a lot of things can be done, molecular, you can predict molecular changes, you can predict the PDL1 status, and a lot of new things can be done using digital pathology that was not possible with the glass slides. So when you talk about accuracy, we'll talk about a couple of AI tools that are already available to increase the accuracy. Like if you look at, there are multiple papers and now even AI tools that you can easily take a lymph node and it can predict which area of the lymph node has the metastasis. And you can like overlay heat maps on it. So these are already available tools that actually are being used in multiple institutions right now. Not only detection, but also like there are tools that can actually help you now classify what kind of metastasis this is, even without doing the immunohistochemistry. So rather than like throwing in a bunch of 10 or 20 or 30 immunohistochemistry at lesions, you could use this artificial intelligence tool to at least give you some kind of a differential diagnosis, and then you only use those IHCs basically. So definitely saving you a lot of time, money, and energy. During a frozen section, many times you spend so much time on finding a micrometastasis. There are now tools that can easily like point out the micrometastasis, and then you just zoom into that area and you can look at the tool. Therefore, it will decrease the turnaround time that you are going to use for frozen sections. Efficiencies is a big thing when you talk about digital pathology. And why efficiencies? Because it brings in automation. Like you know how much time you spend wasting trying to find a mitosis, or trying to find the AFB organism, or trying to find the fungal organism. And because there are already tools that can do this using AI, then it becomes much easy. So multiple tools for finding mitosis in breast cancer. They were already talking about the neuroendocrine tumors which need the Ki67. All that can easily be done with the AI right now. AFB detection, how much time do we spend on looking at a slide? Like 10 minutes, 15 minutes actually. Fungus detection, so like I do around 150, 200 derm path biopsies every day. Out of that, around 10% of my work is looking at nails. If they are positive, it is like a 5-second diagnosis. But if they are negative, I have to spend 5 to 10 to 50 minutes on looking at the nail, making sure it's negative actually. With the tool, it's so much easier. Like it can tell me like which is positive, which is negative, and if it is positive, which areas is positive basically. Increasing efficiencies also comes through by making sure that patient safety is taken care of basically. Like it is always a law of numbers. You're looking at 10,000 cases every month or every year basically, and you are going to miss some cases. But if you're already using an AI, it will help you make sure that you don't, at least the level of miss is a little low, because it will help make sure that if there is a micrometastasis or if there is a small focus of tumor, it can actually point out to that focus, and you'll be able to go back and look at that area and make sure that you don't miss that focus basically. There are a lot of tools that are coming now which can actually prioritize your cases on your dashboard. So rather than just getting all your cases randomly, it could actually put the suspicious cases on the top. It might be negative even after when you look at it, but at least if the suspicious cases are on the top and in the morning you come and look at those cases, first you can then order all your immunostains, you can order all the ancillary studies, so that the report is going to come out much faster, rather than you looking at that case in the evening and saying, oh, this is a difficult case, I'll look at it tomorrow basically. And then when we talk about discovery, we have seen a lot of papers that are already like being published where you are using digital pathology to actually predict the underlying molecular changes, to predict the PDL1 status, and a lot of different things that they can just predict from the digital slide. There are also now multiple papers and tools that can actually also help predict the prediction of the disease actually. So in this one, they took a lot of RCC cases and they were able to predict like which are the high risk cases and which are the low risk cases. And they were even also able to point out which areas corresponded to the high risk actually. So you might find insights from using that, like which are the areas that you need to focus on in the next case that could be actually related to a high risk RCC case basically. So there are so many AI companies right now that you could go back and look at all of them and see which one do you want to use. And we are working with most of them to like see how we can bring them into the real world actually. So that's what is already available in the market today actually. So if you go back and you look at all these companies, you have these tools that are available today. But then suddenly things have completely changed in the last 2 years. We have seen like all these previous AI modules that you saw right now and all the AI modules produced by these companies, they were all based on convolution neural networks. And they were either using labeled data that the pathologist has labeled, or they were using weakly supervised learning where they took a whole slide image collection and then threw it at the CNNs, and they were able to predict all these things that we were already doing. But now, in the last 2 or 3 years, this generative AI has come, which is now it's a complete new way of looking at AI, basically. So many times I think of all the AI that we talked about recently, soon becoming AI 1.0, and now you're going to see a complete new set of tools that are going to be AI 2.0 actually. And so generative AI is able to not only generate text, new text, but also look at images, also look at radiology images, pathology images, create video, speech, code, everything basically. And it's not only like pathology, like every part of our society is being affected by generative AI right now. You see that happening all around the world. And healthcare and pathology are not immune to it. They are also being affected in a big way. So it all started with the large language models that we saw coming at a rapid pace from almost one every month actually. And the large language models were initially built to predict the next word, but now you can do text generation, you can do translation, you can do even summarization of the entire books and entire articles just using ChatGPT basically. And the excitement was very obvious because when ChatGPT got released, like it took just 5 days for ChatGPT to reach 1 million users. Compared to that, Facebook was 300 days and TikTok was around 2 months basically. So all this actually started off with in 2017 when Google came out with this paper, which is Attention is All You Need, where they introduced the transformer model, which is which is still a deep neural network, but it is very different from the convolution neural networks that were being used previously. So how are they different is because they can now scale up massively. And rather than looking at data sequentially, they look at data in parallel. So they can look at huge data, like massive amounts of data. And that is the whole strength, like using a large scale GPU centers and massive amount of data that allows these models to come up in a much better and a faster way. And then in 2021, the other paper that came out of Google, which is an image is worth 16 by 16 words and transformers for image recognition at scale, which was using that same transformer model that was being used for textual data to now be applied to image data. And so now they could actually use large amounts of images to be applied to transformer model and then see what kind of predictions can be done from images actually. And that is where the whole effect in pathology is going to come. Not from the large language models that definitely are affecting pathology in a big way, but this is where the vision transformers, because now they can actually look at images. That is where the whole effect of AI is going to come in pathology. And we know like what can these models do, like we can give it a question and it would then definitely give you a short answer. It like in Google, when you put in a question, you get like pages and pages and pages of data, and then you have to go through that data to realize which one is relevant to what you are trying to look for. But this one, they at least give you some kind of specific answer. It might be wrong, completely wrong, but at least it is giving you some kind of specific answer. And so right now, if you take the most recent ChatGPT, which is 4 or 4.5, and you put in a medical question, like in this one, we tried to put in what is the difference in the ICC and the WHO criteria for myelin neoplasms. It will give you an answer right now, but because this has been trained on a lot of internet data and has not been trained on medical data, the answer is not very accurate and sometimes even gibberish actually. But these things are rapidly improving. But now there are multiple institutions in the US. There is a lot of work being done out of Stanford, a lot of work being done out of Brigham, where they are actually taking these as base models, that ChatGPT, the Llama models as base models, and then now taking their own data from their institution and building now customized chatbots for pathology. And that is going to affect the field in a big way actually. And we are already working with a lot of these institutions to see if we can bring this chat into the viewer when you're actually signing out the case. So this was a hematology chart that was built by Dr. Rashidi. He works out of Cleveland Clinic. So they took that same model, ChatGPT 4.5, and then applied Cleveland Clinic data into the system. And now when they put in the same question, it actually gave a very, very specific answer. And it not only gives you a very specific answer, it also gives you the references from where it pulled the answer actually. So it's not just, so you can actually go back to that reference and then look at the reference so that you know that the answer that is coming out is quite accurate basically. So that, and we are now working with Harvard to create a derm path, because I'm a dermatopathologist, we are creating a derm path model. There is a hematology chart model. So there are multiple chart models that are currently coming up that will actually give you very specific and accurate answers for any medical question. And then obviously with the vision transformers, there is a lot of image analysis that is happening on with vision transformers, where you can actually, in this example where they use the chat GPT, they put in an image, this is a frozen section histology slide, can you tell me what type of tissue it is actually? It will give you what kind of tissue it is, but not very, very specific answers. But now, if you go and look at this patch chart that was just released around 2 weeks ago from out of, so this is a colleague of mine, Faisal Mahmood. He works out of Brigham. He just used a lot of Harvard data to build this patch chart model. And this is very, very accurate, where they put, they can take any images. They took this image of a lesion from the finger, and they put it in the patch chart, and they asked the question, like, what are the features on this slide? It gives a very accurate description that there is hypergranulosis and all the features on the slide. And then, okay. So there is a, let me play this. So this is an entire video for some reason. Let me play it here. So it will then if you give it more relevant clinical information, it can actually give you differential diagnosis. And then it will also tell you, like, what are the other additional information do you need to come to a more specific diagnosis. So all that can be actually asked. You can just put in questions into the patch chat, and it will give you very, very specific answers. You can go and look at this. It is already available online actually. And this was based, these are the papers that they published, how they produced patch chart. So initially they only took they took a lot of histopathology images. So these were not whole slide images. They took 1.17 million histopathology images collected from PubMed and textbooks, and they used that to train the model. After that, they actually took around 100,000 whole slide images, and then they took patches from those whole slide images. And then using the information from Harvard, they actually then went ahead and trained the path chat module actually. Similar work was done out of Stanford, where they actually went on Twitter. They took around 200,000 images from Twitter along with the captions. And then they build a model that can actually predict, if you give it an image, it will actually create a caption for it. Like, it will describe the image and produce a caption for it. This is another paper that just came around 6 months ago. And then the most recent one came out of Page and Microsoft, where they actually took more than 100,000 whole slide images from Sloan data, and then they created this model which is called Virtuo. This is only a month old actually. And when they used this model, it could actually predict what kind of cancer is within the slide, and also it could also predict the biomarkers that are associated with that cancer. So like in the study, they were actually able to predict the MSI, the FGFR, and the EGFR in the lung cancer, just based on the histology image basically. So all these models are now coming up. This is all in the last 3 to 6 months. So you can, like, in the next 2 years, you can see the explosion that is going to happen with all this kind of models that are happening in pathology. So when you see all this, you suddenly say, am I going to lose my job? Or what is going to happen basically? So then there's a time for a break basically. So just for case of humor, why did the pathologist bring a ladder to work actually? To finally reach a diagnosis. Yep. So we talked about what is already being done. Like, you saw the initial AI modules that are already available in the market, and the new work that is already being published and being showcased in multiple meetings right now. But in these we are already integrating, so you can go to multiple viewers and you can actually see almost like an app store coming up and on the viewer, where you can then go and pick up which AI module you want to use basically. And these chat modules are also being integrated into pathology. But then there is a lot of new things happening that are very, very applicable to like what we are currently doing in our world. So we educate, we train people, we do a lot of research, and we are signing out cases. So what are now researchers thinking about dreaming up in pathology for us basically? So the 4 main things that I see happening at a very rapid pace that is going to come to a new lab very close to you is synthetic data, virtual staining, 3D pathology, and integrated large language models. And each of this I could like talk for an hour basically. So we don't have that much time, so we will just 2 or 3 slides for each of that, and then we'll close basically. So when you talk about synthetic data, we have all seen these images. Like we see images of all these Bollywood people and all Hollywood people like being deep-faked and then producing all kinds of images that are now being published on social media. And these are not true images that have been actually taken with the camera. They are like synthetic data that has been created using some kind of original images of these Bollywood actors. So this is being used in a negative way, but the same kind of applications are now also being used in a positive way by creating synthetic data actually. So what is synthetic data? What they do is they will take a lot of real data and then they are applying artificial intelligence and these models to actually create data that is very, very similar to the real data but doesn't come from a patient. So you can actually now not have to go through a lot of regulatory loopholes to actually use this kind of data, because it mimics the property of real data, and if you want to train or validate an AI module, you can then use this synthetic data actually. So there are at least 50 different companies that have produced modules that can be used to create synthetic data from real data. So it is a very useful tool, because as researchers, many times you have a great idea and then you know that you need a lot of data. And then when you want to a lot of data, even from your own institution, like you have to go through an IRB protocol, you have to go through so many regulatory pathways, and in the end, many times you are not able to get the data. So if you have the ability to create synthetic data from your already existing real data, then you can actually even start your project off. It doesn't slow you down, and then when the IRB ultimately gives you the approval, then you can then take that model that you have created with synthetic data and then apply it to the real data basically. And there are multiple papers that show you that synthetic data is now very good, whether it is clinical images, whether it is radiology images, whether it is pathology images. There's a lot of modules that can help you generate synthetic data actually. And this is a study that came out of Gartner, which is a very reputed people that produce all this kind of data, that by 2030 synthetic data will completely overshadow real data in AI modules. So it is really happening all across the world. The other new thing is the 3D pathology. So in 3D pathology, you can actually take a block, and then the block can entirely be scanned and actually produce a histological image of the entire block. And this technology is also now coming up at a very rapid pace. So you can see, like, this is the prostate block, and you can actually see the entire glandular lesion throughout the block. So like many times when you're struggling with whether it is a 3+4 or a 4+4, this can actually be a much better way to look at the tissue, so that you actually give a very accurate prediction of the Gleason score. And just to give you another example of where 3D pathology is like really affecting, where you're trying to look for very small things, like in Hirschsprung disease, you want to look for just ganglions. And any pediatric pathologist knows that they have to go through like 70, 80 slides to actually make sure that there is no ganglion actually. But now with 3D pathology, you can actually scan the entire block, and the entire block will then look at the entire, all the sections in the block, and then say whether there is any ganglion or not basically. So you don't have to go through 70, 80 slides and then say there is no ganglion, because this technology will allow you to do that very easily basically. The next technology that we are going to talk about is virtual staining. So in virtual staining, what they do is they're taking the slide that has not been stained. So you just cut the slide from the block, you digitize the slide, and then you apply artificial intelligence to actually produce an H&E image. You don't have to go through the entire staining process to produce the H&E image. And so you can see like how much time can be saved to actually produce an H&E image. But not only H&E image, you can also take an H&E image and then produce another immunoslide from it. So let's say I want a MELAN-A, I want a PAS, I want a GMS. With just one click of a button, the artificial intelligence will take that H&E image and convert it into another slide basically. So you don't have to wait for hours and hours to, like, you have a difficult case, you do some immunos, and then you realize that I'll need more immunos. So then you send another order to the lab. And sometimes weeks can go by because you have to do 2 or 3 sets of immunos to finally come to a diagnosis. But now with virtual staining, with just one click, you just have an H&E slide, or you have an unstained slide, you produce an H&E image. I need a MELAN-A, I need a SOX10, just with clicks of buttons, you're going to get all your virtual staining. So within minutes, you can complete, you can see all the stains that you need to see for that case basically. So very, very useful for kidney biopsies and for liver biopsies, because for the kidney pathologist in the room, like how many times they have cut and then the glomeruli is gone basically. And you don't see the glomeruli anymore, so you can't get the stains. Like you need multiple stains, you need the silver stain, you need the GMS and all that, which becomes difficult because the glomeruli is already gone basically. But with virtual staining now that becomes much easier, because now you're just going to use artificial intelligence to stain the unstained digital slide. And then the last thing is, like, we are already like now trying to work with virtual reality companies to create customized teaching material. So like you could have a room full of residents, somebody would be first year, somebody would be a second year, somebody would be a fourth year, and there might be fellows or junior pathologists. All of them would be looking at the same case, but then with virtual reality you could customize using large language models the question that they can ask basically. So they might be sitting in the same room, but with virtual reality and application of large language models, you could actually create customized teaching material for the entire residents that you have in your department actually. So this is also coming up very quickly, where you can just go in and then wear the headset, and then you can actually go in and look at the slide, and then there's a button that we are adding to the virtual reality that says chat, and then you can ask questions based on your level of learning basically. So computational pathology is definitely coming in a big way. Artificial intelligence is coming in a big way. And the study that was done before the large language models were introduced, this was done around a year ago, when all this technology that I just showed you wasn't there actually, because what I've shown you is just the work in the last 1 year basically. So in this paper, they looked at a lot, if you look at there are at least 15 or 20 institutions around the world that like what is the effect of artificial intelligence and by 2030. And they strongly agreed that diagnostic accuracy will increase, the diagnosis and grading of tumors will be more standardized, the detection of rare events. So we know all that is going to happen, but now with the new technology, this paper also becomes a little bit old basically, because now everything is changing at a very rapid pace actually. So as pathologists, what is the way forward for us basically? Like I keep telling every resident, every pathologist that the only way is lead. Don't follow, or you'll be asked to get out of the way. So you have to lead this revolution in pathology or healthcare that is happening, be part of it and be ahead of the curve. Otherwise you're just going to be asked to get out of the way. If you do this, it's not going to work out anymore. You cannot be like, I don't want to talk about AI, I don't want to hear about AI. It is not going to work. You cannot put your head in the sand, because it is coming and there is no way out of it, and you have to get used to it and lead the way of using artificial intelligence in making you a better pathologist. Because till now you were a diagnostician, you were making a diagnosis. That was about it basically. But now you are going to become more information managers and integrators basically. Because think about it, you are actually sitting on all the data. It's not the clinician who is sitting on all the data. You have the pathology data, you have the molecular data, you have the lab data. And this is all actionable data. So if you take control of this data and say, I'm going to run this whole show basically, then what you're going to become is, you are going to be the one who's going to do the multimodal diagnosis and reporting that can help the clinician in a big way actually. But if you let them take charge and let them take charge of all the data, then you are going to be asked to get out of the way. So the only way to like really make sure that all this doesn't affect your careers and the field of pathology is to take charge and make sure that you are leading the way in implementing this technology in the way that it is going to be pathology as the centerpiece of personalized medicine. And I put this question into ChatGPT, what is the future of pathologist? And this is a long answer it gave, but if you look at the last thing in the summary, it says the same thing actually. In summary, while technology will continue to transform the field of pathology, the expertise of pathology in disease diagnosis and interpretation will remain indispensable. So you have to like, if you and the pathologist's role will evolve to incorporate new technologies and interdisciplinary collaboration, ultimately contributing to improved patient care, early disease detection and better treatment outcomes. So you have to really take charge and make sure that you know what is happening and how this thing is affecting the field of pathology. Thank you very much.
Sure, sir.
Sir, a very nice presentation. In fact, I had been interested in artificial intelligence for quite a few years, and I have made few presentations as well. Now, there are 2-3 things which I am actually finding the answer. One is the ethical issues that is, considered very important as far as AI is concerned. Suppose a lawsuit happens, who's responsible? Good. So your last line explains that. Number two, what I feel is whatever developments have been happened in AI is basically integration of reading and visual scripts. Of course, the picture reading skills of the AI have gone leaps and bounds. Now, pathology, dermatology, definitely a very complex branch. I just have one question which I've been asking. In medical field, there is so much of variability, and that is where our experience works. There is just one branch where, the variability is, I would say, limited, though there is too many, that is ECG reading.
So there are already multiple AI companies that have produced.
But we haven't got anything yet which can actually tell something. So any comments on that?
Like that is when you look at papers that are being produced by Google or Facebook or Amazon, all these, they always talk about replacing the clinician, replacing the radiologist, replacing the pathologist. But that is because they don't understand the depth of the field. Like when I look at cases, I'm looking at a melanoma, at like 5 or 7 melanomas a week. None of them look similar actually. And that depth of understanding about the disease, for them, if you say breast cancer, that's just one breast cancer. But like for a breast pathologist, it is their entire career. They train for 2 years as a fellowship, and in spite of that, after that, they still are not completely aware of everything that happens just in breast pathology. So the depth of the field is so much that the AI can never cover everything. It can cover very specific areas, like it can tell you like where is the tumor. But even like the models that have been approved by the FDA, they still are only 80 to 90% accurate. There are many cases of prostatic cancer that they miss actually. So you have to take that with a grain of salt, that people might say all this, but it is never going to happen, at least for the next 20 to 30 years. Later on, who knows basically. But at least for the next 20 to 30 years, this is not going to happen. You will still have to be completely in charge of how the AI is working, because you will be responsible of whatever the AI is doing basically.
Yeah, brilliant talk, sir, where computational science, actuarial science meets healthcare. One question which I asked Dr. Amin also yesterday. You're talking about virtual interpretation. What about virtual tissue? If you use confocal microscopy, for example, a virtual frozen, what would be the accuracy? Because then you don't need tissue.
Yeah, okay.
You don't need, because the transmission is going to be instantaneous. Where do you see confocal microscopy? That's question one. As a virtual frozen section, because you can take multiple areas, interpretation. And the second question is, where do you see no biopsy? For example, AI model using, for example, in prostate, you use MR, multiparametric MR, you use PSMA PET, and then you integrate it, and you have a reasonable accurate, based on computational analysis, that this is cancer, and this is possibly this lesion. So, two questions. One, virtual biopsy. Second, no biopsy. Where do you think it will take us?
Yes, so for confocal, it's a very good technology, but there are a lot of limitations with confocal. One, it can only look up, if you are looking at the skin, then it can only go up to the superficial dermis. If you're looking at an endoscopic confocal, basically, it only looks at the superficial layers, basically. So, one, that the depth of vision is not very good. Secondly, it is only good for very specific lesions, basically, like for a melanoma in situ versus actinic keratosis. But I just finished a book in dermatopathology. There are 1,059 diagnoses in that book, basically. So for very specific diagnosis, yes, it is good.
Robot enabled.
Yeah, it's good, but not but what if it is not that diagnosis, basically? That is the big question. If you already say that this is a melanoma in situ, then it is okay. Then for that case, it might be good, basically. But if there is an associated lesion, if there's something else going on, then that confocal is not going to tell you that, basically. And that is where I think the limitation is. So it is just good accessory tool to help you decide, oh, this patient is a pregnant patient, or this is an older patient, or this is a young child with a lesion just around the eyelid. I don't want to do a biopsy. In those cases, it can be a useful tool, basically, but not in every case, basically. And the second question was about no biopsy. Again, if you are a patient, or if I am a patient, basically, at this point, the confidence is not there where we can use this technologies to say, I don't want a biopsy. For certain diseases, yes, again, it is very, very limited. For certain diseases, it can be useful, but given the complexity and the amount of diagnosis and all the different things that can happen in every organ system, it is very difficult for these things to catch up on everything, basically. digital pathology definitely is, because you can definitely put a lot of small cost scanners in multiple places, then they can scan a slide, and then they can, let's say it's a difficult case and they want to show it to Dr. Amin, he's sitting in the US. It's very easy with just one click to get his opinion, even if he's sitting like very far away. So digital pathology is definitely yes. If we talk about artificial intelligence, again, it could be good for a screening tool, like cervical cytology, it could be good for a screening tool, but not for every diagnosis again. Very specific conditions, it's very good, but not for every condition.
And is it also mature enough for a hematological malignancies? Because whichever AI tools which till now we have used, or the scanners which we have used, the resolution to pick up platelets and dysplasias are not that good. People do claim about hematology and hematopathology.
Right now, the scanners are not that best for, like there is a couple of scanners that have come out of Israel, Scopius is one, that are pretty good for hempath. But the rest of the scanners, the maximum they can scan very well is up to 40x.
Yes.
When you start going to 100x, the quality is not that basically. Cellavision is coming out of them.
Yeah, so 100x is all three scanners which are present in India right now. The 100x is the Cellavision is the best, but Morphel and Sigtable.
Coming up with a new one which is even better actually.
Yeah, thank you.
No, it is using artificial. So what they are doing is they are taking a lot of already stained tissue, and then using artificial intelligence to train that stained tissue, train that model. So in the next one, the model is actually looking at the cellular contents of the cell, and based on that, then they are coloring the tissue basically.
Very nice presentation. I come all the way from your neighborhood in Houston to listen to your talk. I also take offense to the fact that they say clinicians do want to be at the cutting edge. So, for example, as you know, we do work on the lymphoma histopathology pipelines. So, question for you is not about these things. It's all about data. I think one of the biggest problems in the US, and may not be a problem in India, is the sharing of information. How do you think we should work together to overcome this and create a federated structure so it's easy for us to work? Because you need a large amount of data.
Yeah, so that has always been the bottleneck of doing research. But there are so many now de-identification tools available, and they are becoming better and better, that will allow you to easily share the data when you want to share it basically. But again, the regulatory loopholes are always an issue. But we are starting to find better and better de-identification tools coming up. Like people will say you can easily de-identify radiology image. It is not that easy, because there are people that can hack that radiology image and find some information that can go back to the patient actually. So both fields are working very diligently. One, like how do you hack this, and the other one is how do you make sure that the PHI can be. But there are tools now available that can make it better.
So I think, sir, that was a very interesting and intriguing talk, and I'm pretty sure that questions are not going to end today. So maybe, we will continue to stay in touch with Rajendra sir. And I think myself, Dr. Amin and sir were sitting yesterday, and we were just discussing, how digital pathology is going to play a role, and, what is going to be the state of pathologists. So as we concluded that it's more like, an autopilot when you're flying, when a flight is flying. So it doesn't mean that you don't need pilots anymore. It's just going to make your life easier. And the more you're able to know it, the better you're able to command it, the more superior you will be in your domain. So as he rightly said, that it's time for us to lead, not just in digital pathology, but in all domains of oncology as well. So thank you. And I think Dr. Suneet would also like to say a few words.
Thank you very much.
So Dr. Rajendra, it was really a very interesting talk. And as AI is maturing in all fields of healthcare, so I think this is the way forward, what I understood. And myself also, I've been dealing with digital pathology for a long time, but with the coming of AI into it, and it's become more of precision and efficiency, as you were speaking. And I think I think the future will be more of AI-based algorithms to understand the recurrence of disease, the disease potential, and I think with so much of data and images which we have in the field of pathology, I think that is going to really predict the outcome of most of the diseases, and that is where we are going to make the major difference for a clinician.
I would just like to add, I think since we have been the first lab to adopt Path Presenter, and I think what I would just like to share with everyone is that We have multiple international locations through which we do digital pathology reporting, and Dr. Suneet does a lot of that work that comes to us from the Gulf, because she is a certified pathologist there as well. So this has really changed our way of seeing things. It has become a whole scalable business model where we just put a single slide scanner in countries where our licenses are acceptable, and it can really change your turnaround times and how you look at things, and probably even data archival and building up of your AI models. Thank you, sir. Thank you so much.
With this, we move on to the next session of Precision Pathology for Precision Oncology. The speaker is none other than Dr. Sangeeta Desai, Professor and Histopathology Head for TMH Mumbai. And the chairperson for the session is Dr. Lata Kini. Dr. Lata Kini is from Core Diagnosis. She is the co-founder, and she comes with more than 27 years of experience in the field of pathology. Dr. Sangeeta.
Wish you all a very good morning, and let me first refer to two comments in the previous session. First of all, pathology is certainly not in shambles in this country, but the gentleman made this and left the room. And the second thing is, gentleman who was sitting here, about frozen section. So there is a technology where you do optical sectioning, so you avoid use of cryostat. So optical sectioning using confocal and then virtual staining, and use of fluorescence staining. So all that is there, still investigational. And let me now start with precision pathology for precision oncology. And the basic principle is every person is unique, and so is every cancer. So treatment is specifically designed and targeted to the unique form of cancer. So basically, precision medicine is a form of medicine that uses information about a person's own genes or proteins to prevent, diagnose, or treat disease. And the story started way back in the year 1990 when Human Genome Project was it was undertaken, and it was a very interesting and exciting voyage of scientific discovery of basically unraveling secrets of human genome. And this was finally accomplished in 2003. And this particular effort, humongous effort, actually led to various discoveries, and the technology which we are enjoying now, that is basically the result of Human Genome Project. And this was followed by the Cancer Genome Atlas, that is TCGA, where around 20,000 cancer specimens, samples, and matched controls, they were analyzed, again unraveling cancer genome, and all that data is available in the available for use, publicly available. And then of course this was followed by in the year 2015 Precision Medicine Initiative, actually launched by President Obama. So this was on 30th Jan 2015. So in next 2 days we'll be celebrating anniversary of this PMI or Precision Medicine Initiative. So all this has led to a huge burgeoning field of, very interesting field of precision medicine. And so the basic concept is there is a cancer cell with various molecular alterations, then you analyze the genome, and then there is a, depending upon actionability of the gene, there is a matching, if there is a matching drug available, then use that drug for a patient's benefit. And but this doesn't mean that all precision medicine initiatives require genomics. In the current era, it's like digital path is whole slide imaging. So similarly, precision medicine, now you feel it is all about genomics, but no. Way back, we started with ER/PR, HER2. Those were also targets. So that this was basically use of immunohistochemistry to highlight proteins. And so similarly, gene arrangements, amplifications, So you're basically interrogating DNA or interrogating RNA or interrogating protein and getting that specific information. All this amounts to precision medicine. So let's move forward. So again, 1984, that was the year when HER2 was discovered. And by 87, we realized that HER2 was associated with breast cancer, a poor prognostic form of breast cancer. But it took several years, and in 2001, finally, there was the first publication in NEJM describing the advantages of chemotherapy plus anti-HER2 treatment versus chemotherapy. And similarly, on the right side is a picture of imatinib in CML. Our basic chromosomal abnormality was discovered way back in 1960, but by the time the drug came into market, it took so many years, and finally it happened in 2006. So why are we talking about precision medicine now? Time is right because we have a lot of information about sequencing of the human genome. There are improved technologies, and now we know how to manage the data. And the data is because of advances in bioinformatics, and of course, with the previous talk, AI is playing a huge role in this field also. So growth in personalized medicine advances the need for companion diagnostics. So almost by 2030, there will be 3 times more drugs that will be paired with companion diagnostic. And so almost 70% of new drug development programs right now, they are biomarker driven and associated with companion diagnostics. Now, if you see this particular graph, you will appreciate that this is a paradigm change in oncology. And in this particular picture, I would like you to appreciate the huge role played by tumor agnostic markers. And there are many tumors where precision medicine initiative is being exploited, or initiative is being used for treatment, but now there is slowly the role of tumor agnostic markers is coming into play. However, the entire story is not all that fine, and there are some issues. Number one is tumor heterogeneity, because there may be a matching drug, there is a molecular alteration, but still the tumor may not respond, and the reasons are tumor heterogeneity. So all of surgical pathologists in the audience will appreciate that HER2 itself, there is so much of heterogeneity when we are dealing with HER2, when we are evaluating HER2. So the case where there is genomic heterogeneity, that particular patient does not respond so well to anti-HER2 treatment. And again, triple negative breast cancer. This is again not a homogeneous disease. In yesterday's panel discussion, time and again it was, I also had to say, and my colleague Dr. Tanuja also finally emphasized the same thing. Even TNBC is not homogeneous, it is heterogeneous disease. And there are various aspects like basal-like TNBC or luminal androgen receptor-driven TNBC, or mesenchymal stem cell-like or mesenchymal-like. So these are an immunomodulatory. So if you are looking for use of immunotherapy in TNBC, the immunomodulatory type of TNBC is going to respond to immunotherapy. So these are the finer aspects, and so these are also the reasons why all TNBCs will not respond to immunotherapy. So tumor heterogeneity. The next point is tumor evolution. There are subclones which are developing, and they have variable dominance over a period of time. So this is, thank you very much. I appreciate. So tumor evolution, so tumor heterogeneity, tumor evolution, and these are the factors which are not actually giving us that much of effect, which is much desired effect following precision medicine initiative. And the third one is mutation burden. If you see the genomic landscape of any tumor, so there are mountains and then there are hills. The mountains are mutations or genes which are frequently mutated, and the hills are the passenger mutations. They are just there, but they do not have that much of effect. Now, these particular driver mutations are actually affecting, they have huge effect on cell survival, cell fate, and genome maintenance. And these are actually only 140 to 150 genes which are dictating the entire genomic landscape. So tumor evolution, tumor heterogeneity, and mutation burden, these are the three major variables which actually do not translate into that impressive effect of personalized medicine initiative in any particular tumor. But despite all the challenges, we have been using precision medicine for molecular profiling, to unravel prognostic markers, even to predict drug sensitivity and resistance, and predict adverse events. So typical precision oncology workflow, it starts with the clinic, first visit in the clinic, and the final is around day 14 and 15. However, if we are using next generation sequencing, usually turnaround time is around 2 weeks. So it goes beyond, say, we can say it is 3 weeks. However, there is a very important step before you release that NGS report to patient, and that is conduct of molecular tumor board. And I'll be alluding to it after a few slides. So therapy options continue to expand for multiple tumor types. So first column is 1996, then 2006, and then 2016. And if you go from breast cancer to CLL, you can see there is the red color is still there, that is chemotherapy. Now for breast cancer and prostate cancer, hormonally driven cancers, there is hormonal treatment. But if you look at lung cancer and melanoma, there is expansion of yellow region, and that is immunotherapy. So immunotherapy and tumor agnostic markers, they are playing huge role in precision medicine. So now coming to the poster child for precision medicine, that is lung cancer. Way back in till the year until 2000, pathologists were busy stratifying into non-small cell lung cancer and small cell lung cancer. Then we started concentrating more on adenocarcinomas, and then we started unraveling all those targets. And then there is to be sequential analysis of first EGFR, then if EGFR is negative, go to ALK, MET, ROS. But now the entire biopsy is subjected to a next generation sequencing upfront. So this is the interesting slide, and all of you must have seen it on multiple occasions, that the number of targets for lung cancer and the corresponding drugs which are available, which are in our armamentarium right now. And so this is the same information is in the form of this table, that on the first column there are biomarkers listed, and the last column it talks about first line or second line treatment. And again here I would like to highlight the role of PD-L1 and NTRK, which are tumor agnostic markers. And this particular slide describing NCCN recommendation on biomarker testing in lung cancer, the reason I'm showing this, that squamous carcinoma is not lagging. It is there with its own set of targets. So squamous carcinoma also is being investigated for a variety of molecular alterations. So now coming to genomics, we started with single gene, then hotspot panels. Basically it is a targeted approach, but now slowly we are moving towards larger panels and genome-wide analysis, and this is basically comprehensive approach. So in addition to genomic alterations, we are also concentrating on MSI and other markers. And it is common sense that as you are progressing from single gene to hotspot to comprehensive genomic profiling, actually more and more targets are being thrown up. And this is the reason why oncologists are also asking for larger panels and more comprehensive genomic profiling. And almost 30 to 90% of patients who undergo genomic profiling may have actionable alterations. And here, this is a very important slide, because whatever we are doing, we have to actually examine the existing piece of evidence. And that's why there is tiered classification of various alterations which we discover. So tier 1 is where there is strong clinical evidence, and tier 2 is where there is potential clinical evidence. So here on the right side, you will see green color. So that is the highest level of our level 1 evidence, followed by purple color, which is level 3A and 3B evidence. And then there is a beige color or very pastel color, very faint color there, and that is that actually depicts drivers without any actionability. So if you see all this particular graph, you will appreciate that there are many tumors where there is existing evidence available to make use of precision medicine. However, there are many, there are a lot of scope to develop and expand, because there are many where we still don't know about actionability. And then there are many tumors, the purple colored ones, those areas where we have to generate more evidence. And all this is important because when you are releasing NGS report, you have to actually study the existing evidence and then only release the report with your recommendations. So development of biomarker driven clinical trials, and this is very important, so that whatever is lacking in this particular, still lacking, can be that particular area can be supplemented with the information which we are going to get from these biomarker driven clinical trials. And there are two types: umbrella trial, where there is one cancer and several drugs which are available, so tumor agnostic drugs; and basket trial, where one drug and several tumor types are there. So what is the impact on overall health care? Standard chemotherapy versus targeted cancer therapy. If you see progression-free survival and overall survival, there is significant improvement, and that if tumor is responding to that particular drug. And at the same time, pathologist has to work harder, because there is level of testing complexity requested by oncologists, because more you dig in, more you're going to discover. So large panels, the oncologists usually ask for. And of course, whole genome and whole exome sequencing is still at the level of, it's within the realm of translational research. There are concerns regarding molecular testing reports, because there are variants of unknown significance which are thrown open. The cost, accuracy of the result, because this requires expertise, interpretation of the results. There are incidental findings, so that actually brings up certain ethical issues, and turnaround time, because turnaround time, at least in our setting, is 2 weeks for a targeted panel. So coming to agnostic approaches, cancer immunotherapy, 2013 was the big breakthrough in for cancer immunotherapy, and it was in the development right from 2011 onwards, and the entire world started humming the success stories of immunotherapy, and it started with treatment of metastatic melanoma. And so PD-L1 and MMR, these are becoming very popular markers, especially for lung cancer. And again, if I come back to yesterday's panel discussion about PDL1, you have to choose the right antibody, right platform, and you have to keep yourself updated with the latest literature. And here I'm referring to SP142, which we are now not using for TNBCs, and instead we have to go for 22C3 antibody. And so basically what we are doing while using immunotherapy is harnessing immune system and trying to teach our immune system, which has gone a little astray, to battle cancer cells. And so MSI and PDL1, these are the markers. And how MSI comes is related to immunotherapy, because it actually leads to high mutational burden and high neoantigen exposition, and that's how the tumor becomes amenable to treatment by immunotherapy. And again, alluding to the previous speaker, the talk on AI, the AI is playing a huge role in precision oncology, and basically is the digital path and AI is the ideal technology to manage and interpret large data sets and also bring information from variety of sources together for better clinical decision making. And this is one example. Deep computational image analysis of immune cell niches reveals treatment specific outcome association in lung cancer using AI predictive model. So now coming to role of pathologists, is not just the tumor diagnosis, but it is also careful optimization of tissue to provide prognostic and predictive information. And this is our data. It's about QC checks for NGS, and you can see the orange colored area. That is we had to organize refund for these patients, and we get a lot of referral cases. And if you see the analysis of the reasons on the right side, is basically housekeeping, gene not working, inadequate or no tumor tissue, or suboptimal library quality. And this is a proportion of course, almost 75% of the cases were analyzed, but there is a proportion of cases where if the pathologist, referring pathologist had worked harder, or probably we would have been successful in offering NGS reports to these patients. So our role as pathologists, ensure adequate fixation, again 10% neutral buffered formalin, right pH, choosing the right block for testing. Tissue processing should be optimal and adequate. Good storage conditions, paraffin blocks to be stored at 25 degrees and document 25 degrees or lower. Documentation and optimization of tissue usage, and these are our roles and responsibilities. And coming to the further details about tissue for biomarker testing. So depending on which test is needed, whether IHC, PCR, FISH or NGS, presence of 50 to 100 viable tumor cells are essential for FISH and IHC. For real-time PCR, a minimum of 5 to 10% of tumor cellularity is required, and for NGS, at least 20 to 30% of tumor cellularity is recommended. And this I thought is very important. If you just see sources of variation in HER2 testing, there are total 16 factors which affect HER2 testing, and accuracy of HER2 testing is still, there is a huge error rate even today in this country. And if you concentrate on pre-analytic errors, and the same reasons are responsible for problems in the rest of the genomic testing also. Coming to clinical utility of NGS testing, NGS to be used for each and every case, certainly not. NGS seems to be useful in providing benefit in the clinical course of advanced cancer when it is performed in patients which routinely need multiple molecular markers. Example is non-small cell lung cancer, patients with advanced rare cancer, or patients that are screened for clinical trials. But it is of little efficacy in patients with rapidly progressing cancer with short expected lifetime, or in patients with cancer that have standard therapy available. Example is breast cancer, because right in the beginning you get to know about ERP or HER2. Of course, TNBC still is an exception where we do not have very well defined targets and we have to work little more in TNBC. The same concept is seen in this particular slide when NGS to be ordered. And so when you come to this Gartner hype cycle, where there is technology trigger, then there is a spike, then you start coming to know what are the pros and cons, and then there is drop of disillusionment, and then you start gathering more information, you start analyzing the entire technology. So there is slope of enlightenment and plateau of productivity. So somewhere NGS is right now, it's over that slope and coming to the plateau of productivity. AI is still at that peak of inflated expectation, and it will start coming down and then it will come up again. And especially when I come across comments like pathologists will be out of the job because of advances in genomics or advances in digital path or advances in AI. I think it is all these are tools which are available to us, and we will always be in the picture provided we start using all these technologies. Now coming to molecular tumor board, no NGS report is ever released without getting discussed in molecular tumor board, and usually it has multi-institutional participants, experts in cancer genomics and interpreters of genomics. And we have published our data. Good communication skills are the key to success, and in almost 60% of cases, after molecular tumor board discussion, there was a change was recommended in the existing clinical management. So are we ready for the prime time? Definitely yes. And I would like to end by acknowledging our team, which is working very hard on next generation sequencing and our molecular pathology section, because they have risen to the occasion and they are armed with latest updates and knowledge, and because of that we are able to practice precision medicine and precision pathology and precision oncology. So be a precision pathologist to practice precision oncology. So that's the message, and thank you very much for patient hearing. Any questions?
Tumor board, is it at the district or it will the medical college, or it is like that? Which is that expert who is going to be identified?
No.
Like,
What we do is the medical oncologist, then the NGS team, whosoever has, there is a team of technologists as well as molecular pathologists. They all sit together and discuss.
in a medical college, how it can be done in a medical college?
I would say wherever this NGS report is being analyzed, that team along with the person who is going to use this information, so medical oncologists, they have to sit together and discuss. And of course, they have to examine the existing piece of literature that is there.
There is oncology unit should be there in a medical college. Thank you.
Any other questions?
Yes.
As a chairman of a teaching institute, what are the things that are being done for the postgraduates so that they become the leaders in both these fields?
See, for postgraduates, they need to be initiated into molecular diagnostics, and however, I should say that there are the previous question about medical colleges. I don't, the current, as per current NMC policy, at least they are setting up immunohistochemistry in every medical college, but it has not gone to the level of molecular pathology. So there we are still lacking. So there are few centers in the country. They are doing the job of molecular diagnostics, and the students, I think, have to make attempts to, say, do fellowship or spend some time there, so that to train themselves. So that.
Should be trained more on the morphology initially to begin with, and molecular pathology should be a fellowship. It shouldn't be a integral part of the teaching, because morphology is the one thing which is more important and the basis on which all these technologies have been evolved.
Last few years, there has been one significant change, although I have some, I do differ with the authorities there also, is about introduction of DM oncopathology. Now, this particular curriculum does have, the candidate is supposed to have strength in molecular diagnostics, immunohistochemistry, even the research posting is there. So all advances in pathology, but again, it's limited to few centers, not there everywhere. But it's a good beginning, I would say. Yeah.
So TMH is a vast repository of material, right? So you mentioned the requirements for sampling 5 to 100 tumor cells. Do you do it in real time? Do you do archival tissue? Do you use FNA?
No. These are patient biopsies. See, what is happening is, since especially the biopsies are becoming smaller and smaller, and they are being sent straight for genomic analysis or NGS, and that's why this tumor content is very important. In fact, we also have to, that's why sequential analysis is no longer preferred in lung cancer. The biopsy, you just ascertain whether it's representative, it contains adenocarcinoma or squamous, and then it goes to next generation sequencing. So
what is your experience in TMH for hematological malignancies like lymphoma? Leave the CML and other areas, but AMLs are very rich.
I think it's again logic, because I'm not expert in hematolymphoid, but there, because the fluid hematology, I think, is better as far as material is concerned, but the biopsies, the tissues, where we face problems. But of course, minimal residual disease is a different thing. Post-treatment, there would be a problem, I'm sure, even in hematology. Yeah.
2 years ago, there were 525 medical colleges in India. Today, there are 725. About 20 of them, in my opinion, are for molecular pathology. So when somebody said it's a shambles, well, I'm not going to go further. You figure out. No, it's the truth. It's the truth. If 20 out of 725 are talking modern medicine, that means 700 are not.
I will say one more
thing. There are
thing.
enough medical colleges which don't have even cryostats.
What's the representation of pathologists in NMC? Hardly one person is over there. So I'm surprised even they thought of, having IHC in every medical college. I mean, that itself is a welcome thought, I guess.
Yeah, but IHC has been around for 50 years now, for 45 years.
Yeah.
So with that, we'll conclude. Thank you very much, Dr. Sangeeta, for that very thorough and in-depth, presentation on biomarker studies in precision oncology.
Thank you so much, Dr. Sangeeta and Dr. Lata. Really, some of the new things we have got to learn today from both of you. Now we move on to the next session, the next talk. It's on the serous carcinoma of the ovary, what is new. The speaker for the day is Dr. Sunita Ehlawat. She is a principal consultant histopathologist and head of the histopath department in FMRI Gurugram. The chairperson for the talk is Dr. Santosh Menon from Mumbai, and Dr. Vinita Pandey from Mumbai. Dr. Sunita, please.
Thank you very much. And after AI and precision oncology, but mine is very mundane. But this is what I do day in and day out. I have just added a pinch of molecular into this. This is one of the most common cancer that we encounter everyday practice. Ours is a very busy gynae oncology hospital and neuroscience. These are my two areas of interest. So I'm going to review this cancer under all these 8 headings and discuss the dichotomy of these 8 headings. So the first one problem that we face whenever we look at a serous carcinoma of extrauterine origin is whether it is a low grade or a high grade. So this is the basic knowledge we already have about the low grade and high grade serous cancers. The low grade cancer, the precursor is a cystadenoma or a serous borderline tumor. And the underlying molecular alteration we see are in the MAP kinase pathway genes. And in contrast, the high-grade serous cancers, that is much more commoner than the low-grade serous cancer. And the underlying or the precursor lesion is the STIC, that is the serous tubal intraepithelial carcinoma. And the molecular defect we see is the P53 mutation. This is the background knowledge, and we feel that these two are distinct tumors. The low-grade cancer does not transform to high-grade carcinoma. So with this knowledge, I show you this case. This was a 58-year-old woman who presented with extensive peritoneal disease with bilateral tubes and ovary involvement. Initially, we received a mental biopsy, which was, we said that it is a possibly low-grade serous cancer. And she was given NACT, and following which the resection was done. So this is the omental resection. The top area showed a very low grade area, and the bottom slide is showing very high grade looking nodule. And this is from the ovary. Again, it shows the low grade as well as the high grade areas. So we were zapped, and even the IHC showed the same kind of difference. The low grade area showed almost 100% cells expressing ER, and the high grade areas only scattered cells were positive. The PR was negative in both the low grade and the high grade areas. P53 showed, we thought, wild type or null type of expression. P16 showed a very distinct difference as is seen here. The low grade area showed very patchy expression, whereas the high grade scattered single cells and those nodules showed diffuse expression. So we thought, we were not very sure what we are looking at. So we suggested that patient should undergo a molecular analysis for this case. So we reviewed the literature. So we found that we are not the only one who are seeing such cases. In fact, in last 2 years, we have seen 3 such cases. So the largest series of such cases was published by Shabnam et al. From Mayo Clinic. She reviewed their repository from 1995 to 2012, and they found 650 ovarian serous cancers, out of which 476 were high grade, 31 were low grade, and 22 showed this mixture of high and low grade tumors, and so they call them indeterminate grade high serous cancers. Out of which 19 they could review there were enough blocks to see, do the IHC and a repeat molecular. And these low grade and high grade areas were found not only in the different blocks, but in the same blocks also. So further review of literature showed that this study and few other studies, they document that the high-grade serous carcinoma can not only coexist with low-grade and serous borderline tumor, but they can even arise after the serous borderline tumor and low-grade serous cancer. And most of such high-grade serous cancer, people have found that they are P53 wild type. They don't find P53 mutation in them, and in spite of that, these cases behave poorly. So the relationship between these low grade and high grade is still not clear, but there are three hypotheses which is proposed. One is that they can be collusion tumors. The other can be that those tumors which show P53 mutation are possibly high-grade serous cancers, and people do treat them as high-grade serous cancer and having a different morphology. And those cases where MAP kinase pathway genes are altered, possibly there are some rare type of low-grade serous carcinoma which has now transformed into a high-grade, showing a high-grade transformation. But these lesions are few but significant number, and we need to explore them further to see what is this new entity is. So another dichotomy that I'm going to discuss is ovarian and extra-ovarian primary of high-grade serous cancer. Initially, we used to think that all these high-grade serous cancer, they arise in the ovary, but now we know that peritoneum and fallopian tube all can be a site of origin for these tumors. So now it may not always be possible to find out from where they are originating from. So now we have a single staging system for all these tumors, irrespective whether they are originating from ovary or fallopian tube or peritoneum. A British Canadian group, they follow this protocol that if a tumor has a stick or has an invasive tumor involving the fallopian tube, irrespective of the tumor burden in the ovary or in the peritoneum, is to be considered as fallopian tube primary. So in case the fallopian tube does not show either the stick or the invasive tumor and ovary shows the tumor, then irrespective of peritoneal involvement, it is an ovarian primary. And the primary peritoneal disease only when there is no tumor or a precursor lesion either in the ovary or in the fallopian tube. So apart from ovary and fallopian tube and peritoneum, this tumor can also start from the endometrium. This uterine serous carcinomas, they are high grade and they harbor P53 mutations. And their precursor is the serous endometrial intraepithelial carcinoma, which is the non-invasive minor component. It can present as advanced stage high-grade serous carcinoma. Many workers don't believe in primary uterine cervical high-grade serous cancers. They say that somehow it has trickled down from the endometrium. And these are very poor prognosis. So this is one case where we found that both the ovary showed high-grade serous cancer, which was P53 mutant, also showed peritoneal deposits and tumor metastasis to lymph nodes, and even in the adrenal. So this case had a very innocent-looking polyp in the uterus, which showed some calcified nodules, and just one focus of an abnormal-looking gland, which was a high-grade serous, and this showed P53 mutation, and on IC4WT1, both the polyp and the ovarian tumor were WT1 negative. So we believe that this is the SIC which has resulted in the advanced stage high-grade serous cancer. So IC4WT1 can help to differentiate between an advanced stage uterine high-grade serous cancer from an extrauterine primary because the endometrial high-grade serous, they lack WT1 expression, but we must remember that almost 30% of them can express endometrial high-grade serous can express WT1. And also about 20% of the endometrial high-grade serous cancer can show tubal fimbrial involvement. So in such situation, it is the extensive analysis of the endometrium, of the fallopian tube and the ovary, not only histologically but also molecularly, may be required for finding out the origin of the tumor. But what my medical oncologist friends tell me that is not actually necessary because the treatment does not matter. The treatment is same. And possibly some of the peritoneal primary serous cancers, primary peritoneal primary cancers may have originated from the latent cyst. The next dichotomy I'm going to cover is the hereditary or the sporadic BRCA dysregulation. As we know that a large percentage of cases of high-grade serous cancer, they arise because of the BRCA1 and 2 mutation, the germline mutation. But this is not the only way the BRCA dysregulation can take place. It can also be sporadic. That is a sporadic BRCA1 and 2 mutation, and sometimes it can be epigenetically BRCA1 silencing, which can account for BRCA dysregulation. Irrespective how the BRCA dysregulation has taken place, they all can be treated by PrAP inhibitors. The important dichotomy for us pathologists is the histology. So the high-grade serous cancer, there are two types. The conventional histology, which is we've seen in these pictures, papilloid belts and slit-like glands with high-grade nuclei and brisk mitosis. In contrast, the alternate histology, which is in the form of solid nodules, pseudoendometrioid pattern, and transitional cell carcinoma like morphology. This is called SET variant of high-grade serous cancer, and this is more often associated with BRCA dysregulation. However, the IHC profile of both the SET variant as well as of the conventional histology is similar. We used to say that the ovarian TCC is the prototype of SET variant, but uncommon histologies like solid, transitional, endometrioid, and very rarely mucinous can also be seen. IHC is very frequently used as a surrogate for P53 mutation. More often it is the overexpression or absence of expression, that is the null type of pattern, which is more often seen, but rarely it can be a cytoplasmic expression of P53. And some of the mutations that we see that may rarely can express as wild type. So in such complex cases where your morphology is matching, your IHC pattern is matching, but your P53 is wild type, don't be scared. Go suggest a molecular test, because such cases can only be sorted out by molecular testing. As I've been talking about SIC and STIC, they are the P53 mutant precursor of high-grade serous cancer. So the precursor for STIC is the P53 signature. In this, the epithelium is normal looking, and there is no high mitotic proliferative activity in this. But when you do the P53 staining, you find that a segment of the epithelium is overexpressing P53. So this can be picked up by routine P53 staining, but what about the precursor which shows null type of P53 expression? So for such, there are certain markers now available. The most oldest one and now time tested is the gamma H2AX, which is expressed in DNA damaged cells. And even when the P53 is null type, we can still pick up this signature lesion. There is another lesion which is called SCOUT, which we used to think that this is of no significance, and we thought that this is just a collection of secretory cell more often seen in the tubes taken out for high-grade serous cancers. But certain workers now believe that these lesions of SCOUT, which are present not only in the fimbrial end but also all through the tube, these lesions also show downregulation of PAX2, which is an initial step in the carcinogenesis of high-grade serous cancer. So possibly this is the P53 intact precursor. Finally, the therapy. So this is the tumor, which are what are the factors which affect a serous cancer for being responsive to treatment, and what are the factors which make it refractory. So three important factors which makes it a good prognosis tumor is the set variant, presence of BRCA mutation, and increased number of tumor infiltrating lymphocytes. And the factor which make them refractory to treatment are CCNE1 amplification and reversal of BRCA mutation. The CCNE1 amplification, a good surrogate for testing it is the cyclin E1, which is a very good marker. If it is overexpressed, the tumor is going to be refractory to treatment and poor prognosis. About 20% of these CCNE1 tumors show CCNE1 amplification. This is supposed to be one of the important molecular events in the carcinogenesis of high-grade serous cancer. Another important bad prognosis factor is the reversal of BRCA. This unique genetic event leads to therapy resistance. This BRCA reversal can not only, so when it happens, the function of, that is the HRD function is lost and it becomes normal and hence becomes refractory to treatment. This genetic alteration can also result because of the demethylation of the BRCA1 promoter region, and that restores the BRCA back to normal, and this results in chemoresistance. So finally, after we have done what are the 8 dichotomies, everything is molecular classification. That is because when the tumor looks the same, histology is same, IHC pattern is same, the molecular marker which is, or the alteration is same, and still the tumors behave differently. The same morphology, everything, clinical factor same, but still some of the tumors behave better than the others. So some of the workers have analyzed them more deeply, and they found there are 4 different transcriptional subtypes of this tumor, and they have different gene expression pattern. So there can be one full class on this, but these are 4 different transcriptional types which have different morphology and different gene expressions. Kasaba et al. Has tried to simulate this classification using this flow chart and by use of few of the routinely used IHC patterns. But this is a very fresh study. He has tried to classify, but we need to test this classification and find out whether it can be so easily simulated. So finally, now for high-grade serous carcinomas, like other tumors, we have to have an histological diagnosis accompanied by molecular classification and finally giving an integrated diagnosis. But it still has a lot of histology. Even when your IHC or surrogate markers don't match, your histology is saying it is serous, we have to prove that somehow by doing molecular testing. So the grass is still green on our side. By the way, this is Meghalaya. Very beautiful.
Thank you, Dr. Lawat, for a very wonderful talk. And there are 3 practical points that you rightly, made in this presentation. One was not having, knowing that in a carcinoma that looks serous, you might have a wild type P53 staining pattern. So don't just let it go because you have. One was that. Other is finding these mixed carcinomas. This is, and knowing that they can either be low grade, that has transformed, just a cytology has transformed to high grade, or it's a collision. So that distinction is important. And the other one is your WT1. That's a very practical point, that sometimes even the uterine ones show WT1 positivity. But as you said, it's a chicken and hen story. So, you're not really. So these 3 are like our everyday woes that you rightly so addressed. That was a wonderful session. Thank you.
Any questions from the audience? Yes, please.
Rather than, I think it would have been better that could we not just stamp it as a high-grade serous carcinoma despite having a wild-type P53 staining, because IHC is well tested that that is more than sufficient for you to stamp it, but morphology again takes upper stand. So how do you?
So
if anybody could help me out.
what we do is we run a panel of IHCs. So we do for ovarian malignancy, we do ER/PR, WT1, P16, P10, and P53 and Ki67. So P53 is not the only marker which will help you. So suppose it is an extrauterine serous carcinoma, so WT1 is mostly positive. So if you have a tumor which is P50, even though P53 is sometimes not helping, then because of whatever reason, whether technical reason or because you don't have the antibody, whatever, if WT1 is positive, EVR/PR may not be always helpful. But if WT1 is positive, P16 is diffusely positive, clinical picture is such, morphology is such, high-grade nuclei with brisk mitosis, necrosis, and solid areas. So you can still say, yes, I'm looking at a high-grade serous carcinoma. But in today's era, and especially if you are, thank God we are in India, we are not a litigation-bound country, but there we can say, yes, we are looking at a high-grade serous. But since I am in a very high-profile private setup, I like to get a P53. I like to see it to be positive. So what I do is in such a situation, because IC can be very tricky. So if my P53 is not working, I will send you to Kunal to get it done there. If he says that yes, mine also is coming wild type, I will write a comment in the bottom that yes, all the IC markers, the clinical picture, and my morphology says it is a high-grade carcinoma. However, the unusual feature is that the P53 is coming wild type, and aberrant expression is wild type, but and I would suggest that a molecular testing should be done for confirmation. That's how I will report.
I have one question, ma'am. Here. Here.
Yes, sir.
Thank you for your presentation. I just want to ask, have you started getting risk-reducing salpingo-fructimies? So BRCA positive patients, breast cancer patients who have decided to get a salpingo-fructimus, how ardently do you check for P53s? How many sections?
We process, we follow that.
CFIM. We also follow CFIM, but CFIM is you take the section, but how do you take deeper sections? Do you start doing P53?
We do P53.
We recently had a case when P53 was very borderline, so you have to have 12 nuclei P53 positive. Sometimes you may not get that 12 cut off. You can't sit and count each nuclei. So the question is, the patient, it's a very question of, what do you say, the patient has agreed to undergo that surgery and the doctor has done. So how as pathologists should we sort of approach that how many sections, and how do you frame the report? It's a difficult proposition sometimes to put up.
What I do is, because the cost is also a factor, we process following the protocol and do one set of deep cut on all the sections, and on the distal segments we do P53. And after that,
Particular case I did, I was wondering whether I should have done P53 because I got stuck with that case, in the sense that there was P53 was looked positive somewhere, but they were not 12 nuclear, but they were strongly positive in some.
But we don't get that many. I think we get about 1 or 2 in a year, not more than that.
Any questions? If not, thank you very much, ma'am. Thank you.
Thank you so much, Dr. Sunita, for a wonderful lecture. And thank you so much, Dr. Santosh and Dr. Vinita Pandey. Now we move on to the next talk for the day. The talk is, the speaker is Dr. Amanjeet Bal. She is a professor from the Department of Histopathology, PGI. The talk is Evolving Landscape of Biomarker Testing in Non-Small Cell Lung CA. The session will be chaired by Dr. Veena. Dr. Veena is the head of histopathology and digital pathology from HCG Cancer Center. I welcome both of you to the dais.
Thank you and good afternoon, everybody. So I will be talking on evolution of biomarkers in lung cancer. So as we have heard Professor Desai about the precision oncology, which is the standard of care for lung cancer. So this is a timeline of biomarker for non-small cell lung carcinoma, and it started in 2004 with the detection of EGFR mutations and these patients responding to EGFR inhibitors. And since then the list is ever growing, and we have now more than dozen of targets for which we have drugs available, and the list of these targets and the approved therapies is ever increasing. So where does the pathologist fit here? So in this era of new generation drugs, there are 3 major roles of the pathologist. First, our basic, what we do is diagnostic, that is accurate histological classification. So we know that oncogenic drivers, they vary with the histological subtypes. So this is the first most important role of pathologists. Second is to look for sensitizing molecular alterations whenever you diagnose it. So at the time of diagnosis, either a clinical or a pathology diagnosis, and the lesions or the molecular alterations which we look for, and the methods which we'll use for looking for these molecular alterations. So once we have done that, the third step is, while the patients are on these therapies, they develop resistance. So how do we look for the resistant mutations and how to go about those? So there is no longer distinction between small cell and non-small cell lung carcinoma, which was done in 2004. It's not sufficient for guiding therapy, so we have to go ahead and give accurate classification. And WHO 2021 has given a classification of non-small cell lung carcinoma into different subtypes, and if not all, we should be able to call it squamous, adeno or adenosquamous, and we should also look for a sarcomatoid histology because it has a particular molecular alterations. And for neuroendocrine tumors, we should be able to label them as small or large cell neuroendocrine carcinomas. So on histology, if the morphology is clear-cut, if we see squamous differentiation or we see a glandular pattern or adenocarcinoma patterns, we can easily call them as squamous or adeno without using any ancillary techniques. In adenos, we have to differentiate whether it's a mucinous or non-mucinous adenocarcinomas because the molecular alterations differ in both these groups. And for neuroendocrine carcinomas, the pattern is important in lung neuroendocrine tumors, and if you see those patterns only, then you should put neuroendocrine markers. But most of the cases we are getting small biopsies, and this is the histology. It's a solid pattern in both the slides, so we cannot differentiate whether we are dealing with adeno or squamous. So this constitutes around 40% of our cases, which cannot be typed exactly on morphology alone. So here we take help of immunohistochemistry. So for adeno, we have a panel of markers TTF1, nepsin, CK7, and for squamous P40, P63, and CK56. But the recommendation is use only one adeno and one squamous marker, and that is TTF1 for adeno and P40 for squamous, because we have to preserve tissue for molecular testing. So best combination for daily practice, TTF1 and P40. TTF1 positivity, any nuclear positivity, you can call it adenocarcinoma, but for P40 you have a cutoff of more than 50%. Tumor positivity should be there. CK7 should not be used to differentiate into squamous or adeno. And as I said, neuroendocrine markers should be applied only if you have neuroendocrine morphology. So this is the change in the profile of histological diagnosis. So initially we used to call, if we don't see squamous or adenohistology, non-small cell NOS. But with the help of immunohistochemistry, we have been able to cut down it to 5% from the 10% which was previously noted. Now once we have a diagnosis, the next step is to look for the molecular alterations in these tumors. So first step is, there are different guidelines which are available. First step is whom to test. So all advanced stage lung adenocarcinomas or metastatic non-small cell lung carcinomas where we were not able to differentiate between adeno and squamous, they should be given benefit of molecular testing, and it should be done at the start of the treatment, before any treatment is started. Now there is a role of molecular testing in early stage lung carcinomas also, because we have drugs for adjuvant setting, and in smaller biopsies where you have not been able to rule out adeno component, like we called it squamous cell carcinoma in a female who is never smoker, even those patients should be tested for molecular alterations. And no recommendation for neuroendocrine carcinoma for molecular testing, and you can use any tumor, either a primary or a metastatic site, or even core biopsy or cytology samples can be used. So the oncogenic drivers in adenocarcinoma, so this is from the Asian cohort, and as you see, there is a difference in the molecular alterations in mucinous as compared to the non-mucinous adenocarcinomas. So we have drugs mostly for the non-mucinous adenocarcinomas, and if you see, EGFR mutation is the dominant one, which constitutes around 40 to 50% in the Asian. So this Asian includes the Japanese and the Chinese cohort also. So the guidelines say that we should test these molecular alterations, which include EGFR, ALK, ROS1 rearrangements, BRAF, MET, exon 14 skipping mutations, RET rearrangements, NTRK1, 2, 3 gene fusions. And out of these, first three are must for every patient. And then in addition, we have PDL1 testing for immunotherapy. Initially, KRAS was taken as a negative predictive, has a negative predictive value, but now we have a drug for G12C, so we have to look for this molecular alteration also. And then there are emerging alterations which include MET amplification. So how do we test these alterations? So if you are using as a single gene testing, then the PCR is the best method. But for EGFR testing, NGS can also be done. And the most common molecular alterations in EGFR gene are exon 19 deletion, followed by exon 20 L858R single nucleotide alterations. And in addition, there are few other molecular alterations in EGFR gene have also been reported. Most of the times we see a single alteration, but sometimes you do get dual alterations in the EGFR gene also. So as I said, histology is important. So this is one of our case where we called it squamous cell carcinoma without doing IHC, and it was positive for L858R mutation. But when we went ahead and did P40 and TTF1, both were negative. So this case should have been called as non-small cell NOS with L858R exon 21 mutation rather than calling it squamous showing this molecular alteration. So recommendations for EGFR testing is laboratories can use the EGFR test methods, whatever they have in-house, and the tumor content should be at least 20%, and it should be able to detect the mutation which is present at a frequency of 1%. IHC for total EGFR is no. Mutant specific EGFR antibodies are available. If you have very tiny tissue which is not yielding adequate DNA, you can attempt it. But the negative mutant EGFR IHC does not rule out EGFR mutations. And EGFR copy numbers have no role in guiding EGFR TKIs. The second target which was discovered in 2017 is ALK, which is EML4 ALK rearrangement. It's a small paracentric inversion in the short arm of chromosome 2. Initially it started with fish, but now D5F3 clone from Roche Montana is sufficient to report it, and if it is strongly positive, the clinician can go ahead and start the treatment. For ROS1, IHC can be used as a screening method, but if you see some positivity on IHC, then it has to be confirmed by an alternative method, either FISH or next generation sequencing. So the overall frequency in our setup for EGFR is 25 to 30%, and for ALK is 9 to 10%, and we have not found any EGFR or ALK rearrangement in squamous, though they have been reported from other institutes in India. So other targets which beyond EGFR ALK ROS1, BRAF is also being put in a must list now, and it's the V600E mutation, but sometimes non-V600E mutations have also been reported. KRAS, as I said, were the markers of poor survival and reduced response to EGFR TKIs till now, but now since we have a drug against G12C, so it should be tested. Then MET exon 14 skipping, the sarcomatoid histology is a clue that we should test for these molecular alterations. Others, we have HER2 mutations, and we have rearrangements for RET gene and anti-RK123. So these can be done either by FISH or next generation sequencing, the RNA sequencing for rearrangements. So while we are doing so many tests, as was highlighted by Professor Desai also, we should be optimizing tissue use. So we should be aware at the very beginning that we may have to do molecular testing. So either you cut all your sections at a first go, or you use a two-block technique. One you use for diagnostic and IHC marker, and other you preserve for molecular testing, including next generation sequencing. So after this, the key consideration is, should we do a single gene panel, that is a sequential testing, or upfront next generation sequencing? So most of the centers, or where we have patients who cannot afford these technologies, a sequential or a single gene panels are still valid. So as we know, next generation sequencing will simultaneously detect many genes and many samples at once. It will provide information about all the rearrangements, copy number variations, and deletion insertions. But at the same time, it's complex, and bioinformatics require a lot of effort, and the cost is also high. But there are advantages of doing next generation sequencing, because so this is our data where we have seen after routine testing, if all these three markers were negative, then the patient's sample was sent for next generation sequencing. So and this was done for targeted panel, which is only for lung cancer panel. And here we saw, in addition to finding a newer targets beyond these three, we had missed EGFR in around 4% cases, ALK rearrangement in 2% cases, and ROS1 in 2% cases in the routine sample processing. So there are issues of diagnostic accuracy using these methods, which can be improved by next generation sequencing. Like this is one of our cases where the false negative reporting was done for ALK using immunohistochemistry, and the external control was nicely positive. On the same slide, however, ALK was negative, but NGS picked up this EML4 ALK fusion. So this could be because of the amount of the fusion protein was too less, which was not picked by immunohistochemistry. Then there is a issue of false positive also, and this is mostly reported by ROS1. So this is a case where, so ROS1 fish is reported as positive if you have a break apart of signals, or it is a isolated 3' signal, or what we call as a 5' deletion. So this case was 3' deletion, and however the NGS did not pick up this fusion, and on IHC it was also negative, but based upon the fish report, patient was put on crizotinib and he experienced the progressive disease. So this could be possibly a false positive on fish. Then it also gives us other information about the co-alterations which have prognostic significance, like presence of P53 co-alterations with EGFR. This will predict a poor response to EGFR TKIs. And if we have coexisting TP53 and RB1, this could predict that patient may transform to small cell carcinoma while on TKI inhibitors. So NGS is a costly technique, but if patient can afford, upfront NGS is the answer, and if patient cannot afford, still we are doing good with PCR and immunohistochemistry and fish. So guidelines for molecular testing: real-time PCR or NGS for EGFR, IHC for ALK, ROS1 IHC you can use for screening, but it has to be confirmed by alternative method, either NGS or fish. Multiplex gene sequencing panels are preferred because of issue with the tissue. So, however, single gene assays are still acceptable. And for next generation sequencing, this panel, this is the list of the genes which should be there in the panel. So once the patient has been put on TKIs, there is an issue of resistance to targeted therapy, which usually happens after 1 year of therapy. And the mechanisms are either it's a mutation at the EGFR gene, that is T790M mutation within exon 20, or there is a small cell transformation from adenocarcinoma, or there is a activation of the other pathways which include MET, MAP kinase, BRAF or PIK3CA. And resistance to ALK TKIs, nobody is testing for this, but the mechanism is mutations in the ALK gene. So this is one example of a 67-year-old female who was diagnosed as adenocarcinoma, was positive for EGFR mutation, put on EGFR TKIs, but in 2020 she developed a new mass lesion which on FNA was diagnosed as small cell carcinoma. For T790M, we have to do either a repeat biopsy or you can detect it in a cell-free DNA also. So here comes the role of the liquid biopsy in the setting of relapse, and it takes care of the tumor heterogeneity, which may be because it takes care of both primary as well as the metastatic clones. So this is one example where after on TKIs, the patient had T790M mutations, and these were picked by ddPCR. So ddPCR on cell-free DNA you use if you have to look for 1 or 2 targets, but if you want to go beyond T790M, then NGS on cell-free DNA is the answer. With progress or with evolution, plasma first approach is now being proposed, and this is proposed for those patients where you have a tiny biopsy at the initial setting and you cannot wait for the patient to undergo a second biopsy which has adequate tissue. So plasma first approach, in these patients we can look for molecular alterations in plasma at first setting without looking at the tissue. If it is positive, it helps, but if it is negative, then you have to go back to the tissue. The other markers which are in lung cancer is PD-L1 testing, again has been discussed. We have multiple drugs and multiple clones of antibodies which are available, and for lung, we are using SP263 Ventana clone because it has been seen that it shows similar results to 28 Pharma DX and 22 C3. So we give tumor proportion score for lung carcinoma patients. So having said that, there are still barriers to biomarker testing, as tissue in lung is always an issue, both the quantity of the tissue and the quality of the tissue. Second is access to the testing. So it's available in most of the tertiary centers or private laboratories, and it's not available in the peripheral pathology labs, that is agreeable. Third is the prolonged turnaround time. So we have to develop the techniques where the turnaround time is shortened so that the patient gets treatment at at the earliest, especially in the advanced lung cancers. Fourth is cost. So, and the fifth one, which is the most important, is after having done everything, the lack of access for and sequential NGS is sent if patient is affording. And in resistance setting, we look at histology, T790M for by ddPCR, and if negative, then cell-free DNA can be subjected to NGS. So thank you very much.
That was a very, very interesting talk. And so I wanted to ask you, you said that, we are, there are recommendations that say that bare minimum of 2 markers, TTF1 and P40. I would like to share a case that I had some days back in which the clinician had asked me that if TTF1 comes positive, we would like to subject it for the molecular panel. And something was not fitting right, the location, the clinical presentation, everything seemed a little odd. And on histology, we had really large cells and many areas of necrosis, and TTF1 was positive. And napsin was very, napsin sometimes can be difficult to interpret, very focal, vague staining. I happened to put a synaptochromo CD56, all of which came positive. Then I happened to read up and I saw that there are cases of large cell neuroendocrine which can show positivity not just for TTF1 but for napsin as well. So my fear now is that, if we talk about bare minimum markers in algorithmic approach, we are probably, at a stage where a large cell which doesn't need a molecular testing, it won't be of much help versus something which has changed the paradigm of how molecular testing has happened for oncology. So I wanted to know your comments on that.
Yeah, I agree to that. Like third marker which we'll put will be one for neuroendocrine, because small cell and large cell neuroendocrine carcinomas do express TTF1, but morphology certainly give you a clue whether you are dealing with a neuroendocrine tumor or not.
Any other questions? So I had a question actually. Dr. Sangeeta spoke about handling the tissue and you also addressed about it. So we do get blocks wherein you have tissues that are, identified with dyes. So we often end up, getting difficulties on interpretation of which. So does that make a, would you like to add that?
Limited tissue, he tells us to do ALK and ROS1 by IHC, then he attempts EGFR on cell-free DNA. Thank you very much.
Histopathology Lab, Center of Excellence, Agilus Diagnostics, Mumbai. And Dr. Sachin is Additional Director and Head of Hematopathology, FMRI, Gurugram, Agilus Labs. The chairperson for the talk will be from the Center of Oncopathology, Mumbai. So I invite first Dr. Kunal and Dr. Shilpa, and later Dr. Sachin will follow.
So good afternoon to all of you. Myself and Dr. Sachin are, we lead respective centers of excellence, but we are also very, very good friends. So some of these cases are cases for which, the aspirate and trifine biopsies and flow is worked up by Dr. Sachin, while the lymph node and if we need bone marrow IHC, it comes to me in Mumbai. So, we will be sharing one or two such cases as well. So whenever I see a lymph node biopsy, lymph nodes are usually a problem at a lot of places, and they're also very exciting because it's more like maths. You just see certain things and how they come positive, and which cell population is staining what. That is also very important. So what are some of the very basic things that I look at is that abnormal comes from knowing what is normal. You should know your lymph node histology very well, which is the mantle zone, which is the marginal zone, what arises from where. We should know that exceptions are rare and nothing is impossible, but commoner things are common. So you should think of commoner things first, but you should I always say that account for variable change. Any illness will present to you in a slide, but hints will only come to those who correlate. It's very, very important that you correlate your lymph node histology with clinical presentations. There can be very common overlaps, like something between an EBV-associated lymphadenitis and an Hodgkin's. What makes matters worse is an EBV-associated lymphadenitis will progress into Hodgkin's. So at times, so sometimes later when the patient presents as Hodgkin's, your clinician will call and tell you that, dude, you gave me an EBV-associated lymphadenitis and now he's come up with B symptoms. So you probably have to understand that these are progressive diseases and you can have one thing going into the other. While good diagnosis brings a lot of accolades, one wrong diagnosis can ruin a patient's life and your reputation. So as much as possible, don't allow the latter. Seek help, have more brains working on something which is very complicated. And the main aim of diagnosis is to make sure that the patient is managed well. Keep that at the heart of your workup. You will seldom, you'll most often not go wrong. So with that, let us come to our first case. This is a 62-year-old male patient who presented with pneumonia and perianal mass. On HNE, the patient was diagnosed at the primary center as non-Hodgkin's lymphoma, likely diffuse large B-cell lymphoma, and was referred to me for final diagnosis. So what we saw was this. You can see that this was actually a tumor which looks like a DLBCL, so not a bad first guess to make. Also, these are diffuse cells, intermediate to large size, look like atypical lymphoid cells, lot of mitosis. And this was my first set of markers. They were positive for CD45. They were negative for CD20, and the Ki67 was very high. It was about 90%. CD3 was positive in the tumor cells. CD138 was also positive in the tumor cells. So the obvious question is, lymphoma, not lymphoma? Lymphoma or not a lymphoma? Lymphoma. What are the two things that are confusing here? One is T and the other is plasmablastic versus a T. So we did some more markers, and if you see, the other pan T cell markers were staining pretty okay, except CD3. 5, 7, 2, they were all alike. We did see some sort of a light chain restriction in this case, which I wasn't really expecting. MUM1 was also positive. CD38 showed focal staining. CD79 was diffusely positive. CD56 was positive. EMA was positive. And Eberich was positive. So what does that make it? EBV associated. Okay, how many for T cell lymphoma? Anybody in the house? Possibly. Anybody for B cell lymphoma? I'm not even putting Hodgkin's as a doubt here. Anybody for plasmablastic lymphoma? Can I see some hands? All right, we do have few people for plasmablastic lymphoma. So obviously the question was whether it is a T cell or a plasma cell neoplasm, and this gave me the answer. So you can see aberrant expressions of CD3 in cases of plasmablastic lymphoma, a diffuse Eberish positivity, everything else falling into place, 79A falling into place, would probably, make it pretty easy. With that, going into my next case, very, very interesting case, a 74-year-old male patient who presented with increased counts and lymphocytosis. On peripheral smear, it was a case suspected for chronic lymphoproliferative disorder. Bone marrow aspiration showed metastatic adenocarcinoma. Bone marrow biopsy was also reported as metastatic adenocarcinoma, but it was sent to me for review because if you see an infiltration in a bone marrow, you would probably expect reduced counts. And here we saw increased counts and PS was looking like a CLPD. So this was the bone marrow biopsy. You do see that, I hope it's clear that there is a metastatic carcinoma there. At places, it does look to form a lumen, so to say. I don't know if you can make that out. On the right side, at the lower end, it seems like it's forming lumen at places. So metastatic adeno wasn't really a very bad guess, but the cytology of these cells didn't look like an adenocarcinoma to me for some reason. They were a little more pinkish. I didn't see mucin. And so I decided to do certain markers. CK was positive, CK7 and 20 were negative, and I threw in another set of markers, which were P63, P40, and CK5/6, all of which came positive, diffusely. So I was pretty clear that, it was probably some sort of an acantholytic kind of a picture, a pseudo, adenomatous picture, and it was a squamous cell carcinoma. But again, my problem was, why are the counts increasing? So I went back into the biopsy, and I looked at it again. On the left side of the picture, there are two cores. If you see the right side of the core, at the bottom, you will see there are some lymphoid aggregates there. And those made me very intrigued as to what I was looking at. And I decided to throw in some of my lymphoid markers as well. And of course, the PS did reveal a chronic lymphoproliferative disorder. I have just tried to put some of my favorite detectives, because we are no less than a detective. We all recognize Miss Marple pretty well, yeah. So this was that suspicious population. And when I did evaluate it, what I saw was it was diffusely positive for CD20. I threw in my other panel and it came positive for 5, 23 with a low Ki67 index. So we had atypical epithelial cells positive for CK5/6, P40, P63, negative for the adenocarcinoma markers, and a lymphoid cell population positive for CD20, CD5, CD23, BCL2, and LEF1, negative for 3, cyclin D1, 43, and CD10. Of course, I was evaluating on lines of a low-grade B-cell lymphoma. Another very famous character. Poido, right. So this was actually a metastatic squamous cell carcinoma coexisting with a CLL-SLL. And that was the reason why the counts were being increased. So sometimes, we get really excited when we see something on morphology and we tend to shut shop. But we should realize that, sometimes 2-3 things are happening in the same patient. So in retrospect, when we went, we saw that the PET-CT had a 3 into 2 centimeter sized FDG avid uptake in right lung with multiple pleural nodules. So that is where the squamous cell carcinoma was coming from. And flow cytometry done by my friend showed positivity for CLL. Case number 3, this was a 60 years old female, painless increasing swelling in the left breast since 3 months. We are in the hematolymphoid session, so I won't be showing you probably a breast carcinoma. And when we see this looks like, a diffuse pattern of involvement. These were actually small to intermediate sized lymphoid cells. They had very, it was giving me at places a starry sky appearance, to be honest. It had those brisk mitosis and, very monomorphic kind of nuclei. So I was a little intrigued. When we threw in the markers, of course, as I had expected, CD20 was positive, CD3 was negative. So we had a CD20 positive tumor, BCL2 positive, Ki 80%, 10 negative, 30 negative, 5 negative, EBV negative, CMYC negative, TDT negative, BCL6 MUM1 focal positive. What do we have? Burkitt's? Huh? See, Burkitt's should usually have 10 positive and BCL2 negative. So here we had BCL2 positive and 10 negative. Unlikely Burkitt's. You know the case. Right. That's, of course, that's what it should be. But I think, as Dr. Narendra suggested, I'm less likely to show you a diffuse large B-cell lymphoma ABC type. So what I wanted to tell you in this case was CD5 was staining just like CD3, and Ki67 was very high. Whenever you see a cleaved morphology, whenever you see a Burkitt's-like morphology, in the aggressive variants of mantle, that is the blastoid and the pleomorphic variants. With that, my next case is a 72-year-old male patient, multiple level 2 lymph node enlargement. Largest was 3 into 3 centimeters, B symptoms positive, pruritus. Diagnosis of T histiocyte-rich large B-cell lymphoma was given. Patient showed very poor response to treatment and disease progressed. Anybody has any thoughts based on this clinical history? Right? B symptoms present, lymphoma probably. Hodgkin's, non-Hodgkin's? Without the morphology. Yeah. Okay. NHL is also a possibility. Correct? Very good. Anything else that strikes you off in this clinical history? Okay. So pruritus is something that comes into my mind. And pruritus is very commonly associated with a set of lymphomas, which you will see. So this is what the histomorphology was like. If you see on the right side of the picture, I'll try and show you here. So there were some of these cells, these large looking cells. And you can see they actually look binucleated here with very small eosinophilic nuclei. So they are looking RS-like. I mean, I would still not throw away the diagnosis of something which is a T histiocyte-rich large B-cell lymphoma, but I did see some large cells, and in the background we saw a monomorphic population. So these large cells were positive for 20, and they were positive for PAX5. So THRL BCL? AITL? The large cells are 20 positive, that's right. The background cells are CD3 positive, and we see a lot of cells which are CD30 positive. Do THRL BCLs commonly show 30 positivity? EBV positive DLBCL. ALK positive DLBCL. I'm really enjoying this. I'm so happy everybody is contributing. So I'll tell you what I did next. Something was not fitting, and that was, if you see the morphology of these background cells also, it's not very healthy. Right? So I wanted to do something here, which I always do, and that is put a pan T cell panel. Of course, Ki67 was very high. So I'll tell you, this high Ki67 rules out a THRL BCL. A T histiocyte-rich large B-cell lymphoma will show you scattered Ki positivity. Recognize who this person is. And this is how I was at that time. So I threw in a pan T cell marker, and to not my surprise, I saw a loss in CD7. I saw variable loss in CD5. CD2 was diffuse. TIA1 was positive. 4 was more than 8. What do you think are we dealing with now? AITL? So this this is the profile in a nutshell. Large cells 30 positive, 20 positive, PAX5 positive, MUM1 positive. Background cells 3 positive, 5 positive, 2 positive, 5 was variable, 4 positive, TIA positive, Eber-Risch positive. Your background T cells will not show you Eber-Risch positivity if they are normal, right? They are negative for 56, so we rule out a NK T cell lymphoma. They are negative for TDT, so we rule out a T lymphoblastic lymphoma. They are negative for ALK, so we rule out a ALK positive ALCL. They are negative for EMA, so we rule out a ALK negative ALCL. They are negative for GATA3, they are negative for granzyme, they are negative for perforin. I had my diagnosis. It was a PTCL NOS, which was EBV positive. These are very, very rare. And what you need to understand is that RS-like cells in a PTCL can show you 30 positivity, can show you 20 positivity, and can show you PAX5 positivity. So always be very careful of the background population. It can actually mislead you a lot. This case was actually subjected to T cell receptor studies, and they did show monoclonality. Very rare. Eber-Risch positivity in PTCL is very rare. And another thing which I would like to tell the house is that EBV association in a diffuse large B-cell lymphoma is a good prognostic factor. EBV association in a T-cell lymphoma is a bad prognosis factor. Okay. So my last two cases, the last one is a bonus. This one is interesting. We saw this together. 30-year-old male patient, high total leukocyte count, more than 1 lakh. The first thing that comes to our mind is a high leukocyte count, more than 1 lakh, TLC, with massive splenomegaly. CML. Patient had fever, patient had cervical lymphadenopathy. On peripheral smear, patient presented as a CMPD, chronic myeloid leukemia in chronic phase. And BCR-ABL was positive. So you had your diagnosis here, right? This is a CML in chronic phase. Patient had huge lymph nodes, especially in the cervical region. So they were biopsied, and they went to different places with different thoughts, and they landed up on our table, and this is what we saw. So this was a set of really, sheets of really atypical cells. They had open chromatin, and I was clear, like this is a, these are blasts or these are atypical lymphoid cells. There was nothing else in my mind. I threw in a 34, it came positive. The next thing I would, of course, like to throw in is myeloid markers, right? 117 came negative, MPO came negative, 13 came negative. So then again, the Pandora's box opens up. We want to throw in everything that helps us to work up this case. CD3 comes positive in this population. 20 is negative. T. 5 is variable, 7 is diffusely positive, TDT positive, 99 positive, Eber-Risch negative. Any thoughts? Lymphoma? T lymphoblastic lymphoma? Okay. T lymphoblastic lymphoma coexisting with a CML, right? Sorry? No CML. It was BCR-ABL positive. Absolutely. So this is a case of a CML in chronic phase, which had an extramedullary infiltration of blasts which were not myeloid blasts.
That flow also has done, but that was not showing any T cell proliferation, means abnormal T cell blast.
Okay. So we had blasts which were positive for 34, 37, 56, 99, TDT. Okay. Variable expression for 4, down regulation of 5 and 2, negative for 117, 13, MPO, 8, TIA1, perforin, granzyme, Eber-Risch. I did Eber-Risch also because there is NK lymphoblastic that also needs to be ruled out. 2079A and PAX5 were staining residual reactive B cells. My favorite of all. Extramedullary T lymphoblastic crisis in a CML. This is my last case, a bonus, and that just came off the table. I thought I should put it. This is a 30-year-old female who complained of fracture femur with a large mass involving the bone and surrounding soft tissue, no other lesions in the body. This is what we saw on histology. On the rightmost side, they look round to oval. Rest of the sides, they look spindly. Right? Sorry? That could be a crushing artifact. Very, very good thought. So this looks like a very poorly differentiated tumor involving the femur and the surrounding soft tissue, and there is a lytic lesion, a large mass. Any thoughts on this? Blastic lymphoma? Osteosarcoma? No? Yes? Biphasic? Synovial? So synovial, usually synovial are very low-grade sarcomas. Usually. They will not show you a very aggressive appearance. This was positive, so I threw in my basic panel. I wanted to know the lineage of this. It was positive for Vimentin, focal. Negative for CK, so carcinoma goes. Negative for 45, lymphoma out. Negative for S100, HMB 45, probably your melanoma out. Negative for SADB2, negative for 30. Any thoughts? Huh? What? Round cell osteosarcoma. Osteogone. Okay. Yes. Osteogone. It could still be. I've got smart people in the house. I still threw in some markers which I love. These were CD20 and CD3. CD20 was diffuse. CD79A was diffuse. It was positive for BCL2, negative for 34, 117, 10, BCL6, MUM1, TDT, and CMYC. Who's this guy? So the trickiest of all, because this is actually a detective whose name is Paul Polacki. He was very famous as Paddington Polacki. He worked in London with the London Metropolitan Police, and he was a very, very famous detective in Britain. So this was actually a case of CD45 negative diffuse large B-cell lymphoma, non-GC subtype. 45 is not, necessary for calling something lymphoma. With that, I give the stage to Dr. Sachin for his. You have spindly is crushing artifact first. Also, there is a spindle cell variant of DLBCL. We'll speak on coffee on. I'll let him speak. Thank you.
Interesting cases. Any question for Kunal?
So I'll tell you what made me think about something else. Nothing else was so. CD5 and CD7 were staining like how I would expect them to stain. They were staining focally. All others were staining in one fashion. CD3 was staining diffusely. So that could be interpreted either as a loss of all the pan-T, which is a little difficult because you sometimes see variability in the losses as well. The other thing was the location of the mass and the morphology. So I did see some plasmacytoid cells there also, and I just wanted to make sure that I rule this out in the proper fashion. There was no history. No. There was no history. Very high. I showed you it was positive. Yeah, positive. Again, 138 was positive, and there was light chain restriction which I showed. Were you seeing? Yeah, lambda was less. No, I think lambda was more, kappa was less, which you don't really expect in a plasmablastic sometimes, but you can still get it. That is more in cases of flow. What we use CD3 is a very crisp and clear CD3. Yeah. Any other questions? Please. Please.
So just a couple of comments. The case where you had coexisting carcinoma with a CLL, we had a situation like that, and unfortunately we actually missed it. It was EBUS TBNA that we got, and EBUS TBNA, the material is very scanty, and you're really looking for things on the smear or the block that is prepared. So we picked up the carcinoma, and it was adenocarcinoma, and the report went out. The patient also had generalized lymphadenopathy, and a medical oncologist thought that it's really not how he expected a lung cancer to be. So he biopsied another lymph node. And that lymph node was very typical of a CLPD, and it turned out to be a CLL. So we reviewed the EBUS TBNA and said, let us now put markers, because we had not looked at the lymphoid at all. And then when we ran the markers, we found out that there was a coexisting CLL SLL. And then we issued an addendum. So that scare is always there when you're looking. I mean, now, you know, once you miss something like that, you wonder whether you're missing it in other cases too. And I really don't have any easy answers to that. Maybe pay attention and see if the background cells are looking very uniform, or are you seeing a reactive population. So that was one comment. Then you had the one where it was a CD5 negative mantle. So that's again, you know, how much, where to stop doing your IHC is a tricky question. Whether it's a DLBCL, because sometimes in DLBCL, depending on the fixation, the cells may not really look large, they may look medium sized. But then it's always very important to do a cyclin D1 in situations where you think that the morphology is not fitting. And that differential can be really tricky at times. Your other case, which was a classic Hodgkin or a T cell rich large B cell, or a T cell which has EBV thing. And especially if the T cell lymphoma has the immunoblasts, which can again be confusing. So very nice case.
Thank you so much, ma'am. Thank you. Please. Sure. Sure. Yeah.
And oftentimes confused with an NKT cell lymphoma looking at still, but clearly the markers differentiate.
Absolutely.
It's very difficult to detect.
Right. Right. Yeah, please.
Wonderful cases. As Madam pointed out, when we see lymph nodes in MND specimens, we are just looking for metastasis. CLL is quite sometimes it's missed. So that was one very important point. The second thought was your case of CML with nodes. Just a thought, did you try dendritic cell markers? BPDCN would be like, with it had 4, it had 7, and core, you know, it can come with CML. So could it be that one point? And second was, yeah, high-grade B-cell lymphomas, especially with medium-sized cells, we do try to add in cyclin D1 and TDT whenever, you know, because that's a very, you can just trip very, very easily.
Thank you for those comments, Dr. Vinita. I'll go in the reverse order. I have started putting cyclin D1 for all my large B, you know, aggressive-looking lymphomas, because CD5 negativity is I'm seeing more and more often in this. In the case of CML and the nodes, I did not put a dendritic cell marker. Maybe that wouldn't have been a bad differential at all. But I thought that once my T cells came positive, my TDTs came positive, and my Eber-ish came positive in that, I actually was, I added, yeah. So I was pretty clear in one way of thinking, and I probably didn't put it early. I would have probably put it early, but then after that, yeah. So, and plus, just for everyone in the house, a blast crisis phase of CML, we most commonly see a myeloid. The next is T, and the least common is a B. So if you're not seeing something which is myeloid, and I thought, like, you know, we are pretty much on the diagnosis. That's enough? Oh, yeah, thank you.
Thanks, Kunar. Yeah, sure.
Yeah.
Thank you for the presentation, very interesting indeed. My question is, from a medical point of view and pathology, it's great that you are able to do so many markers. From an economic point of view, is it practical? Who pays for that?
I would definitely like to answer that question. Click the mic so that everyone hears this comment out loud. I am a little, you know, I've mellowed down with time, but I'm a little aggressive of the humans that you get in touch with. And I'm very clear about the fact that our economic understanding of cancer is very bad. We always discuss the ideas of spending very little in diagnosis, while we are ready to treat with very, very expensive treatments in terms of chemotherapy, in terms of immunotherapy, and in targeted treatments. Our whole intent has to bring down the cost of testing, But at no point in time can you do a suboptimal testing in which you get a wrong diagnosis, because then any amount of money that you spend in treatment would be money down the drain. We are dealing in cancer where the patient would only progress because the treatment is not correct, and the end is death. So again, I would say that 70% of our clinical decisions are made on diagnostics. That is how we should also look at spending. We should make sure that we spend adequate in terms of getting the right diagnosis before we hop on to the treatment. I hope I've answered your question well. Thank you. And yes, we will be looking, we do tend to do as much as possible to make sure that the cost of this comes down. In India, the healthcare insurance is not that well penetrated into the diagnostic sector, but that is something that we are also looking at the policy level. And at the same time, there is automation which is coming in. I mean, we are actually one of the most economical countries for cancer diagnosis. Even in genomics, the tests that take $1,000, elsewhere, we do it for much, much lesser cost. So I think that is where we have to collectively move as a fraternity. Thank you.
Yeah. So my job is now to play quick fire rounds of bouncers through flow. So this is who are not familiarized with flow. That's just one basic slide. That's the most important plot in the flow cytometry. Is a 45 side scatter plot. So there's a very high side scatter and very bright 45 is a eosinophils. Through all my presentations, that will be like this little orangish color. These again high side scatter, bright 45. These are neutrophils. 45 negative, low side scatter. These are erythroids. And this is the lymphocytic area, bright 45 and low side scatter. There green will be the T lymphocytes, and this dark blue will be the NK cells. And this is the blast region. This is a 45 dim. So the case 1 is a 15-year male. Only the plots are here. History I will tell, and will go very quickly. So 15-year male. Presented with almost 1.5 lakh counts, and platelet count was less than 50,000. Patient was having history of only 4 days, gum swelling, and that is basically just a short history, 4-5 days, and no hepatosplenomegaly, no abdominal mass, nothing. And on the CBC and bone marrows was showing almost 80-90% blast, and the sample has come for flow. So here if you will see, the 45 is the lymphocytic area, and this is 45 little dim but not dim. Generally we will expect more 45 dimmer in the leukemias. And 34 is negative, immaturity marker 34 is negative, and myeloid markers MPO and 117 is negative. T cell markers surface 3, cyto CD3, 7 all are negative. So we are not dealing with any myeloid or T lymphoid malignancy, and 19 and 79 is positive. It means we are dealing with B lymphoid malignancy, the sure. Okay. Other 117, that's obviously we have HLA-DR was positive, and 38 is positive. 38 can be positive in BLL also. So till now, from this is the leukemia screening tube. We are clear that's a B lymphoid malignancy. So, and forward scatter is high, it means high grade B lymphoid malignancy. But we can't say here it's a B cell ALL because 34 is negative. Okay, so we have to do some more markers. So that's all other myeloid markers. 13, 33, 11B, in all myeloid markers are negative, and 4, 14, 64, all the monostic markers are also negative. So definitely not myeloid. This one, if you will see, 10 is dim and 20 is bright. So, and 38 is very bright. These are associated markers, but for LAIPs, all are 86 is positive, but all others are negative. So we are dealing with 10 positive and 20 positive now. So in these type of cases, whenever you will get anybody, can we say it's a B cell ALL now? Okay. So it can be B cell ALL, but 20 is very bright and 34 is negative. So we can't say that is a B cell ALL. So we have to do in these type of cases always kappa and lambda. Anything means kappa lambda in my practice I will prefer, because TDT sometimes in flow will not give the accurate result. That's more better on the IHCs. So it's better to do kappa lambda. If kappa lambda also will not help, then we can go for TDT, and we have do kappa lambda in this case, and that was clear cut kappa positive. Okay, so this is basically Burkitt. And later on CMIC fish has been done, that was positive. Patient in conversation with the hematologist, uric acid was not settling. But the two important thing take home message from this case is, in this case presentation was not like Burkitt. Presentation actually was like B cell ALL, because generally I have seen, I think in 16-17 year experience, I have seen first case of Burkitt which presents with count of 1.8 lakhs. Generally it will present around 50-60,000, not more than that. And another thing was no abdominal mass, and history was very short, and classical morphologically cytoplasmic vacuolations were not there. So that was thing, but we have done, and CMIC was positive. So that's case of Burkitt. So take home message is, whenever you are getting 34 negative and 20 bright, so always and always do the kappa lambda in these type of cases in flow. Otherwise you are going to miss the Burkitt. So this is, so case number 2 is 18-year male. This T-cell MRD has come from Uzbekistan. If I am showing only the T and NK, so here this red population is abnormal one, green one is a T cells, and blue one is a NK cells. But so definitely there are some T cell proliferation, and if we'll see here, the abnormal population was surface 3 cyto CD3 is positive. But what is the abnormality here? The immaturity marker, the 34, TDT, 99, these all are negative. One is also negative. Only my problem was 2. One is 56 positive and another is 5 negativity, if you will compare with the normal T cells. Okay, so 56 is positive and 5 is negative. Normally the T cells will not have that expression, and never the mature T cells will not show 56, you know. So this is in my view, this at diagnosis itself, this is a disease positive, but this is not T cell ALL itself. Okay, so we have asked the history, they have not find out. We have told no, get it the diagnostic thing, and I was suspecting the hepatosplenic gamma delta in this case. Okay, so hepatosplenic gamma delta is the most commonly missed diagnosis. Whenever you are getting on flow surface 3 and cyto CD3 positive, okay, so majority of the T cell ALL, 80% of the T cell ALL is negative for surface 3. Okay, in the flow you can differentiate between surface 3 and cytoplasmic positivity. In IHC you can't. That's a little better advantage of flow. So here because 56 was positive and surface 3 cyto CD3 both were positive, 5 is negative, so my diagnosis was disease positive, but probably this is wrong diagnosis. This was hepatosplenic gamma delta. So but somehow, because in the MRD we will bulkize all the samples, and after processing we were not having the samples, so we were not having to, you know, do some more markers to confirm that. So we have asked the report. I don't know how much it's clear on the background. So 34 is negative, and in the report itself, if you will see, 56 was 80% and TCR gamma delta was 87%. Okay, so at the diagnosis time itself, it's not T cell ALL, actually it's a hepatosplenic gamma delta. Later on we have find out patient was having massive splenomegaly still, and this so the take home message is, whenever you are getting surface 3 cyto CD3 positive, always and always do the TCR gamma delta. Otherwise, especially in the setting of massive splenomegaly or splenomegaly, otherwise you are going to miss the hepatosplenic gamma delta T cell lymphoma. Yeah, CD94. CD94 is the activation marker that will come in many of the things also, but the surface 3 cyto CD3 positive, 5 negative and 56 positivity. That's a classical phenotype of hepatosplenic gamma delta. So another case is a 73-year male. This patient is actually of case of DLBCL from medical oncology team, and was following up taking treatment, and actually DLBCL thing has been settled. But somehow the patient has, since last 6 months, patient has lost almost 15 kg weight. Okay, and patient was having gastric ulcers. Biopsy has been done, and it has been reported like proliferation of T lymphocytes. Then the peripheral blood has come to us, so peripheral blood was showing lymphocytes. We have suggested flow cytometry for that. So that's a lymphoma screening tube. Here in the lymphoma screening tube, we will see 45 positive, that's the lymphocytes are increased, and no B cells, 19 positive, no T cells are very less. And this is some proliferation of 19 negative and T cell 3 negative lymphocytes. What it can be? Any idea? Yeah, NK we have 2, because the lymphocyte 3 is not there, and surface 3 is not there, and 19 is not there. So as I told you, in the flow you can pick up the surface and cyto CD3 thing. So okay, so yeah, surface 3 is negative. This is for T cell markers getting, I'm not going into the detail. And here the 4 was negative, and 56 here in this tube. This is basically Euroflow approach. So in this, the same tube, I am having 56 and lambda. So it's difficult here for me to differentiate. Only this is the case, 1 or 2 rare case like this, where you can't differentiate actually. So you have to put different markers. So here either it can be 56 positive, or either it can be lambda. But probably it is going to be 56. We will put it extra. And 5 is negative and 38 is positive. Till now it's looked like to me, because 3 is negative and 38 is positive, 5 is also negative. It's lymphocytic region. So my suspicion is this 56 is coming because of the NK cells thing, not because of the some B cell. Anyway, because B cells are not there. So we have put the NK tubes. So that shows 7 positivity. Anyway, 4 was negative and 5 is negative, and then 56 is positive. In these cases, LGL also have to be ruled out. 57 was negative. So, and 2 is positive. So all NK cell phenotype, classical phenotype, NK cells will be having loss of 5 and 56 positive. So that's a very rare entity. That's a CLPD of NK cells. So this is CLPD of NK cells. Later on, we have reviewed the biopsy also at our center, also at Mumbai also. So that was also consisting of CLPD of NK cells. Patient has started on cyclosporin, later on methotrexate, and patient responded well. Patient is doing fine. Now he has returned his appetite, and he is doing good. So another very interesting case, that's a 2-year male, and all on bone marrow was replaced with blast-like cells. On the flow, that's a leukemia screening tube. 45 is negative. Immaturity marker 34 is negative. MPO negative. Both 1979 B markers are negative, and all T cell markers are negative. So leukemia screening tube, nothing is positive. So only 45 negative. And that's a 45 negative. So we have to remember 45 negative is a very important area. We have to look very carefully, because that's anyways erythroid, but lots of other plasma cells and many cells are coming that. So we have to get the 45 negative area. Okay. So that's a myeloid tube we have put. So in myeloid tube, 117 also positive, 13, 33. All myeloid markers are negative except 15. Only 15 is positive. And monostic markers 64, 35, 123 HLDR all are negative. 14 was very dim, but based on this 45, I can't say that's a myeloid. Only 15 is positive. 45 negative, 15 positive. We have done just 56, because as a myeloid markers, when 45 is negative, to rule out 45 negative AMLs like M6, M7, you have to do it. So 41 and 56 we have done, 41 was negative, and this is 56 positive. So now 2-year male, 45 negative, 15 and 56 positive. Any diagnosis? How many agreed? Are we dealing with the hematolymphoid malignancy? All looking for blast. Huh? Yeah, exactly. So this is actually a non-hematopoietic. We have suggested to do the IHC. So this has come from the remote area. Biopsy, I think, going to Kunal. I don't remember what the diagnosis has happened after that. But we have suggested that's probably metastatic, because the metastatic neuroendocrine, the round cell tumor generally will show 56 positivity. So whenever 45 negative and 56 positivity is coming, you have to think about, rather than hematolymphoid, you have to think about the non-hematopoietic. I think it was neuro. Yeah. No, this is different. This has come from Patna, ma'am. So biopsy has gone for there. So okay, next case. She is 36-year female and very high LDH. Again 45 negative. All the leukemia screening tube, all markers were negative. Then in then we have put the lymphoma screening tube because the cells were very large on the morphology. And here the T cell markers, 3 was negative, 4, 8 was negative, 5 was negative. All T cell markers were negative. Only the 38 was positive, and 56 and lambda both were coming positive. So I don't know this is actually because of the 56 or because of the lambda. But here all the B cell markers are negative. 45 negative, but 38 is positive. Okay. Generally in the erythroids, 38 is negative, but here 38 is positive. So 45 negative and 38 positive. All were like large cells, so we still morphologically was difficult to say where it is going, but because 38 was positive and 45 is negative, and it was looking like either 56 or lambda, so I have thought this probably will be plasma cell. We are dealing with plasma cell proliferation, so we have done plasma cell tubes, and that exactly has shown 38, 138 positivity, 19 negative, 56 positive, kappa restricted, and 117 also positive. So that's a case of plasma cell leukemia. Okay. So the take home message is always to look for CD45 negative population that we have to gate. So another important thing is that's a 22-year female, generalized lymphadenopathy. Okay, and there was 45 bright and proliferation of CD3. Okay, and this is 4 is negative, 8 proliferation. So that's basically T cell proliferation, which is 4 negative and 8 positive. 5 is positive, 38 is positive. That anyway will come. And all other markers, B cell markers were negative. 43 is positive. That shows for T cells. And rest all other markers also doesn't give much clue. 7 was little dim than the normal T lymphocytes. 2 is positive. And some more markers, 26, 27, 28, that also will not help. But here basically is a ratio is reverse. So T cell proliferation, CD8 positive, but 4 negative. And the age you always have to remember in these kinds of cases, 22-year female, and we have seen the slide very carefully. So these the slides were of Downey cells. So this is infectious mononucleosis, not the T cell lymphoma. So take home message is when the ratio is reversed, don't always think about the malignancy. It can be EBV proliferation. Generally in the EBV proliferation ratio is reverse, CD8 positive lymphocytes. So that's basically the infectious mononucleosis, and EBV has come positive. Patient has responded well. I think, okay. 2 more minutes, so I am just skipping this, but that's the question always in our practice. Whenever you are having suspicious M-band, renal function test normal, no lytic lesion, bone marrow showed 4 to 5% cells, so what to do? Because whenever we are doing on the trophine biopsy, because of the non-specific background, kappa lambda, we can't able to make out. These are clonal plasma cells or abnormal plasma cells. So what we are doing nowadays, in these type of cases, if patient is ready to pay, we are doing the
myeloma panel as a MRD kind of thing. And in these type of cases, we have seen in last 2 years that's very helpful, because in two scenarios in this case. So first case was these plasma cells. So these plasma cells are normal, 19 positive, 56 negative, and kappa lambda both. So this is positive. Another case in the same scenario where you can see the two populations. The purple one are normal, and this red one is abnormal one. That's 19 negative, 56 negative, but kappa restricted. That's so this the second last case, very important. 40-year male. That's in monocytic region, but again all the immaturity markers 34, myeloid markers, B cell markers, T cell markers all negative. So but whenever we will see this, so we always go for AML tubes, because all the B cell markers and T cell markers are clear cut negative, 1979, so this cannot be BOT, less likely, so we will go for AML. So we have gone for AML panel. 117 was negative, HLA-DR was very bright, and 33 was positive, 13 was negative. 64, all monostic markers were negative, but the important thing was 123 and HLA-DR was very bright. Okay, so 123 HLA-DR bright is specifically in the blastic plasmacytoid dendritic cell neoplasm. Okay, so patient was having this skin lesions also. So whenever you will see 34 negativity, 123 HLA-DR bright, so that always you have to look for BPDCN. And in this case, we have done 41 and 56, both were negative. So why the take-home message is, generally we will see BPDCN is a 456 positivity, but many of the times that can be negative also. So even if 456 negative, that can be BPDCN. So 123 HLA-DR, there are two differentials. Either is a T cell or it's a AML with aberrant 7. Okay, so in these type of cases, whenever T cell markers are negative, first we are doing the AML markers. AML markers have done. All AML markers are negative except 33. Only 33 is positive. Monocytic and myeloid, all markers are negative. 56 is positive. So till now, 34 is positive, acute leukemia. 33, 7 and 56. Okay, and all other immaturity marker TDT is negative, 99 is positive. All other T cell markers are negative. So 34 positive, 7 positive, 56 positive, and 99 is positive. So we have preferred blastic NK T cell leukemia over acute unclassifiable leukemia, because here few markers are coming positive from NK, few are from T, and 133 is also there. So we have preferred blastic NK T cell leukemia. Thank you. Any questions? Yeah. 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 That depends, ma'am, on the clinical scenario. How's the clinical thing? As a pathologist, our job is there to find out that plasma cell is clonal or non-clonal. So that answer definitely we can give by flow, because I have, in the interest of time, I have not shown in that plasma cells only 0.2% on the flow. But we were clearly able to identify how much percentage of clonal plasma cell and non-clonal plasma cells. In that cases, by from our side, it will fit into MGUS kind of thing. Yes. But it depends how the clinical presentation means all other craft features. So treatment has to be given or not. Yeah, that's true. But in these, not only these, sometimes we have picked up amyloidosis also by doing this. Because whenever we are finding these abnormal plasma cells and patient is having some cardiac issues or splenomegaly, so they have worked up for amyloidosis, and that has been come positive. We have done. Yeah, it can go anything. That's why I have shown two cases. It can go anywhere. But in last in 2 years, we have done almost 10 or 12 cases. Out of them, means more was of benign. Means all more of the pluripotent thing. Only 2 or 3 has come clonal.
But that's important information, I think, for clinician. Yeah, thank you. Yeah.
CMIC was positive. So in this case, we will stop there or we will continue to look for double hit lymphomas.
Which one, double?
Double hit lymphomas.
That I think Kunal will give the better answer.
Can you repeat that again for me, please?
Yeah, Burkitt lymphoma case, through flow, it
Yeah.
was like a high-grade B cell malignant. We
That's
came to a
correct.
conclusion, and we have done further CMIC.
Yeah.
But in this case, we stop there or look for double hit lymphomas.
So CMIC positivity, we definitely have to make sure that we subject them to all the 3 gene rearrangement studies, because we know that the treatment for a regular DLBCL versus an aggressive or a Burkitt's lymphoma would be different. We have the new dose-adjusted R-epoch regimens and other things that we need to look at. So we'll definitely be doing gene rearrangement in those.
Thank you, sir.
Yeah.
One more question, the NK versus T CLPDs or lymphoma leukemias. So do we need only one mark after ruling out others like CD3 negativity and other markers? So is CD56 only on that we can rely, or we need to have more markers? Like what is the cutoff?
It's not only 56. We have to see other markers also. Surface 3 negativity, 5 negativity, 56 positivity, 7 positivity,
And
lot of other
NK
things, 2
cell
positivity.
specific markers do we need? Like
No.
more than 2 NK cells somewhere in the article I read.
You know that's a resourceful country. There are many markers, but you have to fit into. Generally, billing will come only in one panel, leukemia panel or something. So you have to give answer in this only. If you have that kind of patients who can pay, obviously I want to do it. But if not, I think this is the algorithm approach for
And
my lab.
CD16 also specific, but
16 is also good. Generally, it's not in a routine panel to me, but whenever these type of cases are coming, so we are putting 16. So the NK cells I have shown you that in that 16 was also positive, but I have not shown here.
and what is the role of CD94? So they tell whenever we get CD94.
CD94 I have used in
NK.
few cases. CD94 is not I am using in the routine panel, but yeah, that in the NK cell proliferation that will help. But 94 is a basically activation marker.
Okay. So in the
that will
background of other NK cell only we have to give importance to that.
yeah, only in that, not in all like T cells normally.
Okay. Thank you, sir.
Yeah, so one case actually interesting, since we were discussing about multiple myeloma. So I had recently one case, she was actually presented to a nephrologist with high creatinine, and she got worked up. And there was high suspicion of cast nephropathy, so he thought there might be probably a myeloma. So when the marrow was done, there were 11% plasma cells, and biopsy was showing sheets of plasma cells. So it was apparently looking like clear-cut case of multiple myeloma because there was end organ damage. But when the IHC was done, the kappa lambda restriction was not there. The ratio was maintained. Again, serum electrophoresis and other routine myeloma workup did not show any M band. Kappa lambda light ratio was normal. Again, urine was, I was suspicious, was a 24-hour urine protein electrophoresis was done. There was nothing. So,
Actually,
but clinically it is
I understood these
pretty much
exactly these in last 3 months I have seen 2 cases of like
Yes,
this.
yes.
We have seen almost 60% of plasma cells, but that were of polyclonal.
Polyclonal.
So polyclonal plasmacytosis, and one has come autoimmune hepatitis. They have reported another one. Still, we have not find out the answer.
Right.
But we were saying exactly it's the same. Flow also we have done.
The PET scan is normal.
Yeah.
So
PET
there
scan
were
is
no
normal.
light occlusion.
Flow, in another case, what I'm telling, there were proliferation of plasma cells that were also polyclonal, and by flow wise also and IHC wise also. We are also stuck in that.
So we
case
got
till now.
in situ hybridization done, and it showed their kappa restriction. So now I'm treating her with my
patient is responding.
Negative.
One that case polyclonal autoimmune hepatitis.
So now after treating with myeloma regimen, her creatinine is coming down. So looks like quite a bouncer actually.
Point was you said that in biopsies sometimes we have difficulty with kappa lambda, but we get very good. We work with IHC mostly for in-house process samples, but when we get outside process tissue, we work with in situ hybridization, and we get very good results with the light
No, ma'am,
chains.
whenever it is more than 10-20%, there will not be having any problem.
The low volume
Only the
disease
low
we can
volume.
struggle.
That's main problem is when you are getting 3-4% of plasma cells.
Yes.
In that kind of cases, it's very difficult, I think, and I am sure you also might be having
So
problem.
there the MRD approach
There only
will,
these type of cases. Whenever there's a 60% plasma cells, no need to do. But when you are getting 4-5% plasma cells and clinician is not having answer, okay, these are
Then
clonal
it
plasma
will-
cells or reactive. So these kind of cases we have found very useful. This
and the CD56 case that you showed, na,
Yeah.
which was a non-hematolymphoid. I think
Yes.
that's also an important message for
Yeah.
the pathologist, because a lot of times we think 56 is equal to NK cell, but
Yeah.
56 can be seen in neuroendocrine. It can
Round
be seen
cell
in
tumor
plasma
system.
cell neoplasms. A
Yeah,
lot of times
plasma
we've used it in plasma cell neoplasms. I have seen it in rhabdomyosarcoma. So the context is very, very important for the CD56. Very nice cases
Thank
with
you.
very clear messages for
Thank you.
every
Thank you.
case. Thank you so much.
Thank you so much. So we move on to the next talk before the lunch. The talk is Evolving Role of Precision Pathology in Multidisciplinary Management of GU Cancers, an Overview. The speaker is Dr. Santosh Menon, who is a Senior Consultant Uropathologist from TMH Mumbai. The chairperson for the talk will be Dr. Mahul Amin. He needs no introduction. He is the President and Medical Director of LabCorp, Professor of Urology. He is a board-certified anatomical pathologist and clinical pathologist. He has co-authored the WHO classification from 2002 and 16. So I welcome Dr. Santosh.
Thank you so much. Thank you, Kunal, for the kind invitation. And the previous session was all hematology. It's been refreshed a little. Hematologists, especially for cytometers, have got a very colorful life, I must say. So I think my job is pretty simple. We have been deliberating on this since last 2 days. So my specific topic is on uro-oncology and just an overview of the different cancers and where we are going to. So compared to say or say brain tumors, we are still sort of not that precise in geo-oncology. But yes, we are going to encounter these more and more. So this is just conflicts of interest. So I'll start by saying, is it crystal ball gazing or is the future already here? That's a question. So are we ready to use it? Are people using it? What is the future hold for us? So just like what we have been deliberating since last 2 days, where all can precision help in the cancer management, diagnosis? One thing we forget is preventive and early detection. So that's something, once you have the biomarkers and the information of different cancers, maybe we can pick up those things and try and prevent cancers in this field. Obviously, the aggressiveness and the targeted treatment is something which is more evolved in many cancers. So prognostication, prediction is extremely important as a part of a precision medicine. And something again which is not taken up too much in our country is hereditary screening, genetic counseling, which is very, very important because most of the huge amount of cancers can run in families and we need to detect those. So quickly coming on to prostate cancer, I think there are rich array of markers for early diagnosis. And if I can take a blow of this, so whom to initially biopsy, whom to repeat biopsy, that might be a question which the clinicians ask. So this is a multidisciplinary kind of a talk. So always they have this thing, should we re-biopsy this patient? It's suspicious of cancer, atypical small lesional tumor. So there are several markers like the 4K score, the 5 index, and a whole lot of, I'm not going to name them. But I think in the US, Dr. Amin can help me in that. 4K score is done pretty regularly, if I'm not mistaken. 5 score and 5 score are being done. So they can help detect cancer. So there is a suspicion, but you're not getting a positive biopsy. When to do a biopsy, when to repeat a biopsy, that array of biomarkers is coming and they'll soon be in market in India too. So that's one thing. The next is risk stratification of cancers which are already there to prognosticate them. Once you have detected a cancer, is it an indolent cancer? Do you need to treat them? There are tests like the Decipher, the Prolaris, the Oncotype DX, which show different combination of genes proliferation markers, cellular organization markers, androgen pathway markers. So they can have a combination of genes, and based on certain scoring system, just like you have in breast, they can say whether this patient needs treatment, further radiation. So this is all comes in the gamut of a multidisciplinary team. The pathologist is at the center of it. The molecular pathology team is at the center of it. And those questions may be asked, as and as more questions are put up by the clinician as well as the patient himself, we can use these tests in a way. I think this is pretty routine in the West of using Decipher tests. Our clinicians have also started asking this, but unfortunately it's not readily available in our practice in here. So these are the markers which I just mentioned. When it comes to the setting of treating these cancers, a lot has started coming in prostate cancer. You need that PARP inhibitions coming in a big way. Then there are treatment panels for PIK3C and AKT pathway, like in breast cancer, again in prostate cancer. Important part is this BRCA associated prostate cancer. They form only 8 to 10%, but then they are treatable by drugs like olaparib. So this is just a cartoon to show that when your BRCA is not working and your PARP is inhibited, the DNA has nowhere to go and the cell dies. So that's the fundamental of treating this BRCA mutated prostate cancers with PARP inhibitors. So that's important. And there are lot of genes, HRD testing in prostate which is coming up. There are several genes which are picked up, but BRCA2 being the most prominent when it comes to HRD testing in germline mutations in prostate cancer. There have been several studies ranging from 2000 for the last decade which have clearly shown that these are more aggressive cancers. They can run in the families, and they can obviously, when they are treated with olaparib, they do pretty well. And that's the targeted kind of precision management you have for a subset of prostate cancers, but that's available in these practice. So this was the first trial which looked at the PFS and OS of these prostate cancer patients, showing that biomarker negative patients would have a different kind of outcomes. I think I'll quickly go on. One important thing is we are going to see more and more neuroendocrine prostate cancers because they are being targeted with all these androgen response signaling pathway drugs, enzalutamide and abiraterone. So more and more prostate cancer are going to de-differentiate into, and that's what we are seeing for the last 2-3 years. We get this metastatic. They have this EZH2 inhibitors which are now available in the West, and they can also be targeted. So it's a prostate cancer patient now, even with metastasis, can sort of live for easily for 7 to 8 years because there's so many drugs coming in the pipeline already there, and more are going to come. So it's become like a chronic disorder, and that's the aim of the medical oncologist, to make cancer into kind of a chronic disease, and the pathologist, being the guardian of the tissue, is at the center of all this information. Quickly on to ERV7 variant. So this was a paper which came in NEJM. So when you have an androgen receptor variant 7 mutation, these are resistant to the enzalutamide and abiraterone. So we tried doing this ARV7 on immunohistochemistry on prostate tissue, but unfortunately it doesn't work very well. So we got some sample from vendor and we tried to do this, but it didn't work. So they have got huge implications because this is a very common drug which is being given to all metastatic prostate cancer patients. So if we, as a pathologist or molecular pathology, we can look for this variant initially, we can tell them not to use these drugs in this because they don't do well with these drugs. So that's another point in prostate cancer management. I think PTEN loss, some people are started doing IHCs on prostate cancer with PTEN loss, and they are associated with poor outcome, but PTEN per se, immunohistochemistry, is not a great IHC marker. But my point is, in the coming decade, you have several IHC markers, you have molecular markers which will come in. The labs will be forced, we will be forced to learn these things in the day-to-day management of these cancers. Obviously, MMR mutations and PDL1 therapy on these MMR deficient tumors is important. You can see that they form a minuscule of prostate cancer patients, about 2-3%. But when all the other gamut of treatments of these prostate cancer patients are sort of used up, then they would ask for an MMR. So we do get once a month this kind of MMR testing on prostate cancer because they can be given this drug and they have important implications in the management of these patients. The question the clinician always asks, should I do a primary tumor biopsy or a metastatic biopsy? I think several people have shown that once the tumor is metastasized wildly, that becomes so heterogeneous that you just cannot pick up and do biopsies from all these. And so the better thing to do is to do liquid biopsy because it's got all the circulating tumor DNA, and it is not only for picking up the resistance, it can pick up resistance to the tumor drugs. It can tell you how the tumor is going to behave, the aggressiveness, and all those information can be obtained. And we have been sort of discussing this over the last 2 days, so I'll not go into the details. Obviously, deep learning algorithm, we had a fantastic talk by Dr. Raj, and this is coming. This is, though, I think, is being completely used. Automated Gleason scoring is being used in several places. This was just an article I came across which did a systematic review, and you can see that even on deep learning, like Dr. Raj said, you can identify what mutations these tumors are. So you need not actually perform those molecular tests, expensive tests. Maybe once it becomes very, very integrated into your practice, this AI can help you in picking up and telling what molecular aberrations these tumors have. And that can help in your work pipeline. It makes me always feel whether I lose my job, I'll have to compete with, stand in lines with robots for this, or I have to press my panic button. I think that is a fear. Everybody, all pathologists have this fear that good amount of their jobs are going to be lost. Bladder cancer, quickly, I think the urologists are worried about these cancers, high grades, the subtype NMIBCs and the muscle invasive bladder cancer. And why is this precision information needed? We know that not all non-muscle invasive will progress. Some muscle invasive are more amenable to treatment like chemotherapies. And in this era of bladder preservation, many of the patients don't want a surgery. So are there markers or something which can tell you that these things can have? So these are the things which are coming up with bladder cancer. It's still not of clinical usage, but we shall. So as pathologists in day to day, this is somewhat a little precision. It's not actual precision, but when you tell that it's a small cell carcinoma of the bladder, you are indicating that they need to be treated differently. When you say it's a squamous cell carcinoma, you're telling that probably you should go for a surgery. When you're telling that it's a sarcomatoid, you're telling it the prognosis is bad. So this is a precision when you give, even on histology, you are aiding in precision, but not to the extent where a genomic or a AI can give you. So these are important. So like I said, squamous cell carcinoma, they are responsive to PD-L1 therapy. Micropapillary, even if they are T1 lamina invasive tumors, you may need to give NACT in those patients because they are aggressive, they may have nodal positivity. And small cell carcinoma would always be treated with a etoposide based chemotherapy. So this information is on basic histopathology, and there you are precise in certain ways to it. I think I'll skip this. So these are the two pathways, luminal pathway or the low grade pathway, and the basal non-papillary or the high grade pathway, which is a P53 pathway in the bladder. This information has been there for a decade or long, this P53 like, basal like, luminal like, just like you have in the breast. And people have seen that the basal like do well with chemotherapy. The P53 like is more likely to metastasize to bones. So those information has been available, but somehow it has not picked up in daily routine because these are high-end genomic tests which cannot be done on every patient. So that's there. A couple of questions. Always we struggle on a bladder biopsy, whether this is a von Brunn test, whether it's a nested type of bladder cancer. And there a TERT mutation study can help you because TERT mutations are one of the commonest mutations which occur in bladder cancer. Obviously FGFR2, 3 mutations, these are now in clinical practice. If you do them, if the patient has recurrent bladder cancer with FGFR2, 3 mutations, they can be targeted by a different. So all these integrated multidisciplinary meetings and discussions are necessary when you are treating and coming up. Quickly on to the consensus molecular classification. So now bladder cancer is sort of molecularly put up like this. There are 3 luminal type, 1 stroma rich, 1 basal and neuroendocrine. The question is, are there certain histological pointers? So if you look at the micropapillary subtype, it falls into the ambit of the luminal non-specified thing. The problem with this it's good to read a paper, it's good to understand and have the knowledge, but in day-to-day practice it becomes very difficult. But in a bladder cancer, if you find neuroendocrine, that's bad. If you today practice, some people have attempted to do immunohistochemistry to replicate this molecular testing on, and they've used a panel of GATA3, CK56 and P16. And to an extent of 60% of the times, they are able to classify tumors as per molecular. They've seen that if you use a GATA3, CK56 and add a P16, you can probably tell them a little about whether they are urothelial type or the genetically unstable type, genomically unstable type or the basal type. But again, in a given case, you may not be able to say that, and that's the drawback of using this immunohistochemistry. Renal cancer is a huge list by the WHO. It's getting more and more, and I think it in the next edition it will be probably 100 more things, because as and when we know about the genetic mutations of these tumors, the list is going to segregate and become into many different types. So the garden variety clear cell carcinoma, it's a VEGF, VHL mutated tumor. The sunitinib, sorafenib have been there for 2 decades for their anti-angiogenic properties. Recently, belzutifan has been given. So belzutifan is a drug which targets the HIF2 alpha pathway. So the VEGF, VHL all lead to hypoxic, and this hypoxia receptors are inhibited by belzutifan. So my point is, this discovery of molecular pathways is going to lead to discovery of different drugs, even for garden variety of tumors. We know that type 2 papillary RCC is not a diagnosis now, it's just a histology. And most of this type 2 histology would fall into all these very aggressive tumors like the FH deficient, which is one of the most aggressive RCCs you can come across. And thankfully, we have some targeted drugs, some response to some targeted therapy like bevacizumab and erlotinib in FH deficient RCCs. So the point here is, as and when the data and the understanding of these tumors matures, we will be forced more and more to pick up these on morphology and IHC. So the life of pathology is going to be easy in some ways, with Dr. Raj saying that AI is going to help us, but at the same time on routine morphology and routine IHC, we will have to pick up more and more things in our practice. So I think I'll quickly finish with the testicular cancer. It's an excellent cancer. No one does too much research on an excellent cancer. So even a stage 3, stage 4, the survival is more than 80% in these cancers. So the amount of research done in this list, but do we have biomarkers to predict early relapses? So these seminomas, non-seminomas, they can come up with huge masses in the retroperitoneum. We all know that. So there are certain microRNAs now, and they are now into almost clinical practice. So microRNA 371A to 3P, you have to really remember these names. But thankfully in TMH also we are going to start this, and we have already got the reagents for this, because we see a lot of testicular cancers which come back with huge recurrences, or sometimes you have a teratoma inside and you don't know. So if it's only residual cancer and relapse patients, this would be markedly raise these markers. Penile cancer classically described into low risk, intermediate risk based on the classification morphology, but now it is very well known and understood that HPV is the core of the pathogenesis of this. So more and more we are employing P16, more and more we are doing HPV testing, because HPV positive penile cancer tumors are more amenable to radiotherapy. So that's being understood more. My point is, all this tissue is a gold mine, and slowly each one of us is going to get this integrated into this pathway of management of these tumors. I would refer you to this one article which a lot of us together have written on optimization of tissue handling, because I think the core issue is this. In India, still we get very bad tissues. The referral tissues from periphery are not well fixed. Once the tissue is badly fixed, the story gets over there for many of us. So these were some opinions which we had an expert consensus meeting, and if this has come in IJMPO very recently, and it's a decently well worked out article in this. So I'll end by saying things are getting very complicated. I sometimes wish we had a friendly woof or a wagging tail. But dogs are known to sniff out prostate cancer, so it would have been very easy if we had something like this which would have told this is cancer, this is for prediction, diagnosis and prognostication. Thank you very much for this. Any questions?
Thank you, Dr. Menon. Questions from the audience?
I think everyone is very hungry, sir.
Yeah. Everybody's hungry, so I'll just make one last comment. You very nicely summarized this. Although bladder and kidney cancer are in the top 10 cancers, the progress in biomarker-associated precision oncology is limited. At the same time, there are two aspects that are very important, and that's because histology is still a very powerful prognostic and predictive factor. You nicely brought that out. In bladder cancer, almost all therapy, cystectomy, neoadjuvant therapy is guided by this. In kidney cancer, even though they're not practicing precision oncology, biomarker-aided precision oncology, histology is guiding precision oncology. So we should not underestimate that in urologic oncology, it is still primarily histology that is driven. And therefore, in the theme of this conference, really the pathologist that is having very good discussion with the oncologists and the urologists is very essential. In fact, some of our clinicians, particularly surgeons, are not as familiar with the importance of the histology. So a clearly very important role, a little slower than the others, but still very important. So thank you, well summarized.
Thank you. Any questions? This one. Mm-hmm. Would respond to antivirals for a finite number of years or time or months. So it's only very rarely you have a de novo small cell carcinoma of the prostate, which obviously requires a completely different line of therapy, which are not ARI small cell.
And may I make one comment on this, just for the audience? So, because unfortunately, I don't think it's a good pattern that the clinicians will say do, synaptophysin program. Because we can recognize neuroendocrine differentiation, small cell, and that's what is really therapeutically relevant. But in the event that your clinicians ask, in the WHO, I think we have put it in, but there is literature in the neuroendocrine classification of prostate cancer, a descriptive entity called prostate cancer with neuroendocrine differentiation by immunohistochemistry. And if your clinician has asked, and you get 1 marker, 2 markers, whatever, even if you get 1 marker, it is neuroendocrine. I would just say prostate cancer with neuroendocrine differentiation, semicolon, most importantly, in capitals if you can, not small cell carcinoma. So long as, because if you took 100 cancers of non-metastatic, 60% are neuroendocrine positive. It gets to about 85% to 90% with high grade. So since they've asked, and now you have to report something, and it's better to at least say with neuroendocrine, but most importantly, in that same breath, say it's not small cell carcinoma.
Yes.
Sorry, so maybe I didn't. Prostate cancer with neuroendocrine differentiation by immunohistochemistry. You have to say that. So there is no cutoff there. 5%, 3%, and we know that the fixation and which clone you use and which neuroendocrine marker is going to, impact what neuroendocrine differentiation there is.
Routinely do this. So you do a marker, you find 10% positive, you write 10%, and then you write bada that this is not a small cell carcinoma. Because you don't want a phone call coming and telling you, is it small cell carcinoma? They will always ask that question. So that's the. Thank you very much. Thank you.
Thank you, Santosh.
Thank you, sir, for the very insightful talk. And now, I'm sorry, delegates, just in half an hour, if you could spare us before going for the lunch. We have 2 talks, 15 minutes each. Are you fine with it? Please, just half an hour. So presently we have Dr. Narendra, who's section head of Agilus Diagnostics Bangalore, who's presenting. And then chairperson for this is Dr. Adarsh Sanikop from Belgaum, who's an oncopathologist. I request Dr. Adarsh and Dr. Narendra.
Afternoon, everybody. So I'll just rush through the cases because I know I can see a lot of many hungry faces here. So, but then I'll just wanted to say before the starting of this session, I'm going to show you a rare scenarios of few common cases, which the common cases in a common region, but then the common case in an unusual site. That's what I'm going to show you a few. and how I approached it and how challenging it was to me. Maybe it may not be as challenging as it to you, but then this is how I, approached the case. So this is the first case, 32-year female, 4 months postpartum. She was having abdominal distension and mild ascites, and scan report showed, ultrasound report showed thickening over the liver surface, and a biopsy was made. So this was the biopsy. So you can see 3 cores of the tissue, and the tumor cells are here. They are all polygonal, round to polygonal with abundant cytoplasm, and there are mildly pleomorphic nuclei with prominent nucleoli, and there are some interspersed neutrophils, lymphocytes, inflammatory cells. So looking at this, it's not looking very high grade. There is no metastatic activity, no necrosis in a postpartum young female. So that was the challenging thing for me, because as you see this morphology, can I have some opinions about what do you think it might be on a real liver surface? On the liver surface. Yes. Yes, very nice. I thought pseudotumor deciduosis, pseudotumor deciduosis, probably that might be the one. HCC was a DD. Again, HCC can be, yeah, it is scary. So the third thing is whether it's of mesothelial origin again, So I started with my CK7, CK20, arginase, glypican-3. So CK7 was positive. CK20, CD10 I did for, the decidualized reaction. ERPR was negative, CD10 was negative. HepAR1 negative, arginase negative, and vimentin was negative. So CK7 positive, it's leaning towards mesothelial. So CK5R6 was positive, calretin was positive, WT1 positive, CK19 was positive. So this was a, epithelioid mesothelioma like thing, or I may call it as a deciduoid mesothelioma, because more of deciduoid morphology was there here, but still I was very reluctant to give it. So I insisted on doing a PET scan, because my clinical information was only on the liver surface. So, but then PET scan, it highlighted that the liver surface nodule, and there was many metabolically active peritoneal deposits along the, various peritoneal surfaces. Okay, so there was no other visceral or skeletal metastasis, no lymphadenopathy, no retroperitoneal or pelvic lymphadenopathy. So this was a malignant deciduoid mesothelioma, quite rare case, usually common in young females. And it's quite aggressive, it has got a bad prognosis compared to other types of mesotheliomas. Okay. So next case is it's a 52-year female, again abdominal distension. CT showed large omental mass with central areas of necrosis. See, most of the cases come from the periphery. We work as both in-house and as a diagnostic, referral diagnostics too. So in-house it's easy to get the details, but when it comes to from the periphery, it's quite difficult to get the details. So these were the fragments of tissues sent to me. So you can see they are all, low-grade monomorphic cells. Again, low-grade monomorphic cells, round to oval nucleus, indistinct cytoplasm. Plasma, yeah, nice. There is a rosette formation. So 52-year, yes, very, it was quite evident that rosettes. So now, any DDs at this point of time. So I too was, in a condition where what to call this as, with such rosettes, can it be a small round cell tumor? Any other mesothelial tumor which is presenting like this. So I just called the clinician, asked for the history. She had a hysterectomy done and bilateral salpingoalpectomy for fibroid 3 years back, and I wanted ovary. What is the ovary? There was no ovarian tumor, no ovarian pathology was seen. So I started with pan-CK, vimentin. Pan-CK was focally positive, vimentin was positive. CD56, CD99 was strongly positive, and WT1 was positive. So, sorry? No. Okay, fine. DSRCT morphology is quite different actually. It will be coming in nodules, lot of desmoplastic reaction. It will be mimicking a small round cell tumor. This is not as aggressive as, it's not as aggressive as DSRCT, morphologically at least. So only thing was those rosettes, those microfollicles, that was bothering me. They're all call-exner bodies, they are actually. So I wanted to rule out the previous histopathology report of the hysterectomy specimen. There was no ovarian. So, but then this morphology and IHC showing CD56, CD99, WT1 was positive. WT1 can be positive in both mesothelioma or granular cell tumor. So just to differentiate those things, I did calretinine, inhibin. So calretin again positive in both, but inhibin positive in granular cell tumor, but negative in the mesothelioma. So this one, again, I did other markers. Paxite was negative, CK56 to rule out mesothelioma negative, NKX 2.2 for Ewing's or Ewing's family tumors, CK dog 1, any again extra GI GIST, lot of morphological variants are there for GIST, so just mandated to rule out. Fly 1 again was negative. So this was an extra ovarian granulosa cell tumor. Okay. So the third case, again, this is a 25-year male. It's a known case of C ascending colon and cecum, poorly differentiated adenocarcinoma of the diagnosis. And the patient underwent right hemicolectomy and post-hoc chemotherapy 1 year back. Now present with the right iliac fossa mass, query recurrence. So these were the biopsy bits. So here, it's all scattered, the tumor tissue. If you see the tumor, again, no distinct cell borders, moderate cytoplasm, pleomorphic nuclei here and there, bizarre nuclei. The cytoplasm, again, if you see, they are clear, vacuolated, and these are the, if you observe, there was some kind of eosinophilic bodies. Okay. So, again, this was, I started with CK720, SAT-B2 and CDX2B. Being there was a history of colonic adenocarcinoma. There was necrosis also. So CK7 was only focally positive, CK20 negative, CDX2 was quite strongly positive, but SAT-B2 was negative. Now, pancreatobiliary? No, 7 is focally positive. Pancreatobiliary will be CK719, very strongly positive. So again, I was scratching my head. SAT-B2 was negative, CDX2 positive, CK20 was not as strong as it should be in a colonic adenocarcinoma. So young age, the morphology was not very neuroendocrine like, it wasn't like a neuroendocrine. There was polymorphic cells with a lot of pleomorphic bizarre nuclei, and young patient always rule out germ cell. Yeah, SAL4 was positive, glypican 3 AFP was positive, P63 was focally positive, and all other markers C8, CD30, beta CG, OCT34 and SAT-B2 were negative. So again, I was wondering whether it's recurrence of is it a new tumor or recurrence of the old tumor? Is there a testicular tumor present? Is there a retroperitoneal tumor present anywhere? So again, I asked for an ultrasound and PET CT. So no tumor in the testis, no metabolic active lesions anywhere. So this was actually a primary colonic germ cell tumor, yolk sac tumor. Serum AFP was elevated. Agreed. Agreed, but what about CK2720 negativity, SAL4 positivity, SAL4 positivity? CDX2 can come positive in any GI origin tumors, ma'am. It can come positive in any GI origin tumors. Any GI origin germ cell tumor, it can come positive. Any GI origin tumor, it can come. Even in germ cell tumor, it is CDX2 is positive actually. It can be positive. 1 year, 1 year back, 1 year back. I really don't know how big it is tumor, but
hepatoid variant or sometime even
the previous biopsy also.
Like you get in gastric, like we get in ovary, we get it in endometrium, and all it has been described in anywhere in the body. So we need to I mean, before we write a germ cell tumor, we need to say that.
Even the
So-
previous biopsy has to be looked into.
Yes.
No, previous biopsy, that's what. This was a Bangladeshi patient. There it was treated. It was quite difficult to get it. But then, with the available clinical details, with the available morphological features, with the available IHC features, this is the diagnosis.
Yes,
but
that
then
is a wonderful
you-
observation.
Yeah, but then, if you have any other comments, what can you call this, man?
No, I will call, since I have this history of adenocarcinoma just a year ago, and that too in a very young person, I will put in this caveat that we need to examine more tissue to exclude an adenocarcinoma with such kind of differentiation. Yes.
Were these markers performed on the initial?
No, not. It is a new tissue which had come.
You didn't have the...
No, it was a Bangladeshi patient actually. So obviously it was difficult to obtain those things. But then in-house I could get the AFP tumor markers. AFP was raised. SAL4 was positive. AFP glypican 3 is positive. CK7, CK20, SADB2 is negative. Nothing. SAG was negative. No.
Can be seen in various
Hepatoid?
We had this patient,
Okay.
69-year-old, her alpha-fetoprotein.
But wasn't looking like a hepatoid morphology?
Yes.
No, ma'am. It wasn't looking like hepatoid morphology. I'll show you the morphology once again. See?
Polygonal with a
Mm, it's more like, these, if you observe, there were some globules also. Okay? And it looks like yolk sac tumor for me, morphologically more. Okay. Sorry? No, but I didn't do arginase here. I didn't think of liver cancer or anything else. This was because the young patient, I jumped into SAL4. CK7, CK20 was negative. Yeah. Why there wasn't any liver tumor? Why? Hepatoid adenocarcinoma. So hepatoid adenocarcinoma, HEPAR1 will be positive as such, HEPAR1 arginase will be positive. But then what about SAL4 and all the tumor markers will be raised?
Yes, AFP will be raised.
Oh, this is a new information to me. But then morphologically also, I didn't think it as a hepatoid adenocarcinoma.
AFP can be raised not only with hepatoid differentiation or with yolk sac differentiation when a tumor has an infantile intestinal differentiation also, then also the AFP.
Agreed, ma'am. Hepatoid adenocarcinoma, I have reported in a gallbladder cancer. Gallbladder actually shows hepatoid adenocarcinoma. What you have said, you agreed. But then this particular tumor, I didn't feel it as hepatoid. Okay. Morphologically, I didn't feel it as hepatoid. Yeah. So for me, this was a primary colonic germ cell tumor. So yolk sac tumor. So the other thing, other case is a 49-year male. So ulceral proliferative tumor in the transverse colon. And segment colectomy with adherent jejunum was sent. So this is the transverse colon, mucosal surface. This is the tumor, ulceroproliferative, and this is the jejunal surface. There was no tumor in the jejunum, but then it appears as if it's arising from the jejunal wall and infiltrating the transverse colon. Okay. So here, here this will be the jejunal mucosa, and the tumor is in the jejunal serosa. So this tumor, it was showing kind of nodules and diffuse sheets, and there was also a pseudopapillary pattern. And here again, they were all not very high grade, low grade monotonous tumors, and there was associated, these giant cells were there. So pseudopapillary tumor, pseudopapillary morphology was there. So any inputs here? Sorry? GIST could be ruled out. Okay, GIST, then SIK, okay. SIKIT, DOG1, PAN-CK, SMA and DESPIN, all four were negative. So if you know where these osteoclast type of giant cells comes, then I think that can give you the clue. SNRide was positive, SOX10 was positive, Synapto was patchily positive. SIKIT, DOG1, PAN-CK, chromogranin, HMB45, Melania, SMB, DESPIN were negative. So this is a malignant GI neuroectodermal tumor. Okay. GAN, yeah. Yes. So here synapto can be positive, chromo will be negative, SN-RED will be positive, SOX10 will be positive, HMB45 melanoma will be negative, closed read will be a clear cell sarcoma, okay, or metastatic melanoma, so that has to be ruled out. Okay, and GIST, of course, it has to be ruled out. So this is also a very aggressive tumor. Sir?
It won't show that strong as 100.
MPNST actually loses the SN-RED, except in epitheloid NPST where it shows diffusion. It wasn't very epithelioid actually, it's more of oval and spindle shaped. Okay. And EDOPLOSR one was done, and it showed, there was the translocation of EDOPLOSR. So case 5, 45-year male, pain in the abdomen, endoscopic submucosal mass in the stomach. So this was quite, I got very small bits like this, and there were this again low-grade tumor. You can see they are all kind of plasmacytoid to oval, and there was no distinct cell borders, low nuclear grade, and there was some hyalinized blood vessels in between. Okay. So now, what markers you want to start with? Or any morphological DDs? Gastric? Yes, gastric submucosal lesion. हाई पावर तो नहीं है मैम, उतना ही है अभी तो जूम करना पड़ेगा आपको Yeah, great. Neuroendocrine morphology was there. Yeah, well, first thing is neuroendocrine, low grade. Again, just, any morphological presentation can be there. So CK dog 1 was negative, synapta was positive, chromogranin was negative. Now, no, I don't have INSM1. Even let's consider INSM1 as negative. 56 negative. Okay. SMA was positive, HCAL-Desmin was positive, Desmin was negative. Yes. So it's so CD34 was negative, CD56, SN-RED, PAN-CK, Desmin, they were all negative. So this was a glomus tumor, and excision biopsy came. So yeah, this was a submucosal tumor. So whenever synapto comes positive, not to jump to neuroendocrine. Okay. So synapto again, this was excision specimen. Synapto was positive, SMA positive, 34 negative, chromogranin negative, HCAL-Desmin mosquito, gastric glomus. Right. Okay, thank you all. Thank you. Thank you for the participation.
Interesting cases.
Sorry? Most exciting. Thank you. I was hoping that to keep you occupied, in this lunch, free lunch hours. Thank you so much. Any other doubts, any other question, except that third case or fourth case, whatever. Otherwise, everything fine. Thank you.
Thank you, Dr. Narendra.
I think there is a request to finish another small talk before we break. Yeah. So the next talk, because Dr. Hazarika is also waiting, so we'll go on to the next talk. It is D-Dish for HER2, the new kid on the block. The talk is a virtual talk by Dr. Tanuja Sheth. She is a consultant oncopathologist from Tata Memorial. The chair for the session is Dr. Hazarika. Dr. Hazarika is a senior consultant histopathologist from Healthcare Global. Dr. Hazarika, please.
All, at the onset, I would like to thank Fortis hospitals and organizations for inviting me to this webinar. And I'm sorry I could not be there in person to attend the meeting. This topic is very exciting for me. So I've been asked to talk about D-Dish for HER2 testing in breast cancer. And the thing about science is, by the time you say something is new, it's already old. So this new kid is already in practice in Tata Memorial Hospital, and I'm here to share our experience with it. So the plan of discussion is to first do the introduction. Why we prefer D-Dish over fish? What is the principal interpretation? I would like to share our experience with D-Dish, the diagnostic workflow that we use in Tata Hospital for D-dish, and finally the conclusion. So all of you here know that breast cancer is to all patients with breast cancer get a HER2. Why? Because we've seen a 13 to 15% improvement in survival with anti-HER2 targeted therapy. This is applicable for locally advanced breast cancer as well as metastatic cancers and even early breast cancer. And hence, the mandate is to test HER2 on all breast cancers with that come to your laboratory. Now, all of you know that for positivity, we consider strong membrane complete staining in greater than 10% of the cells as positive. And for fish, we say anything greater than 6. So basically, fish, we use dual fish, where the HER2 is labeled with one probe and the CEP17 is labeled with another probe. So the HER2 signals greater than 6 and a ratio is considered amplified. If you're looking at the ratio as well as the HER2 signals, then a ratio of greater than 2 and a HER2 of greater than 4 is considered as amplified. So this is the algorithm. All of you already are practicing it, that in India, we only fish the equivocal cases or dish the equivocal cases. Now, the problem that with people who are practicing fish will understand is that the fish signals fade over time. It requires a unique molecular diagnostic facility. Sometimes it becomes, as I get older, I'm finding fish more difficult because your focusing becomes a challenge and it takes a long turnaround time and sometimes tissue fluorescence interferes with it. As opposed to that in D-dish, the signals are permanent and the beauty of it is that it can be done in an automated immunohistochemistry machine like Benchmark, X3 or ALTA and bright field. The light that it brings is phenomenal. So you can actually have your tissue morphology along with the HER2 gene status. It picks up heterogeneity much better than the dart in the dark of fish. And it is fully automated. Your TAT is only 6 to 7 hours. There is no interference from tissue autofluorescence. However, fish is patterns like co-amplification of CEP17 and HER2. On the other hand, D-dish is highly dependent on pre-analytical factors. So you need water conductivity is one of the biggest nightmares. It requires slightly more training as far as one of the most common errors of false positive, whereas pseudo-polysemy is one of the commonest causes of false negative. Because your CEP17 is overcounted in D-dish, often the ratios come down. So this is the Ventana HER2 D-dish cocktail, which has been approved by the US FDA. Now, essentially what we do is we use labels that can be seen under bright field. So the label that is used for HER2 is dinitrophenol, and the reduction or the substrate which reduces that label is silver, and hence HER2 signals are black. For the CEP17, we use deoxygenin, which is a plant-based label, and it has a very good specificity and it has very short TAT. And because of that, the color, and you use naphthol red as a substrate, and that's why the signals for CEP17 are red. Now, we always do the chromosome 17, HER2 testing first. So we reduce the silver first because you cannot, silver is often produces non-specific reactions, so you don't want that. And that's why we do the chromosome HER2 first, because it's a dual fish. First we complete this run and then we move on to the CEP17 run. So the black enters first and then the red. Now, prerequisites for a good D-dish are fixation, because under, over or delayed fixation, the same nightmare that we face in immunohistochemistry occurs even in D-dish, and hence we can't get away with good pathology practice. You have to implement them. The machine decontamination, low water conductivity, things that are also for impact immunochemistry, because it is done on an IHC machine, these impact D-dish as well. The section thickness is very critical. The test has been standardized for 4 micron, so don't be overzealous, don't do it on 1 micron, and don't be sloppy and do it on 10 micron. The same validation protocol that you use for usual fish, you can use. The controls that we have to use are the same as that we use for fish. Now this is just to show you a -1 plus IHC. This is fish. We use, in our hospital, we use zytoprobe. So the green generally represents HER2 and the red generally represents chromosome 17. So this is a dual fish, and you can see green and red. This is a D dish where the black is the HER2 and the red is CEP17, and you can see similar results. This is an amplified HER2 where you can see IHC score 3+. You can see that on the fish, the green is in clumps because it's so much excess of HER2 is there, and that's your amplified HER2 by fish. And the same clumping is seen with the silver dust because the silver is labeling the HER2, and that's the D dish amplified for you. So interpretation of D dash is, the wonder of it is we do it on a 60x objective, but if you don't have a 60x, you can do it on a 100x as well. Now, 20 cell count only is enough, but there are certain errors that if you don't count slides that have more than 25% signals missing, or if you have empty nuclei and only say one red or black, don't count it. Slides greater than 10% of the signals outside should not be counted. Now, these are same pictorial depictions of the same events, that you have to have separate black, which is HER2, and separate red, which is chromosome 17. As I said, that if you don't have anything, don't count. If you have only one signal, don't count. If you have signals outside, don't count. If you have a doublet, that is two black signals, don't count. But you have a black and red, because you can see the difference between the two, you can count them as two different signals. The biggest problem is that when you have amplifications, you see this little balls of clusters. Now, when there are smaller clusters, you count as 6. When there are larger clusters, you count as 12. If you have a black and red next to each other, you can count them separately. But if you have two blacks, count them as 1. Don't count the silver dust, don't count the red signals. Now, the problem is, why are we struggling? D-dish was introduced in Europe way back in early the 2010, etc., and it's been used very widely. So what is the overall concordance? It's very easy to do, but what is the concordance with fish, which is the gold standard? So the thing is that concordance varies according to two things. Now, number one is test cohort. So if I'm using all comers, that means positives, negatives, and equivocals, and my concordance is very high because obviously there are no complex cases there. But if I'm using a cohort of only equivocal cases and doing D-dish and fish comparison in them, then my discordance increases, because you already equivocal means that there is genetic complexity, and in that you are looking at concordance, that concordance is going to fall. Concordance was better in the new probe. I'll share our experience. The older probe that was launched way back in 2017, that has lesser concordance. And our guidelines, they keep changing. So 2013 had poor concordance with D-dish. So let's look at some of these studies that have been done. So you can see this study, all comers, 94% concordance. The concordance has always been above 90 in studies that are all comers. And you can see that only one odd case, there's a real discordance. In the Mayo Clinic study, they took all genetically complex cases, and what they found, very low concordance rate, only 64% concordance. And there was a lot of hodgepodge there, but what you can make out is that both were right and wrong. That means it is not that D-dish only was wrong, but in these equivocal cases, you have to be super careful, because D-dish might miss out some part of the HER2 amplified cases. So that's the moral of the story here. So this is our study that we did way back in 2017. I was not very happy with it, and that's the reason it found, we didn't send it for any international journal. We sent it to an Indian journal just to document that we did D-dish. But concordance rate was fantastic, but what was the problem was that silver, so you have three aspects of D-dish. You have the ratio, the test result, the ratio, the chromosome 17 count, and the CEP17 count. Now, fantastic concordance we observe for the test result, very good concordance for the HER2 gene copy number, but the CEP17 and the polysomy showed very poor concordance. So as I said, we had relatively moderate strength of agreement for HER2 chromosome 17 ratios, and poor concordance for only CEP17 signal. So what it told us, that between that you don't have very, so if I fish the results and D-dish results, that is the maximum discordance occurs in the chromosome 17 counting. So this is our result from that. As I said, two cases were, we called it false positives because we counted black dust. And many cases were called false negatives mainly because of genomic heterogeneity. So these are the just slides from that. Now here comes our latest study. So as I said, I was always wanted to have fish in our leadership in our clinical practice. So when the Roche team got approval for the new kit in 2020, then we decided to do this study, and this is our latest publication, which has been published now in archives. That the reason it found its place in archives is a huge effort on the behalf of our resident Dr. Aditi. And the objective was that the first study I did with Pooja, and we only two of us were comfortable with the test. The objective of this study was, are all pathologists comfortable reporting, and then we can apply in clinical practice. So this study was led by Dr. Sangeeta Desai and Aditi, and what we did was 148 breast cancer cases with HER2 known. We all of us interpreted 148 cases IHC, FISH, DDISH, and then in a blinded manner, and then we saw the concordance rates. So fantastic concordance, only 2 out of 148 there was a discordance between DDISH and FISH. If you look at the major test result, for the positives 100%, negatives 100% concordance between DDISH and FISH. For the positives also fairly good concordance, but the discordance only occurred in the equivocal area. So sensitivity of 96.36% and specificity of 100%, a positive predictive value of 100, and an accuracy as high as 98.65%. Now, as I said, the concordance for in the amplified cases, there was almost very good, non-amplified was better concordance than the amplified cases. And for the average HER2 signals in this study was 0.97, that means 97%. And for SEP17, it was 92%. Now, what about inter-observer variation? Because, pathologists come in different kinds. They are bold, they are shy, they are very good. So, depending on that, and we have all these personalities in Tata Memorial Hospital, and you can see that whatever we are, our HER2 status never changed. We did have a little variation in the reporting of polysomy, where we had moderate to substantial agreement, and you had moderate to substantial agreement in genomic heterogeneity as well. Now, these are the two discordant cases. You can see that this was a HER2. Actually, as I said, I'm the bold pathologist here. I would not ask for FISH. I would call this straight away 3+ ampli on IHC. But if you have not called it 3+, then you know it is going to be amplified. But lo and behold, it was negative on FISH, and when we did DDISH, it was amplified. So this was picked up by DDISH accurately. The second case was like this, and it was actually reported as non-amplified on DDISH, but it was amplified on FISH. This was a low borderline amplified HER2. Now, look, coming to the inter-observer variability, in the non-amplified cases, our HER2 signals were perfectly aligned. In the amplified cases, somewhere I used to say 10 average HER2, somebody used to call it 15. There was a little bit more variation. You see, the top part of the normal was not very concordant, but we still had fair concordance. And so this is the same thing in the non-amplified cases. So are we ready for DDD in Newton Pascal? I said, of course, but you should understand. So I will quote the study. Now this institute has been doing DDISH for 5 years. They went back and did FISH now on all their cases, around 273 cases. And they saw, okay, let's see where we made a wrong. So the report had already gone. And they found 13 discrepant cases out of 273, which makes around 7, it makes 13%. And in either ways, one of the tests was wrong or one of the tests was right. And what are the problems with DDISH? That if you count signals outside of the nucleus, you end up calling it as a false positive. The silver dust is a major nightmare still. It's better today, but it's still there. And one interesting thing is, lymphocytes swell up in DDISH. So they sometimes mimic tumor cells, and many pathologists count them as tumor cells. So they go as non-amplified cells mixed with amplified cells. So that's the important part of DDISH that we need to understand. So this is just to give you samples from that study. You can see that this was actually should have been called as false or uninterpretable. But because there were only red signal, there was no black. But somebody went and reported it, and actually they were amplified because the chromosomes, the HER2 was not picked up in this, and that was a nicely amplified HER2 on the FISH. So this is a problem that you have to understand, that you don't see black, in fact focus on the black, because that's what gets the patient the targeted therapy. So here are the examples of the dust being counted as falsely positive, and actually it was frankly negative on fish. So these are the examples that a pathologist needs to train themselves, and if that problem is solved, then we are good. Now, the general issues with D-dish they share with fish is chromosomal aberrations and genomic heterogeneity. So, as per the ASCO guidelines, a ratio less than 2 and an average HER2 less than 4 is clearly negative. A ratio greater than 2 and an average HER2 greater than 4 is clearly positive. Now, there's a group of these three in between. Now, in the current guideline, and even if your ratio is greater than 2, your HER2 less than 4 makes it non-amplified, whereas in the 2013 it was called as positive. Now, what we know today is that in these three groups, there's anyway a little bit of problem. So, there is a monosomy type of amplification where the ratio appears good because the CEP17 is missing, and that's why you get a falsely haploid. Today, we call monosomy amplification as negative. And you have a second situation where you have, because the chromosome 17 is high, the ratio comes down. So and it falls into one of these categories, either so if the average HER2 per nucleus is 6, it is amplified irrespective of the ratio. But if it comes between 4 to 6, that's the problem that occurs in most fish interpretations. This is a monosomy. You can see most of the greens are missing here. This is an older group. Now here is a polysomy. You can see the polysomy is in the green signals. The green signals are the CEP17 signals, and you can see a lot of green here masking the red. And there have been studies to address whether polysomy patients, how do they behave? Yes, they behave very aggressively, but they don't respond to the HER2 new drug the same way as an amplified HER2. So today we don't treat polysomy in HER2. So if you have polysomy, what do? You don't look at the ratio, because you know your ratio will get messed up. Look at the HER2 gene number. So if it's less than 4 negative, greater than 6 positive, between 4 to 6, you look at the immunohistochemistry. If the immunohistochemistry is negative, negative. If it's positive, positive. If it's equivocal, that's where the problem occurs, that you need to do it on a different block, a metastatic node, or you write a caveat in your report that this is the problem with the dish and repeat it on a different specimen. The second issue is of genomic heterogeneity. Genomic heterogeneity is of two types. You can have cluster type of heterogeneity where you have clusters of amplified cells mixed with non-amplified cells. Clearly, this cluster of cell has a survival advantage. So this is an omnious type of cluster heterogeneity. This has to be targeted. The other type of cluster heterogeneity is intermixed or scattered type, where singly scattered amplified cells are mixed with non-amplified cells. Now this is not really significant because this will follow the pattern of a normal HER2. That means you count all cells together, and what your final count comes you give. Whereas if you have this type of cluster heterogeneity, you count the cluster amplification in the clustered area differently from the non-clustered area, and you decide whether this is amplified and not accordingly. The reason being that if I count all this, then the ratio will still come non-amplified, whereas there is a nice group of amplified cell here. So what is the definition of tumor heterogeneity? When you have cancers with between 5 to 50% amplified cells, and the cutoff of 10%, anything above, if in a tumor you have greater than 10% of cells that are amplified, irrespective of whatever, you have to call it as amplified. Genomic heterogeneity is associated with generally a ER positive association and a very poor prognosis. So if you have genomic heterogeneity, you can't only count 20 cells and stop. We generally count at least 60 cells, but more than that. If it is intermixed type, you count continuous cells, 1, 2, 3, 4, 5, and if you get an amplified cell in between, fair enough. You go, and if the ratio comes out greater than 2, and the average HER2 is greater than 6, you have an amplified situation. Ratio comes out less than 2, average HER2 is less than 6, you are generally HER2 negative. And of course, 4 to 6 is a different event. I have not listed that here. In the cluster, count the amplified and the non-amplified separately. If you have less than 10% of the cells and the ratios that are non-amplified, or the ratios that are close to amplified, you test it on different blocks. Whereas, if you have greater than 10% amplified cells, then you straight away call it HER2 positive. So what is the diagnostic workflow for D-dish in TMH? Now, very clear that we do it only for equivocal. Now, unfortunately, unfortunately, in Tata Hospital, the patient, we don't do, all equivocals don't go for D-dish testing. That has been my dream. But what we do is we wait for the surgeon or the patient or the oncologist to pay for the test. Then we raise a requisition for D-dish. In 2 to 4 days, the D-dish is reported as per the ASCO-CAP guidelines. And in some cases, we reflex test with fish. Now, patient is not charged for fish because this is the complexity of the case, and we have taken into account the charges of that additional testing for fish within our D-dish charges. So, around 9% of our D-dish get converted into fish testing concurrently. Now, what is the approach? As pathologist, when I see an average HER2 of less than 4 and ratio of less than 2, I'm not worried. IHC is also fine, I'm not worried. If the IHC is positive, the ratio also comes amplified, I'm not worried. But if the IHC is positive and my ratio comes close to not being amplified, then I worry. And this was the dish in a case, it was non-amplified. We repeated by fish and it came amplified. So these are the cases where the average HER2 is between 4 to 6 and the ratio is less than 2. Those are the group that we clearly send for fish testing. So whenever you have situation like this, we check histology. We are very thankful that we have 4 colleagues in breast pathology. 4 of us count, not 4, but at least 2 of us count. We have a discussion with each other. We test on 2 different blocks and we always correlate with clinical presentation. If all of this plays, then we ask for fish, and if that fish also fails, we ask for repeat biopsy or repeat testing on an excision specimen. So our clinicians are very happy when we have, since we have introduced D-dish, because in 4 days they can start planning chemotherapy, especially port insertions and all the problems that are associated with HER2 positive breast cancer. And this is our data for the last year, and you can see a total of 820 cases. We've sent this also for publication. That if you see that only 9% of the D-dish went for fish, and most commonly it was because either the signals didn't work, and in 8 cases there was a true problem, and that is 11 cases there were true problem. What was the true problem? That in 2 cases the IHC was strong, but the D-dish was amplified, and when we repeated by fish, the fish came amplified. 3 cases were falling into the group 4 and 2, the typical category, and even on fish, the results came the same. So only in 1 case actually repeating helped, but 1 in 24, but nevertheless, it is worth the try. So here's an example. This is a post-NSCT breast cancer patient, and you can see an equivocal HER2 here. The D-dish didn't work, but we repeated by fish and it was nicely negative. But in this patient, there was another liver biopsy. So what we did was we also tested the liver biopsy, and we found in that liver biopsy both amplified and non-amplified areas. So this case actually taught us that not to stop only at 1 test and being happy with it, especially if it's negative. Give the patient the benefit of doubt and see if there's any other material available with you. This is a very recent case. Now this was a 42-year-old with locally advanced breast cancer. So, the decision HER2 is very critical because whether to add the HER2 or not. Now this was the IHC. Now as I said, both pathologists, weak pathologists, all of us call it equivocal. But I worry about this kind of strong staining of HER2. So I got worried and then gave the D-dish. Now the D-dish did show you, mind you, increased signals, you can see. But what was the problem was, you can see signals outside and you saw a lot of red. So the red was complicating the matter of ratio. So you can see, when I counted, the HER2 was 4.9 per nucleus, but the ratio was coming at 1.3. And this is a very typical example where we did retest by fish. It was counted by 3 observer and 200 cells. These are different images from each of these counting. And the similar kind of result was seen amongst all 3 of us together. So, but we all agreed that this looks amplified, so we need to repeat it. And this was the fish. The fish came frankly amplified because the ratio now was better. And hence, the HER2 also was a little better. So, these are the kind of impact cases that we do repeat on by fish. So to conclude, DDs is a very easy test, can be implemented widely in India since Ventana platforms are now increasingly available. It can be implemented in all centers even without, because I think HER2 molecular test is everybody's requirement. So you can implement it without having a MolPath lab as it were. But the error rate is slightly higher, and what I have learned is it takes a little training time. I don't know whether because I'm old, But I think it took me a while to get to use, not me, all of us getting to used to dish. Whereas fish, you start from day one and you pick it up very easily. And hence make sure that you see more cases before you release it into clinical practice. The cost versus that benefit, I think, is fantastic. And the way today the fish costs have come down, but day dish is not yet that cheap. But the tat, I think, is a beautiful benefit, and the bright field benefit of it is enough light in our lives to make its way into routine diagnosis. So as I said, any test requires training. So I will not say I failed 1,000 times, but I'll say that I discovered 1,000 ways that can cause failure. So thank you to all of you. Good afternoon to all. At the onset, I would like to thank Fortis Hospitals and organize.
I think you can close the thing. And I'm so sorry to missing this beautiful meeting. I was also listening to the slide seminar earlier, and I was itching to be in the audience there. So thank you, Fortis Hospital and Cancer Summit for inviting me. So I'll be happy to take any questions.
Anyone has any questions?
So I asked, are you looking for a commercial algo for this? You understand my question?
So you are saying that is there a commercial algorithm? I think
no, it is available now. Even Ross also making.
Acha, you mean digital ways?
Yeah, digital.
Yeah, of course. One of Sangeeta's students, Dr. Sangeeta Desai, is heavily into digital pathology, and her student is looking at the digital algorithm. But I'll just tell you my experience with most algorithms. The problem is that in the hands, experienced people. Can you hear me?
Yeah.
So experienced people find algorithms difficult because they are better than the algorithms. But in the hands of a novice, the algorithm will be better to train them and for them to understand. So algorithms, I think, are a very good step for beginners, where you don't have, like, we did a study and we got that experience. Whereas if you don't have that kind of resource material available, you can use an algorithm to kind of train yourself. Okay, this is how it works. And then you can start reporting. Algorithms are wonderful, but for us in Tata, like for me, DDish is very fast today. So and I'm not a very good agile digital pathologist. So for me to select those areas, count them and all, for me, I do the same thing much faster under the microscope. So it depends on what your original personality. So for me, I would go by the manual way, but many pathologists committed to digital pathology, I think they find algorithm fantastic.
And one more question, like this whole thing is roaming around this precision medicine, and HER2 law is coming very big way. So do you see any update will coming in the 2018 update?
The update is already released in 2023. The ASMO released its guideline for HER2 low, and the European group has released. So the only thing they say is that to understand HER2 low, one thing you must remember is that the HER2 low has to, like, if you have a DECO platform on which HER2 has been reported as 1+, you can't call it HER2 low because it has not been tested in the same manner. So we need to understand that HER2 low is under that Destiny 4 clinical trial banner, where it was tested in a particular manner and they defined that 1+ category. So those of us with Ventana machines can definitely report, and the Ventana benchmark XT reports are still valid today. But those of us who have shifted to Ultra, the standard time that we use in an Ultra for reporting HER2 low is different. So just a word of advice that HER2 low is here to stay. TDX1 is already in the Indian market. It's exorbitant and beyond exorbitant. But I'm sure the biosimilars will be launched, and tomorrow we will be dealing with this HER2 low. So I think it's time. Number one, there has to be a revision under the ASCO-CAP guidelines, which is already done in a small paper, but they have not specified. They have used the Destiny trial criteria only. So that's number one. We need to have some additional tests like molecular, which is added to quantify the mRNA of HER2, to understand the copy numbers, and because you can't have an amplified HER2, it has to be between normal and amplified. So that has to be defined in larger studies. And I think we should be good to go. And
the IHC that kits we do today, they are targeting the amplified HER2. They're not, because you know that the amplification represents the number of receptors that are there on the surface. So you need, what the IHC today is speaking of is more than 2 million receptors per cell. What we need is between 20 to 50,000 receptors per 500,000 receptors for HER2 low. So defining this in a IHC algorithm is the need of the hour, and I'm sure the ASCO-CAP is working on it. But as of today, we are using HER2 low. Clinicians have started the drug without understanding all the nuances.
Then what next then? Like something you might be knowing.
No HER2.
No HER2, not the technique.
TDX.
Like a multiplex.
Yesterday we were, actually I was in Bangalore yesterday. I flew back in the night because I had a talk today. So there was a panel on the same matter, and the clinician said that don't worry, tomorrow even in negative HER2 we'll give TDX2. So, you know, I think it will be the mRNA quantification. I think molecular tests will come into routine practice. I think we will need, I don't know, mass spec or ddPCR, whatever, to define the quantities of HER2. And above that particular quantity, like the 429 HER2 above per nanogram is the current defined DDH cutoff. We are also working on something like this, but I think in a year or so we'll come to know our TMH data, but that will need to be defined. We need to define how much HER2 is required for TDXD to add, trastuzumab deruxtecan to add, and or N-HER2.
Okay. Thank you, madam. And it was a very lucid presentation, very informative. So no more question, I think.
Thank you so much, Dr. Hazarika, and thank you so much, Dr. Tanuja, for the fantastic talk and a great discussion which happened. So now we break for the lunch, and post that there's a workshop.
I would really like to thank all of you who have stayed back, and it's not with everybody being out, you know, trying to be a part of the conference. I think it takes passion for real science to be here. And we have a very interesting workshop on fish, which is hands-on post the lunch sessions. It's sponsored by Path Institute, and Dr. Shilpa Prabhu Desai and Dr. Vinita Pandey would be the course chairs. So I hope, you know, we have good lunch and all of us get back here soon. Thank you. Thank you, Dr. Sunit. You've been really wonderful. Thank you.
कोई फोटो लिया
normally when we complete an event and come, there will always be one minor hiccup, one this thing could have been done better and all those things. Surprisingly, I am seeing that it is overwhelmingly positive. Nobody has a single concern, and when I was standing in the lobby, people are walking up to me and saying, "Thank you, this was really nice." And this is a consequence of the efforts all of you have put in at every step and months of effort. So we hope that this will continue, and we should also get the international doctors to start referring to us. Fortis Bangalore was probably one of the 20 options that they had. Now it should be that one option that they send because they know the kind of work we do. Right? Great.
And this is not only one of the again, we came together as a team. Oncology is growing, right? That is the reason why we have kept this conference. So every hospital has the potential to like get that a specific business in terms of oncology, right? If you're doing 40 lakhs, there's scope of 80 lakhs. If you're doing 5 crores, there's scope of 10 crores. There's huge scope in oncology. That is the reason why we showcase this today. So think on those lines, right? If one specialty can add revenue, get that additional revenue for you, oncology is a specialty. We'll announce the date of the party. We'll let you all know. And let's come together. Thank you.
Thank you. No comp off because it was good fun. Thank you. Live stream in it.
Yeah, hi, very good afternoon. I know this is the wrong time to start a session. All the blood is flowing to the GI and very less to the brain. So this workshop is being conducted by Path and Saitu along with two of us, Dr. Vinita Pandey, that's me, and Dr. Shilpa Prabhudesai, my colleague. And we are here from Center of Oncopath, Mumbai. So we'll be talking about HER2 new testing basically and fish testing. So basically first we'll start with the clinical implications. What is HER2 new testing? When should you test? Why should you test? And why not should you test? You know, so it is, and as most of you know that it started with breast in 84, like long back, but now it is in so many solid tumors. And breast is the only tumor, and then GI, where we know the guidelines. Rest of them, we are always confused and we don't know what to report. So where should we actually focus on and play, what is important? So what is HER2 receptor? So HER2 is basically, it's called an orphan tyrosine kinase. That's because it does not have a ligand. So what happens is that when it dimerizes, it starts a chain reaction of tyrosine kinase, and that's how the cell cycle, cell proliferation starts. Dimerization is what causes. So two HER receptors come together and they form HER2. There is also HER3, there is also HER4. And one important thing to remember is when we talk about HER2 in tumors, we are not just talking about HER2 amplification, we are also talking about HER2 mutations. Now, we are testing HER2 amplification by FISH, but so many other solid tumors also show HER2 point mutations. So how did HER2 gain the the celebrity status that it did? Because it could be used as a target for a drug called trastuzumab, and trastuzumab was the first thing to come up, and now we have so many other drugs that are against this HER2 receptor. And there's also this concept of HER2 low that has come in, where HER2 amplification is not what they are looking at. They're just looking at HER2 protein expression. They are combining trastuzumab with another cytotoxic drug, and they're using HER2 as a vehicle for that cytotoxic drug to enter the cell. So a lot of changes in that front. These are the organ systems where HER2 has become important. That is breast, gastroesophageal, of course. These two we are doing day in and day out. Colorectal and lung. And recently we had few requisitions of head and neck squamous carcinomas, also somebody asking for HER2. So now let's start with the main one, that the bread and butter, that is the breast. So what is the treatment algorithm? So basically for all these hormone receptors or HER2, the basic thing is whether to give adjuvant or not. So this is the basic algorithm. So we have divided the tumors in these molecular subtypes, and depending on that, either the patient, if it's not a very small tumor, the patient either requires, if it's not a T less than 0.5, the patient either requires a hormone therapy or a trastuzumab based on what, if the HER2 is amplified or if hormone receptors are positive. Now this is, you cannot start testing for FISH without doing IHC beforehand. So this is what the IHC protocol that we follow for HER2, where you have 0, which is negative, and you have 3, which is positive, and 3 is something which is 10% strong membrane positivity is what we say 3. Now 2 is again complete membrane positivity, but not as strong as 3, but it is also 10% or more. Score 1 was not very important a few years back before the introduction of this N-HER2 new drug or the HER2 new ADC compounds. After they have come in, HER2 1+ has also become important because of the introduction of this HER2, the concept of HER2 low. Now, what the ASCO-CAP guidelines came in picture from 2007, the revision has been going on. So 7, 2013, and now the latest is 2018. So what has changed? Basically, when in 2013, the ASCO-CAP guidelines that we were using for testing HER2 by fish, we had an unequivocal category. We had an equivocal category in the fish as well. But in 2018, what happened is that this equivocal category in fish, I know this, the equivocal category in the fish just went out. So there is no equivocal category in HER2 fish testing in the ASCO-CAP 2018. Now, one very important pertinent question is, what is the material that we use for testing? And of course, biopsies, resection specimen. Can we use FNA specimen for testing in breast? And if, can we do fish, or even, would you even do HER2 IHC on breast aspirates? What would you do on a breast duct carcinoma cells positive, and it has duct carcinoma cells? On a breast FNA, would you do? And what would be the reason for that? Yes, exactly. But you would do that on a metastatic lymph node, yes. But having said that, that is only for breast. But if you have esophageal or if you have GE junction, a node there, you can attempt a metastatic node FNA. Yeah, so basically the updated ASCO-CAP guidelines addressed the 5 clinical questions. That is, they defined the HER2 2+ IHC more clearly. In the 2013, that was not defined very well. Then the other question of repeating HER2 testing on the specimen if the biopsy is negative. Now in 2013, they said you must repeat it on the resection. In 2018, they say it may be repeated, so it is completely at your discretion. If you don't repeat it, it's not a must. Then question 3 to 5 are based on the group 2, the category of group 2, which is clearly not positive. So the various algorithms that we'll be discussing in the interpretation part of it to remove that equivocal category that was there in 2013. And it also answered a very important question. Like most of you who are doing FISH would be aware of a phenomenon called polysomy of chromosome CEP17, that we have 2 colors. One is for your HER2 and one is for your CEP17. So CEP17 is nothing but chromosome 17, a part of chromosome 17. So that can have polysomy and your HER2 can also look amplified. Now there is another probe which detects, which has short CEP17. That is what it detects, and there the polysomy factor you can completely eliminate. But the use of this alternate probe was discouraged by ASCO-CAP because they did not really find. They found that doing that, more false positive cases were being reported. So using another alternative probe is really not required. How has the HER2 evolved in breast? And it's basically in all the tumors, but how in breast? First is heterogeneity that we'll be dealing with too much in detail. We'll discuss it in the when we discuss the next session on interpretation. We'll talk about heterogeneity with examples. And with bright field, now you know that fish is nothing but a fluorescent-ish. So there are bright field-ish, that is silverish, or where you don't need the fluorescent microscopy. So that particular concept has an advantage over fish when you talk about heterogeneity. Then the another concept is HER2 low. As I already said, that now score 1 is also important. So barely perceptible score 1 staining on IHC, or where score 2 is given and fish is negative. Those patients become important targets for drugs called N-HER2, where they club trastuzumab with a drug which is an ADC, which is nothing but a cytolytic drug, and it enters the cell using HER2 as a vehicle. So that's a therapeutic option that they've been utilizing. Now, some important questions that come to one's mind when one is practicing FISH is that the changing HER2 status in already tested patient pre and post chemotherapy, is it mandatory to test a sample? If you have tested something pre-chemotherapy, is it mandatory to test it post chemotherapy? What protocols do you people follow? Anyone who's doing FISH? Do you have requisitions for the same patient pre and post chemo? You don't? Do you think it is important? Does it impact in any way? Okay, so we just spoke about a concept called heterogeneity, and as the tumors are mutating and with the advancing times, we are seeing more and more heterogeneous tumors. And heterogeneity increases with post-NSET, post-NSET because of the instability of the chromosome. So heterogeneity is something that causes change in HER2 receptor. A case that was positive earlier becomes negative now, and something even negative to positive conversions are seen. So it is important to test a patient post therapy as well. Okay, so it is recommended. They have seen in quite a few patients. Also, retesting for HER2 at a metastatic site, is it needed or not? Yeah, and that also is explained by the factor that tumors are so heterogeneous that you might have a completely different clone at the metastatic site, which is not responding to your treat. So it is recommended. So then a very important question comes that, okay, fine, you're testing 2+. What about 1+? 1+, fine, you're utilizing them for your HER2 low and a different kind of treatment option. But do you think that there are tumors that are 1+ and you're not doing FISH and then they're probably FISH positive and you're missing out on them? Yes, so that can be pre-analytical factors as well, first. Secondly, there are some important histological subtypes like mucinous, micropapillaries, neuroendocrines, where the membrane staining may not be complete and one may tend to give it 1+. So special histological subtypes, and when you're not sure of the pre-analytical factors in a case, it is always prudent to advise a FISH testing. Because then if it comes as amplified, the patient is benefited. Okay, now after breast, we come to gastric carcinomas. So all gastric carcinomas are tested for HER2. And initially there was like in some time back in some countries, they were following that even 1+, they were putting it for reflex FISH. But now they're not putting 1+ for FISH, so it is the same 2+ or the equivocal category of IHC is further tested for FISH. And this is what the IHC scoring for gastric carcinomas is. Now, the important thing for gastric carcinomas is that here, even the basolateral staining pattern, even the basolateral is important and not just complete. So that has to be kept in mind, that even basolateral staining, you have to, sometimes the IHC is not interpreted properly. So in gastric carcinoma, it is basically the well-differentiated intestinal types which overexpress HER2. Signet rings almost never do, diffuse types never do, you know. So it is just that if you see HER2 overexpression and you're probably overinterpreting at some pre-analytical factors. So it is good to know that it is the intestinal or a more well-differentiated types that have okay, it is advised for all gastric carcinomas, biopsies, resection, FNA specimens. 2+ have to go for further ISH testing, and ISH positive if the ratio is more or HER2 copy numbers are more than 6. Yeah. HER2 testing in colorectal cancers. Now in colorectal cancers, this new, this concept is very new in colorectal cancers. But in this, basically it is in metastatic colorectal cancer. Now HER2 amplification in colorectal cancer is also associated with, and it is also a negative predictive biomarker for efficacy against anti-EGFR therapy. So those patients which have HER2 amplifications do not respond well to EGFR TKIs. So that is why HER2 amplification becomes important. And it is a little different because it is based on, I can't really see. So the scoring for HER2 is basically her ACLIS diagnostic criteria, and it is a little different from our, even the IHC staining is different from what is in the gastric. And here, more than 10 to 50% positivity in cells is what we expect. Now we come to lung cancers. In colorectal as well, if you don't see FISH positivity, you can take the case for an mRNA testing as well. In lung cancers also the concept is pretty new, and the same thing, HER2 amplification is associated with resistance to TKIs. And whereas, in fact, they use, it's not just about using trastuzumab and pertuzumab, it's also about using ADCs. And the guidelines, basically these are the NCCN guidelines that say that after you have exhausted all other things, MET, NTRK, everything apart from that, you test for HER2. And this is the recommended HER2 algorithm for non-small cell. Although I must say that this one is still not the standard regimen, and different countries have different ways of testing, at least for lung, and most of them are following that mRNA testing protocols if you don't have HER2 IHC or HER2 amplification by FISH. And also, one very important thing to note is that colorectal cancers and gastric cancers, apart from having HER2 new amplification, HER2 new point mutation, missense mutations are also very common. So basically, you might not detect them by FISH, because in FISH you are detecting amplification. So in these two solid tumors, the mRNA becomes more important. mRNA testing becomes more important. So I think with this, we can just start with the workshop, and then we'll come down to the interpretation part of it. Kiran?
So nowadays we are getting a lot of true cut biopsies, and NCCN guidelines have also changed, saying that for T1, T2 you give neoadjuvant, then plan for the surgery. So I am from a peripheral center, so I'm in a tier 2 city, so we don't have that well-trained technicians. So we usually use eosin to stain. Yeah. And whenever I send for FISH, the report I get back is that, it is very difficult to interpret with that. So in your center, what are you using instead of eosin, so that this interpretation should...
So that is a very common problem, and I'm happy that you brought it up. We are using food color dyes that you get in the market. They do not interfere with this. Okay. They can be easily washed off with alcohol, or even when you do the protease digestion, they just go off. Okay. And eosin we discourage. Food colors, they're very readily available in the market.
But the whole purpose of using eosin is to identify the cores.
Correct.
And they should not get dissolved in any of the solutions.
Correct.
So, but these food, if they get dissolved in alcohol,
they do not completely dissolve. Only with the protease digestion. That step, because it's a diastase and carbohydrate, and that's how it gets dissolved. Yeah. Okay. But of course it lightens. It's not as bright as eosin. Yeah. So we have to, even in alcohol, it definitely lightens. We have to train them. But even if you're not doing FISH, it would be very prudent to replace all your eosin with food colors. Yeah.
Thank you.
Yes.
I've been seeing requests for FISH completely bypassing IHC. What is your experience and what is your comment on this? Is this to be encouraged?
Is it breast that you're seeing, or other solid tumors?
Breast only. So is this to be encouraged, discouraged? Because, we insist that it should be done. So when we get requests, we say, no, first we'll do the IHC and then proceed with the FISH. So they're not very happy when we say that.
Okay, so ours is a referral center. So there are many cases which come only for FISH, and we do not know the IHC status. We do the IHC first, and then we proceed with the FISH.
Always do
the
IHC.
We always do the IHC. Okay. Unless it's an in-house case where we are the ones who have seen the IHC.
Okay.
Yeah.
But if someone is sending it just for FISH, you have to accept it, because it is... FISH is considered the gold standard. So if some doctor wants directly to test it by FISH, you can just recommend. So when, like she said, that if we have not done the IHC in-house, our policy is to do the IHC and so parallelly we start both processes. But we don't bill the patient separately for the IHC. That's a
Okay.
cost that we
So
absorb
it's done as
because it's
part
our
of the package.
Yes.
Okay.
So the charge stays the same.
And it's not done by us, we repeat the IHC because if it falls into
Okay.
group 2 to group 4, then
No, because I've noticed that when we get those referral slides and we repeat, there's invariably some kind of a discrepancy in
Yes,
interpretation.
we have
Correct.
noted too. Yes.
Okay, so you feel it's better to do the IHC and then proceed?
Yeah, we always
in all
do,
cases you
always,
do.
unless it's done, it's our case and we have done it. And
Okay.
that too, we, before doing the fish, we do have a look at the IHC, we revisit it, yes.
Thank you.
Yes, a very good afternoon to everybody. It's a pleasure to be here. Thank you, Dr. Vinita, for a detailed lecture on fish and its clinical utility. And yes, fish technique, according to me, is very definitely not a plug-and-play process. Since it is included with a lot of multiple steps, it comes with human errors as well. So on that note, I'd like to take a session today based on fish procedure and how to overcome the challenges that come along. So the fish technique or methodology, basically it includes a basic principle of fish, which includes denaturation, the first step, and hybridization and analysis of the sample. It is not as easy as it is said, but since it comes with multiple steps, it is also a very, I can't say it's a complex process, but taken proper measures, yeah, it can be performed very well. The fish technique can also be performed on solid tissue samples and also liquid tissue samples, as Dr. Vanita has mentioned in the previous session, whether it can be performed or not. In the FFP sections and the cell suspensions, the only difference is you find that the cell tissue processing and also cell processing. In FFP, formalin, fixed paraffin emitted tissue sections, you fix it in the formalin. But whereas for the cell suspensions, you fix it in the methanol and acetic acid in 3:1 ratios. And also in cell suspensions like blood and bone marrow samples, you need to be treating the cell samples with colchicine or colcimid, whatever it is called, to arrest the chromosomes at metaphase. So the ideal use of FFP tissues is you can identify both in dividing cells and also in non-dividing cells. But whereas in the cell suspensions, you can identify the metaphase chromosomes as well. So for the fish samples, you don't need prior culturing of the cells. But whereas for the cell suspensions, prior cell culturing is needed. You need to arrest the cell samples at metaphase chromosome using colchicine and also swollen up the cells using hypertonic solutions like potassium chloride and sodium citrate. Compared to interphase and metaphase fish, interphase fish is mostly preferred because in the metaphase chromosomes, we see there's a lot of condensation of chromosomes, but whereas in the interphase, it is loosely condensed, I can say, and also there's wide availability of probes are available for interphase chromosomes compared to that of metaphase chromosomes, and also the short data analysis time, because when it is interphase chromosomes, you need to perform karyotyping as well, but for the metaphase chromosomes, it is not that way. So it will require lesser or shorter data analysis time. So what are the material and equipment that we require in the laboratories to perform fish technique? The basic requirements or reagents and equipment that we require is the first and foremost, that is citrate solution or the retrieval buffer, you can say. For the FFP sections, this is especially for the retrieval, we can say, that is the target DNA sequence to retrieve it and also break all the methylene bridges, for which we need citrate solution at pH 6. And a digestion buffer where we use pepsin. This is used to digest all the protein components which are there in the tissue, especially the one which is surrounded around the nuclear DNA. And wash buffer SEC, that is saline sodium citrate wash buffer, we use it to wash off the unbound components which are there in the tissue. And post-hybridization wash buffer, this is a strainant wash buffer which we use if this is not performed properly and we end up in all background staining. This is post-hybridization where you perform this washing after hybridization step, probe hybridization. And the DAPI solution is used as a counter stain here. 10x magnesium chloride and phosphate buffer saline, these two comes along with 1% formaldehyde. You need a 1% formaldehyde again because you need to fix the cells. Once after the pepsin digestion, there will be a lot of digestion happen over there. And you need to fix the cells so that you need to, it is like you can permeabilize the cells so that the probe penetrates and binds to the respective target DNA sequence. I'd like to talk about a few things about the probes that we use, because this is the plays a very important role. Probes, when somebody, if you're planning to use a type of probes like DNA probes or RNA probes, one should be having an idea whether they are double standard or single standard. Because if it is double standard, ideally they should perform the denaturation of probes first. You need to denature it and then use it then. So DNA probes are short stretch of oligonucleotides, which ranges from about 50 to 1000 bases, and the probes could be either single stranded DNA or double stranded DNA. And also one need to have an idea whether the probes are single colored, tagged with a single fluorochrome or dual chromosomes. They are classified into 3 types, broadly classified into 3 types, depending on the length and nature of the nucleotide sequence. There are locus-specific probes, centromeric or telomeric probes, chromosome-specific painting probe. If you say the locus-specific probe, specifically, the probe is binding to a specific region of interest. That is, here it is binding to the specific region of interest. It can be gene-specific or locus-specific probe, you can say. And the probe, if it binds to the centromere or the telomere, they are highly repeated sequences. So they can bind either to the centromere or they can bind to your telomere, depending upon the designing. And there are probes which bind to the entire chromosome. They are called chromosome-specific painting probes. Among these 3, the first one I'd like to focus because that's the topic today where HER2 gene is coded, chromosome 17. So here, if you can see the first chromosome 17 with dual color probes, locus and centromeric, whereas the locus, the centromeric, where the centromere is tagged with FITC, and the gene that is coding for HER2/neu, that is at 17q12 position, that is tagged, the probe is tagged with TRITC. So, and okay. So the first one, if you see that the gene is tagged with TRITC, the probe is tagged with TRITC, fluorochrome. If there is a gene amplification, we see more of all the orange colored signals. There are more of orange colored signals and the centromere is just 2. The second one, where it shows the centromere is tagged with the TRITC and the HER2 is a probe that is tagged with FITC. You see that more of gene amplification, but the genes are green in color, whereas the centromeres are orange in color. And in the third case, the centromere, the probe that is tagged to centromere is tagged with the FITC, and the gene that is coding is, the probe is tagged with Texas red here. There is another fluorochrome. So if there is a gene amplification, there's more of red color signals you see. And the last one you see, that's a chromosome 17, where the centromere is tagged with Texas red and the gene that is coding for HER2/neu is Texas red. Here you see more of green signals because there is gene amplification and the centromere is of 2 signals. So I should be having an idea whether the probe is tagging, is it staining the centromere or is it just staining to the specific gene of interest. So another one is most important one where we need fluorescent microscope to detect the probe, the signals that are we have to be detected. The fluorescence microscope, it works on the principle of excitation, emission, and fluorescence. So excitation, if you can see here, there is a light source and through which it is passing through the excitation filter. In the first image, the light source can be halogen or LED or mercury lamp, made the inner light source, but if the light source is excited, the excited light is passed through the excitation filter and it strikes the sample and it sensitizes the probe where the fluorochrome, it gets sensitized and it releases the light, emitted light of different wavelength. So the wavelength of excited light is different from that of the wavelength of the excited light. And the color, if you say that the excited light is blue in color. Once the molecule or the fluorochrome that gets excited, it will be releasing a light of, emitted light will be of different color. So when you observe under the microscope, you keep the sample and you, working under the microscope, you observe that the excited light will be of different color and the field of view will be of another color. So this, if the second image, if you see, those are filter cubes in the microscope. Inside the microscope, you find 6 different filter cubes. Each side there is an excitation filter. There's another side that is called emission filter. For example, the first one, if you see, there's a filter cube of TRITC. When the excited light strikes towards the sample, you see that the light is inside. There is a dichroic mirror, which will direct the light towards the sample, and the probe gets excited. The light that is sensitizing the probe is of green color and the emitted light is of orange. The second one, if you see, that is a Fixie filter. The excited filter, the excited light, when it is sensitizing the sample, it is of blue, but whereas when you observe under the objective lens, you see it is in green. And in the DAPI filter, if you see, the excited light is of violet color, and the 405 will be of blue in color. So the excited light and the emitted light has different wavelengths and different colors as well. So one need to keep this in mind. Here in the picture, I have mentioned two different types of fluorochromes, like DAPI, BFP, GFP. They are having different excitation wavelength and also emission wavelength. There's a graph which shows, if you see the DAPI excitation graph, there it shows it is violet in color. But whereas there is DAPI emission light, which is blue in color. I wish this works. But so there is a DAPI Fixie excitation wavelength color, which you see that is in blue. And again, Fixie emission light, if you see, that is in green color. And same as with Fixie excitation filter, it shows green color, whereas the emission, it shows yellow in color, orange to yellow in color. So the color changes with excitation and emission filters. So we need to have an idea regarding the wavelengths and the color of the probes and emission excitation filter wavelengths. And the final equipment and most important equipment which I want to talk about is denaturation and hybridization system. It is specially equipped with humid chambers because the uniform temperature has to be maintained while you perform hybridization, because that's a long time you perform hybridization. Around 12 to 16 hours you give hybridization time. So you need to make sure that the samples should not get dried. So there's a humid temperature has to be maintained. Ideally, in laboratories, they maintain a hot air oven and also some solutions which has 20x SCC and formamide, made of formamide. But formamide is again, that is teratogen, cannot be used, and to avoid hot air oven, where there will be a lot of temperature fluctuations, to avoid that, and also to maintain proper humid conditions throughout the hybridization procedure, one need to have denaturation and hybridization systems. So it comes with the features like hands-free denaturation and hybridization, so there's no hassle, and it comes with power recovery functions, even if you even there is a power loss during your hybridization, because that's a long tenure of procedure. Even if there's a power loss, it regains back to the procedure normal. And heating, it maintains the temperature, more consistent, accurate. Real-time display for temperature curve. You will be getting to see where exactly the temperature is running as in the equipment. And easy program setting. So basic procedure of fish test, that is, it is a 2D protocol wherein it shows that that's a day one protocol. If we can see, it's for the FFP tissue sections. We need to, it starts with baking slides and deparaffinization and rehydration, and it's subjected to pre-treatment where you give a retrieval buffer, as we have seen the components of the fish before slide, where it is used as a citrate solution at 15 minutes in MASI, that is multiple epitope retrieval system, where you can place the slides and retrieve it using the citrate buffer, and subjected to pepside digestion next, that is to digest all the protein components, and wash out 2x SSC wash buffers to wash off the debris, and fixation of the slides in formaldehyde to fix the cells, and also allow the probe penetration, and connecting it to wash buffer, and then dehydration and air dry. So once it is air dried, from here on the procedure has to be performed in the dark, because you're going to add the probe. So after probe addition, it has to be cover slipped and kept into the hybridization. And we need to set the program at denaturation at 75 degrees centigrade for 10 minutes and hybridization of probe at 37 degrees centigrade for 12 to 16 hours. This program has to be set, and once it turns on, it continues through the day 2 procedure. And on day 2, once the probe addition, denaturation and hybridization is done, the glue has to be taken off, and it has to be given a stringent wash of post-hybridization wash buffer. Because if the unbound probes or whichever areas are still there, the probes is still there, if it is not washed properly, that leads to cross-hybridization issues. So the post-hybridization is very stringent washing, so it has to be performed very carefully using 1x post-hybridization wash buffer at 37 degrees centigrade. And then it is about dehydration, air dry, and you counterstain it with the DAPI, and you signal enumeration and interpretation using a fluorescence microscope. This is a 2D protocol. I've already had to perform troubleshooting, as we have seen throughout the sessions that many of them have mentioned that there will be pre-analytical errors, analytical errors, and post-analytical errors. So back in 2008, there was an article which says bad cancer test drawing scrutiny, where thousands of breast cancer patients may be getting the wrong treatment because of errors in two laboratory tests widely used, that is IHC and FISH, to determine which drugs are prescribed. So tracing back to which error it is, may the error be minor or major, since ultimately it will risk the patient's life, every minor error also to be counted. So the pre-analytical errors mostly will be in the specimen collection or specimen accession and transport of the specimen to operating room to the pathology laboratory, and analytical phase errors, which includes fixation, grossing, cell sampling issues and microscope interpretation, and post-analytical errors, the reporting of the pathology test reports and clinical interpretation. So all the errors has to be overcome. And what are the errors that we encounter and how can we overcome them? Let's see a few of the issues that we encounter after we perform FISH technique. So these are the most common issues that you encounter when you're performing with FFP slides. So the first and foremost is improper dewaxing. You see the first image that each and every cell is surrounded with a white coating like. So that is your paraffin wax. If you're not performing dewaxing, or if you're not removing, if you're using the saturated xylenes, or if you're not clearing the wax properly, or if you're using aged slides and improper quality of paraffin, this leads to the residues of paraffin around the cells. So dewaxing has to be performed properly and fresh xylenes are preferred. If not, we end to see such cells that are surrounded with the white coating. And the second issue that we encounter is underdigestion, where you use, most of them they use pepsin, and the recommended percentage or concentration for pepsin is 0.1 micrograms per ml. So, and it differs from laboratory to laboratory. It has to be ideally known or tested. The concentration has to be determined because it depends on the thickness of the tissue, the concentration of the tissue, and the time you digest the tissue. So this is the underdigestion, where you see there is no clear, crisp cell membrane, or the nucleus has been determined. There's some autofluorescence also is seen. This is because of underdigestion. So here in this case, ideally we need to increase the pepsin digestion time or work on the concentration of pepsin that you use. And the third issue that you face is overdigestion, where you see donut-like cells. You call them as ghost cells as well. You see holes in the center of the cells. Ideally, these has to be omitted when you're counting the cells, because the cell digestion is a very common issue that you face. This happens because of your, again, pepsin concentration, and the time that you incubate in the pepsin also will result in such ghost-like cells or donut cells, what is called. So the pepsin concentration has to be ideally determined from laboratory to laboratory as it changes from tissue type. And the fourth issue in FFP tissues is background stain, where you see a lot of dust around the cells and the eaten cells. This is because of your washing issues, improper. As I've mentioned before, post-hybridization, you need to be very careful in giving post-hybridization wash buffers, because if the washing is not stringent, you end up in seeing such background around the cells and eaten cells. If the washing is not proper, and proper agitation of the cells while you're washing the cells, it leads to background staining again. So errors in liquid biopsy slide processing. Earlier we have checked in FFP tissues, but this is common errors that you encounter in the liquid biopsy slide processing. The first issue that you see is cell burst or cell leakage. This is because of your hypertonic treatment. Laboratories, they use KCl and also sodium citrate, and also the concentration of KCl and sodium citrate is really important. And the timing that you keep in KCl solution is important. If it is prolonged more than, generally recommended is 0.1 molar KCl for 10 minutes. If it is prolonged for more, that might lead to a hypertonic situation where the cell bursts and the cell constituents leak out. So we do not want that. The upper image, if you see, that is a neat swollen cell which is ready to about burst and release the chromosomes out. But whereas the second image, if you see the down one, there is cell leakage and the cell constituents are leaking out. Ideally, you need to maintain the concentration and timing of hypertonic solution. The second one is the dilution of cell suspensions. Ideally, in the previous sessions also, the doctors have mentioned that ideally the field of view should have 50 cells per field. So the dilution of your sample is really important. And also the dropping angle or height at which the cell samples are dropped onto the side. When you prepare the slides using the cell suspensions, at what height you're dropping the cells, that is also important to avoid the clusters during the cell preparation. And the third one is cell cytoplasmic aggregates. This is the most often issue that people encounter. This is because of drying time. Ideally, humidity has to be maintained for the easy spread of metaphase chromosomes onto the slide. For the easy spreading, the humidity and temperature has to be maintained. Ideally, it is 55% of humidity and temperature is 25 degrees centigrade. If not humidity is maintained, immediately the tissues, the slides gets dried out and you find such cell aggregates. So if proper humidity and temperature has to be maintained using equipment like thermotron and all for the continual maintenance of humidity, for the easy spread of metaphase chromosomes. And the fourth one is cell debris. This you observe, this is because of some bad pellets where you observe improper washing of cell pellets. The pellets, there will be few dirty pellets where you, even if you wash for around 5 to 6 times, you end up see such a cell, the supernatant will be even not cleared. So for that, you need to give even more washes and clean the slide prior, before dropping the cell suspensions onto the slide using alcohol or ether in 1:1 ratio. Common errors while performing FISH. So this could be the non-specific signal around the cells. The first one, this is because at times people think that adding more probe, maybe you end up in good signals. It's not like that. So adding approximately the recommended volume of probe addition is 10 microliters, and using a cover slip ranging of 80 mm or 22 mm sized cover slips is more than enough. Doesn't mean that if the tissue is bigger, I had to add more amount of probe. No, it is not like that. So it has to be ideally determined from laboratory to laboratory to avoid such non-specific signals around the cells. Ideally, it has to be within the cell. If you see the first picture, there's a signal around the cells as well. This may be because of your probe concentration. You can use hybridization buffer, where you can dilute the probe there. And the second one is a cell fragmentation with hazy signal. This could be because of the denaturation issues, where you give prolonged denaturation at high temperatures and maintain optimal denaturation time and temperature at 75 degrees centigrade and 10 minutes. This is the issue that we face when you use hot plate, where the temperature is often changing because there will be a lot of fluctuations in the temperatures. So in the hybridizer, where you use, we can set the temperature at 75 for 10 minutes, ideally recommended time. And the next one, as you see, is spotty fluorescence. This you observe because of drying of slides during hybridization. Improper sealing of slides with sealant, no humidity maintained. Again, this is because of drying. Since hybridization is a technique which prolongs from about 12 to 16 hours and it's a long duration time, it tends to end up in drying the slides. So if you want to avoid drying the slides, and there should be a proper sealing of the slides to avoid the drying. And to avoid the drying, you need to use hybridizers where you can program accordingly and minimize the humidity throughout the process. Common errors while performing FISH. This is another common issue that we tend to face, that is the binding of probe to non-target areas. We all know which areas had to be targeted. Ideally, if it is tumors, which they had to focus on tumor cells, there's a cross-hybridization of probe where it binds to non-target areas as well. This is because of lack of stringent washes, where you can use the buffers which has NP40 and tween 20, where you can use stringent washes to avoid the binding of the probe to non-target areas. And fluorescent speckling, this you can observe because often this is about maintenance of probe. When the probe or the stained slide, if it gets exposed to light and if it is exposed to photobleaching, you want to see such fluorescent speckling because ideally the probe has to be stored at 2 degrees centigrade in the dark, and also the assay had to be performed in the dark. If not stored properly, or if the probe is continually exposed to light, and you end up seeing such fluorescent speckling while you're observing under a microscope. And the last one is overstained. This is a common issue. This depends upon the DAPI concentration, where you is concentrated. You have to determine the concentration of the DAPI to avoid such overstaining in the cells. So what can we do to avoid? What can we do to improve the staining quality? That is, the first and foremost, the procedure should be performed by a well-trained staff, and sample collection, fixative, and time of fixation storage with appropriate controls in measure. The sample collection, if we take an example of cell suspensions, blood and bone marrow, ideally the blood tends to clot immediately. So they had to use heparinized tubes, and also as soon as they receive the blood samples, they have to put it on the rocker so that the clot formation is avoided. And the sample is received, and after 1 week, it tends to form the clots. So you need to avoid the clots. For that, we need to be taking about cell suspensions carefully. And the fixative that they use for formalin, Generally preferred, as we know, it is neutral buffer formalin, and also for cell suspensions, it is methanol and acetic acid, which is 3:1 ratio. Usage of appropriate reagents for fish testing, which is avoid reagent contamination, change the solutions frequently, basically avoiding the saturation of the reagents. Protocol optimization, validation of process flow, as we have discussed before, that is Pepsin or KCl or whichever the reagents are used. Ideally, it has to be determined from laboratory to laboratory. It changes with tissue type and the reagent concentrations. Knowledge of type of probes used, this is also we have discussed. Ideally, one should be having an idea so as to which type of probes they are using, whether they are DNA based or RNA based, double standard, single standard, are they tagged with fluorochromes, dual probe, single probe. So preferably checking on to the specification data sheets will help you all, and determination is easier when you follow the specification sheets accordingly. Usage of specific FFPE controls, that is using of positively charged slides to avoid the tissue lift-off during your retrieval, when you're performing retrieval for DNA retrieval. So recommended tissue thickness, as we all know, according to CAP guidelines, it is 3 to 4 microns, and the thicker slices can lead to improper probe penetration. And too thin sections can instead truncate the signal. If you see the picture here, the first one shows there are 4 cells, but then since the tissue is very thin, it has lost one of the signals, where this will lead to the misinterpretation. Ideally, if it is 3 to 4 microns, this you can avoid to the max. Exclusion of non-target tissue before analysis decreases the likelihood of an incorrect cells. So before performing FISH, ideally it is recommended that you observe the HLE slide and IHC slide, mark the areas which you want to see, because we wanted to see in the tumor cells. We don't want to see in the lymphocytes and necrotic fibers, mucin, anthracotic pigment, inflammatory cells. All those areas need to be avoided. Prior marking the tissues will help you avoiding the non-target areas. For example, if you take breast carcinoma, the target area will be your tumor cells. In the tumor cells, but non-target areas will be your DCS and LCS. You don't want to count on that. Ideally, you want to count on IDC. And non-follicular lymphoma, the target area where the probe has to bind is at the centrocytes and centroblasts in the follicles. You don't want to see in the lymphocytes and reactive cells. And rest of the components like necrotic areas, fibrous, mucin, anthracotic pigment, inflammatory cells, all these can be avoided prior you are using HLE slide or IHC slide to avoid such issues. So proper maintenance of equipment with special regard to fluorescence microscope, because the fluorescence microscope, it comes with filters as well, filters and excitation lamp, because the lifespan of the filters and the excitation lamp that you're using in the fluorescence microscope is really important. The lifespan is generally 3 to 4 years for the filters that you use, that we have seen previously. The excitation and emission filters, they had to be replaced every 4 years because it dims the signal again. You'll tend to see weak signals. And excitation lamp, beyond its lifespan, again, you end up seeing in dim signals, they had to be replaced. Hybridizer and periodic inspections with temperature strips and preventive maintenance. Water bath, periodic calibrations and preventive maintenance. These equipment are major equipments that you use during your fish process. So you have to be really sure about the equipment that you use, whether they are calibrated or in proper maintenance. Fish stain slide storage. Lastly, you use preferentially an anti-fade mounting medium and DAPI as a counter stain. And do not expose the slide to high light intensity for too long while screening in order to reduce photo bleaching. So once the staining is performed, the slide had to be properly stored at in dark and at 2 to 8 degrees centigrade preferably, so that it can be the lifespan, you can see prolong the lifespan of the slide. Thank you. Any questions? Yes, ma'am.
Digestion times. So that is where we face problem, because we don't always deal with in-house samples. For in-house samples, it's all standardized, the fixation and everything standardized, so the timing protocol, everything is fix. So generally we don't face issues. But when we receive blocks from outside, that's when we face, this problem of over and under digestion is always there. So one thing that we do is after the digestion, we put DAPI and look at the cells. So what is your comment on that? Is it okay to do that?
It is okay to do that, but then before that you can use, after pepsin digestion, you can treat it with ethyl alcohol instead of DAPI.
Okay.
You can treat it with ethyl alcohol, 70% ethyl alcohol, and observe under the microscope to see whether the cell is intact. I mean the membrane is intact or not.
Okay.
Whether the cell is burst open or not.
So there's no need to add DAPI and look at the whole
You
thing
can do
again.
the DAPI as well, but preferably if it is ethanol, wash again.
That's enough.
Yeah, dip it in the water, put it in the ethyl alcohol and observe under the microscope to see whether there's a cell burst, if the membrane and nucleus is intact or not.
Okay.
Yeah.
Okay. And the other question is, when we are doing it on cell blocks, it's the same or they're treated anything different?
Cell blocks, I'm not sure about it.
Okay. Because the fixation is slightly different.
Yes,
so
yes,
whether the
yes.
same thing would work or there has to be a different...
You mean the same question you asked for? For the
for
observation?
the procedure, the same timings, do we have to standardize separately for cell blocks is
Yes,
my question.
It has to be.
Okay.
It has to be,
Okay.
yes.
And also, do you use a positive and negative control with each run?
Yeah.
Okay. Yeah.
We
You
have batch controls. We don't use
don't-
controls.
okay.
We use a batch control. So on one of the test slides, we put a control tissue as well.
Yeah.
So it
Yeah,
is
because
one slide.
the cost
only.
is the
So it is
major
on the
issue.
same slide.
Okay.
One
But it's a
control in
batch control. You don't put a slide control. Okay. Okay.
So we'll continue on to the hands-on workshop for fish.
Welcome everyone for the workshop. And actually it's a 2-day protocol which have been concised into a 1-hour program. Sorry for the delay that happened earlier. We'll try to accomplish it in 1 hour. And actually is, the real FFP tissues that you need to bake it and remove the dewax and then rehydrate the tissues. So till that part we have already done. And then we go for a citrate retrieval. Which is for the retrieval of to make the methyl bridges that are formed during the formalin fixation. So we are going to use, right now in distilled water we have rehydrated and already accumulated the slides. Now we place all of them into the citrate buffer and keep it for 98 degrees, 5 minutes. Actually the protocol is for 15 minutes in 98 degrees of citrate buffer. But of time concised, we have got it down to 5 minutes in the MERS, which is already an equipped pressure temperature controlled equipment. Here you can see the MERS. So whoever want to handle the slides, we can come and we'll start the procedure. Yeah. Yes. Yes, yes, yes. Right now the retrieval process and all the formalized steps will be conducted together, and whereas the staining and all will be taken for the individual slides. Okay. Right now they are in the distilled water. So these are the citrate buffers.
The citrate pH is 6.0.
6.0, where you need to break the formalin bridges and the formalin bridges.
So they're all deparaffinized and kept ready in the slides. If you make any, can you handle these slides? gases there in distilled water we can use, I mean, for...
The very first protocol is for the real procedure that need to be followed, and this is the concise procedure that we are going to follow. Here you have all the steps in detail. Right now, what are the procedure that you are following will be here. So you can do accordingly. If you have any doubts in between, anyways we'll be guiding and performing the staining. So these are the citrate buffers. All of them are loaded? Yeah, you can. Yes. The solution is actually preheated into 98 degrees, and then we keep it for retrieval for 15 minutes. That's the actual protocol for 15 minutes. We have concised it to 5 minutes for now. And you can carry this over to that equipment which is called as MERS I, which is a multi-epitope retrieval system. Why it is off? Offline the good thing. Yeah, you need to. Direct. If you let me remove this. Already it is pre-warmed. Actually the buffer also need to be pre-warmed. But the thing is, I just made it wait for you guys to do it by your side. But the thing is, buffer also need to be pre-warmed. So after pre-warming, you need to keep it for 15 minutes, and now it is for the 5 minutes. In this, it is like customized program, where the program button, if you press, you have a customs. And actually this is used for immunohistochemistry, where we will do the retrieval systems, right? So you have a lot of customized programs over here for different temperatures and pressure and times. All these things can be customized over in this equipment. Actually, ideally they will be doing it in a water bath or any other equipments. But this is better than the water bath. Yes, it's better than the water bath, because we can like control and everything, pH of those. Yeah. And if you have multiple tissues, this can accumulate around 24 of these slide standers, and this can accumulate around 250 ml of your buffer. So 24 slides with 250 ml, so it can accommodate around 5 jars of this, 3 to 5. So 3 to 5 means is around 120 slides. So in one protocol, like in one run, you can have a different protocols. You will be even having in the IHC like a different markers, like for the trace, a higher pH and a lower pH, right? All of them can be done in one shot in this MERS. And you can customize according to your like which buffer and which temperature you wanted, and which pressure you wanted, and which for how long you can adjust it. Generally for the skin type of tissues, you need a little bit low temperature for a longer time, and you can customize it. So we have around 10, 15, 20, 30, 40 minutes, which are already pre-programmed. If all the IHC markers that we do supply have a same protocol of 15 minutes to 20 minutes. If at all you have more number of slides, you can bulk it up to 20 to 30 minutes according to your standardization of the laboratories. Right now it's for 15, it is for 15 minutes, but we have done it for 5 minutes. But
so I need to start this?
No, it's already in the hot mode, so it will be sufficient temperature for you to maintain for 5 minutes. Okay. That's why I haven't on, because if you on again, we can't open it, right? Okay. It's difficult.
So
that's
you pre-warmed it?
Yeah, we have pre-warmed so that we can move upon for the step. Next. I think the 5 minutes are done.
No.
You have 5 minutes. Okay. Because even if you do for these slides, you're not going to get the same result as you do for a 2-day protocol. Just to understand of each step, you are doing it. Okay, you can have it. That's fine. We already.
Just to concise the time.
Yeah.
After return, what is the next step?
It's next is a DI wash for 2 changes, which we have DI wash. Last 2 jars.
We'll take the slides there. So same instrument can be used for immunohistochemistry as well as fish. So
I would say not for the technique, but you can go for FFP tissues and all the cell blocks that you prepare. Everything it will be suitable if your customers should think. And it's very user friendly. And you can put a portable material also. Yeah, it will work mostly for 15 to 20 minutes. If at all you have any hard tissues, you can go for a further long. If you have a soft tissues, you can less. You should talk to our marketing sales. We are R&D.
Now you can transfer slides to the water.
Wait, this is a pressure, actually it's a pressure locking system, whatever you are seeing here. And this is the pressure release system. That's fine, that's fine. Right now the pressure is not enough to be get burst, okay. So it's a pressure releasing, and this is a lock-in system. You can unlock and then you can pull it up. So it's a safety, so that you don't just click a button and it opens. Yeah. Wait. That would be hot. Yeah, you can carry. If you doesn't feel the hot, then you can. It's fine? Yes. Here's the distilled water wash. Someone else can. I'll keep it over here.
So you can just transfer the slides.
Yes, you can just transfer.
Like how many minutes we have to keep here in the distilled water?
Ideally, it's 2 minutes according to the protocol, and we can do it for 1 minute.
Just leave it.
Yeah, for 1 minute, yes. Now all your formalin, like formaldehyde methyl bridges have been broken, that one formed because of formalin. Now you have a wash so that it will get removed, the reagent, whatever the citrate is there, it will get extra reagent will be removed. And after this step, you need to dry the slide, air dry it, and then you need to add pepsin. For that, the pepsin need to be pre-warmed for 37 degrees. So that we have already kept in a flotation bath, the 37 degrees the pepsin is already been warm. So after the distilled water wash, you can take the slide. Individually, people can handle one slide, mark the area, and then add the pepsin. Then the pepsin digestion goes for 15 minutes, but we have concised it to 5 minutes. Okay? Yes. No, you can take this.
Okay. 10 slides are there, so when you go to the
Yeah, you keep it on. Actually, this till pepsin and the next wash, you can do it in a light source, but once after the pepsin digestion, everything need to be done in a dark area, because the probes and the DAPI that you're going to use all are light sensitive.
We are keeping reverse?
No. You
Like
can
this
keep it. Actually, you need to. Yeah, so that the extra water gets removed, and you need to dry the tissue. Someone wants to have it? Akkada kuda pettu 3 stands. ఇంకొక స్టాండ్ ఏదో ఇంకొక someone any of you? One can take thing and you can handle. You want to handle? You want to handle? That's fine. Yeah. As you won't having the visibility of the tissue, you can mark the area so that you can add the exact location wherever you want to add the probe or the DAPI. You can mark that little area so that you can, because all the probes and the DAPI, the kit is expensive, you should make sure utilize each and every drop of the reagents. Can you do it here so that you have a free space. You can have a free space. Hybridization. Pepsin on Pepsin program. అది on 37 को check చెప్పు తీసుకొచ్చి పెట్టేసి.
Check out step by step what we are following next. The reason we don't use PAPN because it will avoid the fluorescence. So that's why we don't use the PAPN over here. Otherwise, it should be okay. If technician has a good hand to mark surrounding without interfering the bleeding towards the tissue, they can use the PAPN as well. The hydrophobic
Hydrophobic pen that
which
can
is used
block
for
the
illness
reagents.
disease.
Okay, like ink pen.
Yeah, barrier.
Okay, that marker, CD marker. Slide marker.
It's a like a hydrophobic liquid so that it doesn't allow, you have a minimum usage of the reagents. So you can just mark it around the tissue and it doesn't allow the reagent to pass it over that.
Yeah.
So your minimum usage of the reagent will be there,
That is
concise.
very
Instead of
Yeah.
using lots of antibody, you can just have 100 microtest marking the tissue around.
That is PAPin.
PAPN.
PAPin.
Okay. These are the pepsin enzymes. You can just add it onto the tissue. It's sufficient for you. You can resign. You can see it. Yeah. While doing this step, you need to be a little bit careful. If you do over concentration or over time or under concentration, it might lead to,
Yeah,
it's sufficient for the tissue.
until you
How
cover
much
tissue.
the volume sufficient for the tissue. If
Just make sure that it covers the tissue.
yeah. If the concentration is more or the incubation time is more, that your cells will get digest, so you don't find any proper morphology over there. Yes. If it's covering the tissue, then it's fine.
Yes.
Yes. Second, sorry.
Only the probe and DAPI are expensive, so you can be care on that. Otherwise, the rest all will be okay.
The tricky of this step is not finance, but it's the technique. How much time, concentration, and the time that you're using for it. And now, whatever the pepsin reagent that you have added, it has been already warmed to 37, and you need to keep it for 15 minutes in actual protocol, which will be concise to 5 minutes. And for that, we need a warm surface for 37 degrees, where we are using this hybridizer. You can get the slides over here. So the hybridizer, this can accumulate around 12 slides, and has an accuracy of 1 degree. If you want to set your temperature around 37, it has plus or minus 1 degree change, which is very helpful in managing all your protocols. So it need to be warmed around for 37 degrees for 5 minutes. No, reagent has been added. Reagent is not added. Yes, here the water will be there. It's because why is that, see, if you use a water bath, you need to heat it to 98 degrees. Again, then you need to get it back to 37 degrees, which is a very time consuming. Here, it plays a crucial for the time construction. It will reach from 98 to 75 degrees within less than 1 minute. So your protocol can be almost, it can be concise to 20 to 30 minutes of each step. So that in the water bath, if it's been for 98 degrees and you want to reduce to 70 degrees, it will take around 20 to 30 minutes. And there is a chance of you changing the water also. Here with the minimal water, you can do it within 1 minute. So your time is being very much sufficient. Now we need to keep it for 37 for 5 minutes. So I have already warmed the plate for 37. Now I'm just starting it for 5 minutes. And hybridizer. Hybridizer. Yes.
Okay.
And whether to know that actually this is maintaining the temperature of 37 or not, you can see it over here in the graph.
Okay.
It will say we have it set it for 5 minutes. So you'll be seeing here the time, 7 minutes, whatever the time that you have kept. And here is the clock that is ticking that shows that how much time. And it will show even the leftover time and the temperature. And if you want to stop the run button in between, you can stop it. And you have a once the program is done, I will show you how this is done, and you can customize all your protocol more than 50 plus. So for each experiment, like for if you want to do it for the fish, or if you want to do it for the fish, or whatever it can be. So all your different techniques can be customized into it and can be labeled.
Okay, what is this green line going on?
That is it is showing you like this is the
It is
temperature
maintaining.
and this is the time. The time you have given and what is the temperature that it is been maintaining. And this, you can take this data also to a pen drive or connected to a system so that you can have your graphs that while if you in the research you need to show all your proofs of data, right? That also can be retrieved from here. So what's the program that you have set and what's the temperature that actually has gone? It will give you in a Excel data or in a graphical, whatever the way you require.
So that means it can go out of the temperature, means the graph will change.
Yes,
is
the
it?
graphs will
And
change.
that moment we can stop the procedure in between. Is that right?
No, actually, see, for your research data, they'll be like how accurate, like you are there to say that it is run in the 37 degrees, right? So to show that my temperature throughout the experiment has been in 37, that thing will
That's
be,
the only thing. But
yeah.
it will not alter on its own or
It,
technical
no, it
glitches
doesn't.
or will not.
That won't be there. Actually, for your fish hybridization, you need denaturing and hybridization, which are at 2 different temperatures, to make sure that your graph is the proof that, yeah, we have done in the same temperature and it will. And the entire data can be collected into a system and you can have it. And it's a system generated, so no one will be having an issues for
Pointing
it. Yes.
So 5 more minutes. So the instruction manual will be given.
Yeah, for all the equipments, we have instruction manuals.
Right now, we
and
don't have any instruction manual
for this.
which you can
Right,
share.
right now we don't have. If you go to our website, you'll have. It's
It
at
will be there?
www.pathoncity.com.
It
Yes.
will be
Yes, all the specifications, whatever the requirements that you have seen, everything.
Troubleshooting also is there.
Troubleshooting for?
For any step we are doing.
That
Pre-analytic or
Okay, analytical. That request you can give it to the customer service, the mail ID that has been inbuilt you have in the website. Then they will share the documents accordingly. Yeah.
And this PPT, can we get the PPT? Is this recorded? The session?
I don't know about that. That you need to
Recorded,
record
right?
it.
It is available in the YouTube. Okay. Can we get the PPT?
The PPT is not short.
What's there on X and Y axis?
Yeah. On the y-axis you have the temperature and the x-axis you have the time. So at this much time, what is the
We can
temperature that is
adjust.
maintained?
Adjust also, plus and minus is there.
This plus and minus is like, see, for the grid, one grid, it is showing 15 seconds for one grid.
Okay.
So if this plus and minus is like, you can change that grid.
Great.
Now you want to change one grid into 30 seconds, 1 minute, 2 minutes. If at all you are having a 20 hours or 48 hours protocol, each grid is giving you 15 seconds, that is so much of data. To concise it, you can change your grid.
According to the time.
Yeah, according to the time you need, you can change that.
What is this 16 degrees centigrade? Can't see.
Actually, every graph has their cumulative standard thing that can be calibrated. So this will be calibrated at 60 degrees.
Okay, C is for calibration.
Huh.
And when you need to escape?
No, once the program is done, actually, if you have kept for 37 degrees 5 minutes, for example, let's take this step. It will first start the temperature attaining. Within less than 20 to 30 seconds, you will attain your 37 temperature. As soon as whatever the temperature that you require, it will be attained in 20 seconds or to 30 seconds. Once you attain, in the display it shows that we have attained that temperature. Do you want to start the program? So once you press the start button, the program starts. Then whatever the time that you have given, it will go run into that time. Once the time is done, it will show that the program has been completed. And then you can then it will ask whether you want to extract the data or not. And once, if you have a requirement of transferring the data, you can transfer it either by connecting to a system or a pen drive. So once you have collected the data, you can escape the program so it comes back.
Okay. So when you press escape and when you press stop means only in between you want to stop.
You want to stop.
Otherwise, the entire program completion we need to press the escape.
If at all you want to stop in middle of the
then only
program.
we will be using stop.
Yes.
Otherwise it is escape.
Yes. Once the program is done, you can't see the initial programs whatever you have set for other experiments. But once you have done with this program, I'll show you escape and then we'll go to the main menu where you can see all the programs that has been jotted out.
Oh.
Different programs, you can label it. And in this, actually it is denatured and hybridization, 2 steps are there. So accordingly you can eliminate one step or you can perform both the steps or one after the other, and what time and what temperature it need to be done and everything. And it has a lid sensors where it will always maintain all the corners of the instrument same temperature.
Oh. Okay, that's why every slide will be at the same temperature.
Yes. Yeah. See, now it's done. Okay. This in mark indicates that the program has been completed. Okay. Now you can press escape. Now it is asking for you whether we can transfer the data or not.
Return main menu will lose data.
Mm.
So
If
what
it,
we have to do now?
if I press no, it will show you the path over there. Right now the system is not connected, so it won't show you the path.
Okay.
So if I say yes,
then
there it is lost. And these are the files where you'll have a lot of protocols that you can customize.
Okay.
You can label and you can keep it. Okay. And now after this, we'll have a wash. We'll have an SSC wash, which is placed in the on the tables. Let me get it. SSC. ఇక్కడే ఉంది. Here one more SSC wash is there. If you want, you can. slides. Huh? Less than 10, 7 or 8.
This one we need to put
Yes, yes, SS wash. For 1 minute you can wash and shift it on to the second SSC wash buffer. It's the same solution.
You have to put it
want,
back again.
yeah. Yeah. Is this SSC wash? Yeah, yeah, that's fine. You don't have the protocol? Huh? Already వాళ్ళకి ఇచ్చాను. Yeah, second one. Yeah, one more time wash. After the wash, now due to the pepsin, all your digestive things, the cell has got digested. So now you need to again refix the tissue. So again you'll be going for 1% formaldehyde preparation, where you'll have different salts to maintain the pH and formaldehyde to refix the tissues. So and again you need to keep it in 1% formaldehyde. Again it's for 15 minutes, so we have concised into 5 minutes.
Okay, you are going to fix again.
Yes.
Formaldehyde.
Yes.
Then you will transfer to alcohol. So SSC.
Wash buffer. After formalin, yeah, you can place it into formalin, 1% formalin. There. It's actually 15 minutes. Now you can keep it for 5 minutes.
So we need to put twice into SSC.
Yes, 2 washes of SSC, 1 minute. Formalin? You have placed this once? Yes.
I'll keep little later.
The 1% formaldehyde. You can place it over here now. Now it's
From here I transfer.
one wash, second wash, and now you're transferring to formaldehyde. Transfer.
No, just now I transfer from here to here.
Okay, fine. You can stay because anyways you're not going to get the results. Just a practice of it. All of you are doctors? PG? PG.
Okay.
Okay. Timer పెట్టలేదు. Once the formalin, again go for a wash.
Washing.
Distilled water. It's not yet. SSC wash buffer is also called as a pre-hybridizer solution, and this is the post-hybridizer solution. All there you have a distilled water. Here distilled water is here. Here is the distilled water. This is the SSC. Once after you wash, again after distilled water, again you need to go for 2 changes of distilled water, each of 1 minute, and then again you need to dehydrate the tissue. Again by using now again you need to dehydrate the tissues in gradients of alcohols.
What step is it? What step is it? 17. 70. Wow, 9. So next to interpretation is there, right?
I can change.
And what is this light under microscope?
Let's do little bit of faster because you need to go to interpretation. And then in each I have how many? 1 minute in knowledge. Normally also it's a 1 minute. You kept it in 70. Okay, you can change it. Yeah, after this you need to age, right? Add the rope. Turn off the lights when you're adding the rope. Need to be age, right? And the dish need to be held. So theater mode we are going. Yes. 1 minute each. You can change it. Chip. You can keep them here. Okay, actually from here all the steps need to be done in the dark, but we can't off the lights. We'll switch off. Only this side. You can actually air dry it. It would take around 10 minutes for air drying, but now we don't have. I'll give you the probes. It's very difficult to add. So these are the fish probes. You need to get them into the room temperature and then add. Take out the slides, air dry, and now you need to add the probe. And it's light sensitive. They are fluorescence, no? It's light sensitive. So you're not supposed to do it in the light source. This one is already used.
Those are used for pipsing.
You can use it. No.
Few more droppers are there. We'll give it to you. Actually, if you leave it for 10 minutes, it's alcohol. It will get dried up. So no need to worry so much. Rakesh, last program. Last.
Speakers,
Very careful.
Cover slips.
Cover slips.
Sort of boxing. Once you add the probe, you need to keep the cover slip. So when you enter the dehydration process, really careful. The probe should not be there. Very slowly. Very slowly. From the side towards
Air
the side.
bubbles.
Under your probe signals. Okay. Be careful.
Make sure that you don't have
What was the dropping height that you were talking about?
That's for cells.
No, but what exactly is the drop? That is preparing the cells lights. That is different from FFT. Okay. When it comes to cell suspensions, you take this light, pick up the cell suspensions and draw from cell light. Because you have already swollen the cells. just in case
So that they don't burst.
keeping slit.
Oh.
So it's not so that the chromosomes comes out and they spread very neatly on the slide.
Okay.
So keeping the slide at certain angle and dropping the cell suspension. That will be when you strike the slide and the cells open and the chromosomes come out. And that has to be performed in a remote manner so that the spread will be if not you'll see cell aggregates again, chromosome aggregates. I think you have seen the picture.
Yeah, like you were talking about that interface and the interface.
The chromosomes will be like aggregates again. So the dropping angle and the height at which you're holding the slide is really important. Okay. Sukha. We'll be sealing the entire area, that is edges of the cover. There is another slide you can try.
This is sufficient.
Because anyways the probe volume that is going to add is very high. You just drag it, it will expand. And you should always make sure that your cover slip is center of the slide so that you can cover the entire area. Right now. Yeah. Now we need to keep it in place.
This first we should move.
Yeah, actually this is really excess.
Which one? This one, right?
More or less like this. That's okay. You can keep it in a moderate speed. Just cover this.
Yeah, yeah. Vidya? Bring the slides. The camera. You don't have. I have.
See, before you have, I showed you the programs, right, of different kinds of programs, and now this is the short hybridization program that I have done actually. Now I'm showing you how to do this. So in here you'll have a name, hybrid, what you want, whether you want to do only hybridization or you want to do any denaturation or any in situ BCRs or you want to run or any other protocols that you want to customize. So you can select over the option. So ours is a fish, so we need denaturation and hybridization, two steps. So I'm selecting the both, and here denaturation temperature and the time that it needs to be taken, hybridization temperature and its time. No, denaturation will be done around more than 75 degrees where your DNA is inside. Now we have license and items by using the peptide. That's it. Time denaturation usually around less than 10 because there you are just unwinding the DNA. Once the denature is done, whatever the growth that you have added will go and bind to the specific target that you are targeted in the DNA. So that goes and binds. When it binds, it will need a certain temperature. So if suppose you are at the probe that you are adding is a dual strand probe, then you need to denature it. So to denature the DNA that's in the cell and also the DNA that is out, the DNA probe that we are going to add, both need to be denatured. So once the both are denatured, then because of the high temperature it gets unwind, and that means you will keep it in reverse. Because this is the hot plate, right? Your probe need to, no, no, please. So this is the temperature I have selected. So the program I have done. So now it is asking me to attain the temperature. It's asking me to wait till 75 degrees because our denaturing temperature is around 75 degrees. We have standardized this protocol according to the kit that we have supplied. But if you have any other methods, you need to follow the data space, data sheet specifications that we have obtained. Or you can concise the, or you can validate your own reagents and the protocols that you have created, whatever is useful. పెట్టా పోతాను ఇప్పుడే పెట్టా Still don't mind because you need to learn more about interpretation, the presentation skills. So they're going to really wait for the time that we have. It will be difficult for you guys. 2 days, it's a 2 days protocol because here it's a Now we need to remove this steel, but to remove the steel, by the time the hybridization is done, this will be harder. Okay. So it will be difficult. So you need to remove the seal, and whatever that is left over, this can be done by using SS post hybridization buffer. This also need to be warmed up till 37 degrees so that your cover slip will be easily drawn, and also the extra reagent that is there, that will be washed. And this also this will be very what to say, little high concentration because your probe is there. You need to watch that extra probe that might cause you an autofluorescence in the background, some kind of noise in your interpretation. So they will be actually this will get dried up. So by using the forceps itself, you can remove this entire thing. రాకేష్ తీయచ్చు కదా రాకేష్ చూస్తా ఇంకోటి తీ ఇది లేదు సివిల్ తీయాలి కదా డ్రై అయితే సివిల్
It's become like a plastic, just remove it like this.
You can remove it like this, but the thing is it is not dried because we are not following the entire, because of the temperature that we are keeping in the hybridizer, it will generally get dried. So if at all after removing this superficial thing, వేరే స్లైడ్స్ ఉంటాయి కదా, వేరే స్లైడ్స్ తీసుకొచ్చేయండి వాష్అప్ పెడదాం. It's difficult to remove it, no? That's fine. Let's go with the remaining slides that are left. So we want to remove the cover slip here. Yes, we want to remove the cover slip and also need to remove the extra probe that is being left, and also you need to have a stringent wash. Here this wash is very important because the probe that might be left will causes you a noise or autofluorescence in the background. Wash. This again you need to warm it. So warm around 37 degrees, and you can wash it around 5 minutes each. But we can pass it on to the next step. Sorry that we are a little bit.
Currently we have to remove the cost tube. When the cost tube is too much hard to remove.
You can keep it in the post-hybridization buffer. It will get automatically slipped away from the slide.
So possibly remove the slide. That time what are the cells in the tissue will be attached to the cost tube and remove.
It should come with these.
Yes, it should come with this. That's why we will be using the post-hybridization and a little bit of warmness to get it done in quick.
Now I can keep mine.
Yeah, you can keep it over, but the buffer is not warm. So if you've done the wash, you need to do the wash for the 2 times post-hybridization wash. And this is a
So that
it
the
will have a
excess
detergent,
will be washed
up. So it might have the detergents which he was mentioning, like Team 20 or MP40 or another kind of detergents will be added into there, so that you get your things washed away. Once the wash is done, again you go for dehydration. Again you go for dehydration.
Dehydration steps twice we are doing.
Yes, before adding the probe and also before adding the DAPI, we'll go for dehydration twice. So again we go for dehydration, then we'll add the DAPI, and after DAPI again we'll do the cover slip while using the nail polish to seal the entire area. Again this also need to be done in a dark area itself.
DAPI.
Yeah, DAPI also.
Once we added a probe, all process in the dark area.
After the pepsin addition, from the probe till you get visualized under the microscope, your slides need to be maintained in a dark and a cool temperature.
Dark and cold.
Yes. You can maintain at room temperature also, but as the days pass, it will get faded away. So if you want to wait it for 3 to 4 months to keep a storage of your signals, then you can keep it in a cool area to maintain, and it should be dark also. So nowhere the light should get exposed to the light. This light system doesn't work. Even the microscope that you are going to show should be in the dark itself. All the counting and everything will be done in the dark.
How can we see?
Microscope has that.
Microscope has the thing, but other steps, the area where we have to put the reagent, everything, we should be trained.
Yes, we'll have a very minute light that you need to magnify these things. Actually, I have skipped the dehydration step, so I don't know. Actually, it's dehydration, then we need to air dry, and then now we need to add DAPI.
This one more from Actually, this is not dried, no? It is looking good.
5 kilometers from
All this needs to be practice to put fly.
So what are the targets for pre and
Yeah.
మీరు తినేసండి రాకేష్
It has started. स्क्रीन शेयर करना Shall I start? So I'm going to speak briefly on the interpretation of HER2 fish and troubleshooting. What are the problems that can be encountered during the interpretation of the slides? Sharon already spoke about the multiple steps during the staining process and how we can figure out what has gone wrong and how we can take corrective measures. So quickly to revise what Dr. Vinita told you earlier about the immunohistochemical interpretation, we have to score the IHC as 0, 1, 2 and 3. Now 2 and 3 have to be as defined, they have to be a very obvious staining. You know, it has to be seen at low power and it should be seen in a homogeneous population of cells. So that is important to remember. Doesn't work, no? So it has to be seen on low power and in a contiguous population. Whereas to distinguish between a 0 and 1, it is important that we look at the slide under high magnification. So please remember that. And whenever there is a score of 2, if you are just reporting, signing out a IHC thing, don't just say score 2, you say score 2 and that you recommend confirming the HER2 status by using fish, because it's important that the recommendation goes in your report. Now, as people who are reading fish slides, how do we decide whether the tissue is accessible for reporting? One is that a pathologist has to first go through the slide to see if what are the relevant areas of tumor. As you heard it before, we have to look at the invasive component of the tumor and not the in situ component, because HER2 has been defined for the invasive component. Only the invasive carcinoma is scored. Avoid areas of heavy inflammation, any necrosis, areas where you cannot see the nuclear boundaries well. When you see the slides actually under the microscope, you will be able to understand what I am saying. Disregard nuclei where you're not seeing good signal intensity of the immunofluorescence, and any areas where you're seeing a lot of background staining. So basically you have to see good non-overlapping nuclei, no background staining, and good intensity of signals within the cell. What is the objective recommendation for interpreting fish? For identifying the area which you want to score the signals in, you need an oil immersion 20x objective, and for scoring the signal pattern you need a 60x or a 100x, again a oil immersion lens. Now we spoke about matching the tissue, that we have to look at fish in a particular area and then read the slides only in the same area. Now that can be tediously done on the slide itself, but in our lab we have a software which is called Tissue Suite. It is a part of a ASI software. So you can see over here that we have marked the, so this is our IHC slide, and we identified the areas where we were seeing a 2+ kind of a staining, and then automatically the software picked up the same area in the fish slide. So then when we look at the fish slide, it automatically takes us to that area. But for those of you who have to do it manually, you have to manually mark the area of interest and then go and look at it under the microscope. So what are the quality control mechanisms that are required? The signals have to be bright, distinct and easy to evaluate. Normal cells will allow you to have an internal control. Now what does that mean? Your internal control should show you normal signals. So your internal control may be either the normal breast parenchyma, or it could be the endothelial cells. Any normal cells that are there in the tissue. And what should they show you? Either 2 green, 2 red, or 1 green, 1 red. You should not be seeing any amplification. Normal cells should have 1 or 2 clearly visible green. This is what I told you already. And what does that tell you? That tells you that the hybridization of your DNA probe has happened correctly. Due to tissue sectioning, this was also shown very nicely by Sharon in one of her cartoons, where there is truncation of signals. So sometimes normal cells need not, I mean by definition you would expect them to have 2, but it is likely that sometimes there will just be one signal. And sometimes cells which are undergoing cell division may have more than one. Now, if you do not see signals in the so-called normal cells, then something is wrong with the assay, and then the assay becomes uninterpretable. The nuclear morphology, again, stressing on that, you should not see a lot of ghost-like cells. You should not see too much overlapping. The nuclei have to be seen neatly, and otherwise, again, the test run becomes invalid. I think someone was asking about what are the digestion times, etc. So, now Dr. Vinita and I know that we have certain centers from where when we get tissue, we know that for certain, if we use our standard protocol, it overdigests the cells. So by now we know ki is hospital say if something is coming, we have to modify our protocol. So that comes by trial and error, and each lab has to set up its own practice for it. So review and document both the external batch control, or if you are having a slide control, as well as the internal control. So that has to be a part of your internal quality control records. And when do we reject a test? We reject a test and repeat it if controls are not as expected. If we cannot find areas of invasive tumor, we need to find and count at least 2 areas of invasive tumor. If more than 25% of our signals are unscorable. Now see, every time the entire tissue that we are seeing may not show us good signals. There will be some areas where the cells are showing weak signals. So it is okay as long as those areas are less than 25% of the entire tissue that is being studied. More than 10% of the signals are occurring outside the cytoplasm. The nuclear resolution is poor. We will see examples of these. Autofluorescence is strong. Autofluorescence, Sharon again had shown you, where everything seems to be fluorescing, and that is because of poor washing techniques. And if anything like this happens, first we reject that particular run, we repeat it. So we repeat it with, depending on what the problem was, we try to modify our protocol a bit and we repeat. And if the repeat also fails, in our lab generally we attempt 2 times. Once in a while I think we've attempted thrice. But otherwise then we report that it is indeterminate and an opinion is not possible, and if they have some other blocks they can send it, because it's an expensive test, so you can't keep repeating the test. Plus, it is always recommended that a lab enrolls itself for one of the external proficiency testing programs. Now, testing programs which are available are the CAP, the NORD-IQC, the Tata Memorial Hospital, and there must be other organizations. Our lab is enrolled with NORD-IQC. So this gives you confidence, because see, this is an expensive test. A very important decision for a breast cancer patient is going to be taken on basis of this test. So if you have to feel confident about what you're signing out, it helps if you have enrolled yourself into an external proficiency and you're performing well. By definition, you have to get at least 90% right. And typically, these CAP, NORD-IQC, they send you 2 batches of challenges in any calendar year. Signal location. So how do we decide which area to interpret? So look at the HE slide. We have a sequence in our lab of HE, IHC, and FISH. So we look at our HE slide, then we see the IHC slide, and then based on which area of the IHC slide showed us a 1 plus or a 2 plus, or sometimes, rarely when we get a request on a case where there is 0 IHC staining, then the better fixed areas, etc. So we decide which is the invasive tumor that we want to look at, evaluate the same area on the FISH slide, scan several areas of tumor for possible heterogeneity. So I showed you that we matched the areas, but it doesn't mean that you directly just go to the matched area and look at that. What you have to do is like any other slide that you see now, scan the entire slide. So you get an idea of what's happening in the entire slide, and then you come back to your matched area and decide that, okay, I'm going to focus on this area and count. What happens when you scan the area? You get an idea of how the signals are distributed. Are they being seen uniformly? Is it everywhere non-amplified, everywhere amplified? Is there heterogeneity? So it's very, very important that you have an idea of what's happening on the entire section. And then you select the tumor areas for assessment. And those of you who have done cytology or hematology, when you do differential counts, we all have a method in which we move on the slide, a zigzag depending. So this is just an example that you start in the left, move left to right, left to right. So each one of us has their own system. The idea is that we don't miss any area of the tumor. We screen it in a very systematic way. Signal enumeration. They say 20 cells are, 20 nuclei are enough to be scored, but in our lab we tend to actually, I think, overdo it, and we also have another analysis software. So if we use the software, it goes into hundreds of cells that we analyze, but manually at least 100 cells we do analyze. Adjust the microscope focus. Now this is important. You may not see all the signals at the same setting. So you might have to do a fine adjustment to see the signals in individual nuclei. Two signals of the same color, if they are separated by a distance equal to or less than the diameter of one signal, are counted as one signal. So remember that the separation has to be more than that to be counted as two separate signals. Nuclei, if they exhibit only one. So one thing that I think we all forgot to mention till now is that the ish that we are talking about today, the HER2 ish, is a dual ish that we are talking about, because there is single ish available, but here we are talking of dual. So anytime, I mean, now I'm speaking to you about HER2 fish, but when you're interpreting any fish, so you need to be aware of what probe you're using, what colors are located, which is the centromeric color, which is the locus color, etc. So all that has to be kept in context. So if the nucleus is showing you only one color signal, you have to ignore that nucleus. Overdigested nuclei do not count. The HER2 in this is orange-red in color, and the CEP17 or the CEN17 is a green signal, and you keep counting. So the way we do it is that if two of us are sitting together, then one dictates and one keeps writing down. So we just, I mean, we have our sequence. So if we'll say HER2 CEN, so we'll say 2, 1, 2, 2, 4, 2. And so someone keeps writing down. Then we move to the next area. So we write in area 1. In our lab, as a policy, 2 readers count every fish case, which is always a good idea because you have one more person, like a balancing person. And then if we are still stuck, a third person comes in. So that's our standard policy. So count your signals per cell, write them down, and then calculate the HER2 CEP17 ratio. And when there is a significant amplification, there will be so many signals of HER2 that you will not be able to actually count them individually. And then we say that they have formed signal clusters. So a lot of times we may say in our report that clusters of HER2 are seen. Now these are some examples to show you. So you can see 2 green and 2 red. So this is 2 copies of HER2, 2 copies of chromosome 17. So this is a normal cell. Then here again you're seeing 3 green on the left and 3 red. And on the other side you are seeing more. You're seeing 5 orange red, and you're seeing 2 of chromosome 17. So there you have greater number of HER2 signals. This is just to give you an idea of how the signals will look under the microscope, so that when you look at the slides, you will be able to appreciate what I am saying. And you can see the nucleus, the nuclear outline. This is what I was trying to tell you. On the left side, if you can see, clusters have formed. So this is an amplified signal, and it is so amplified that some people do try to count that, oh, how many signals may this be? But typically they say more than 6 signals is a cluster. So this is a amplified case. On the right, again, it looks like there are a lot of clusters which have formed, and it's probably amplified. But here, the limiting factor is that you can't see the green signals very well. And here it looks as if the cells may be overlapping. So this cell you may ignore and look for a better cell to count at. Do not count. This I spoke about, and this is an example. Here you're seeing only green signals on the left and only orange-red signals on the right. So signals of only one color in a dual fish, please do not count them. And over-digested. See, you can't see any nuclear outlines over here. That is just a clump of cells that you're seeing. So you don't know where one cell is ending and where the other one is beginning. So any counts that you do in this situation will not be accurate. So please do not score these cells. And this is again, if you remember what I said, that if more than 25% of your cells are showing you signals like this, then the test is really not valid. If something like this is seen in less than 25%, you can ignore them. Otherwise, if you're saying 90% is looking like that, so do not score, and then 10% I'm seeing something, I will score the tumor based on it, is not a good idea. Dual probe-ish group definitions, this is available online. Thing to remember is group 1 and group 5 are the clear-cut categories, where group 1 is positive or amplified, and that is when the HER2 CEP17 ratio is more than 2 with more than or equal to 4 HER2 signals per cell. And group 5 is a clear negative, which is the ratio is less than 2 and less than 4 HER2 signals per cell. Now the groups 2, 3, 4 are what were initially called as equivocal HER2. Now with greater understanding, they have been split into these groups and they are classified further. It's again easy to remember. I'll show you the 2, 3, 4. So see, group 5 is clearly negative, group 1 is clearly positive. And this is where the role of IHC comes. And that's why, like someone was asking whether when someone orders just for a fish, can we do only the fish? You can do and get away with it if you end up with a score of a group 1 or a group 5. But if you have scores between 2, 3 and 4, you have to have a IHC to interpret along with it. And this is the importance, because if the IHC at that point is something like a 0, 1 or 2 in group 2 and 4, then it becomes negative. If IHC is 0 or 1 in a group 3, it becomes negative. It becomes a positive group, the 2, 3, 4, if the IHC is 3 in any of them, and if IHC is 2 in group 3. It sounds confusing, it isn't. If you see this table at leisure, you will understand this. So this has to be done by definition. If I'm the person who is the only person looking at the fish slides, I can myself look at the IHC and I will say, okay, this is what I'm calling it. But if by doing this, I'm still not coming to any clear answer, then I will request another colleague. Now again, it cannot be any colleague. It cannot be a colleague from biochemistry whom you will say come and show, count these signals. It has to be someone who is trained in reading fish. So call another trained colleague who will come look at the slide, and this colleague has to be blinded to what the findings have been so far. They are just looking at the slide and they are doing an impartial count, and more often than not that solves the issue. Now what can be the reasons for a failed IHC run? The pre-analytics, of course, prolonged fixation in formalin, fixation in non-formalin fixatives, procedures of fixation which involve acid. So there are times that we are called upon to do fish on bone biopsies. We do them, but we have a standard disclaimer that this has not been validated on decalcified tissue, because decalcification, if harsh acids are used, can degrade the DNA. Insufficient protease treatment of tissue, use of eosin in biopsies. Dr. Adarsh had brought it up, and we had a similar problem when we first started fish some years ago. And for us now, with the use of food colors, the problem has been taken care of. Where else can the results go wrong? If we choose a wrong area to interpret, because a lot of times DCIS shows HER2 positivity. And if we look at the DCIS and say that it is positive, even if you're dealing with a proficiency testing sample, etc., you will get a wrong result. So this I cannot stress enough, that please score only the invasive component. Then equivocal by fish and IHC. A lot of times we are not able, I showed you the group 2, 3, 4. So whenever we report a group 2, 3, 4 negative, we can say group 2 positive, group 2 negative, depending on the IHC correlation. If you are saying negative, it goes with a comment which says that, that there is insufficient data in these patients and blah, 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 and then they may not respond to HER2 and they should be considered as negative. But then what would you recommend for such patients? So sometimes they say repeat testing to rule out possible technical problems, but a lot of times that doesn't help. So if such patients recur or metastasize, then if your lab has a system where you have a chance to review that, I'm looking at this patient today, but I know that last year this patient had a group 2 negative result, then you can suggest that why doesn't the oncologist order a new fish test on this particular sample. So these patients, it is worthwhile trying to evaluate the fish again. Intratumoral heterogeneity. Those of us who have been looking at fish for some time now realize that this is really a problem in cases, and sometimes even in proficiency testing problem. So it's a well-known phenomenon. Now, depending on which literature you read, up to 40% of the cases they have reported tumoral heterogeneity. And what does it mean? It means that there are different populations of cells within the same tumor which can differ either genotypically, phenotypically, or behaviorally. And sometimes it can happen in the same tumor, or it can happen between the tumor and its metastasis. So when we talk of HER2 tumor heterogeneity, there's a difference in the expression or the amplification within the same tumor. So commonly this is seen in cases where we tend to report the HER2 as equivocal. And one of the important reasons that an equivocal report happens is heterogeneity. Before, I'll show you some examples. And why is it important to recognize heterogeneity? Because these patients may respond poorly to the trastuzumab therapy, because the patient has different clones. So, one clone may respond, another one may not, and they tend to have a poor prognosis. Now, before you say that something is heterogeneous, we have to be very clear that we didn't have any pre-analytic factors. That, the tissue was fixed properly, our test was run properly, because once we are sure of that, then we can say that, okay, this tumor seems to have differential expressions. Because a lot of times the differential expression may happen because of technical problems, some technical things that we have not recognized. So it poses a remarkable challenge to characterize these tumors, and even for imagine a lot of times you get the most frequent calls that you get for a HER2 fish is when you report that this is group 2 negative or group 4 negative, or something like that, or you write that there's tumor heterogeneity and I'm seeing a population of cells which looks amplified. Because a lot of times the medical oncologist doesn't know what to do with a report like that. Do I treat it like a HER2 positive, or what should be done? So it's a difficult call for all of us. The way they have classified heterogeneity, and which we can appreciate when we interpret fish results, is genetic and non-genetic. So what is in the genetic type? The clustered, mosaic, and the scattered type are seen. The important one is the clustered type. In the clustered type, you see two distinct areas with different HER2 gene amplification. There will be maybe a non-amplified tumor with one or two clusters of amplified tumor. In mosaic, the word itself is explanatory. You will have diffuse intermingling of cells, some of which are amplified and some are not amplified. Then there's a scattered type. In scattered type, most of the tumor looks negative, but here and there you get amplified cells, and then you're confused. So for those of you who are starting to read, the temptation is that because your eye is drawn to the amplified cell, you're seeing clusters, so you will tend to first go and count them. Don't do that. You have to count contiguous cells always. Don't just do like a berry picking and count only the positive cells. You count them in continuation. So these three types are important to remember, and for pathologists also to mention in their report. If we are reporting a heterogeneity, then we say that we are seeing a clustered type of heterogeneity, or a mosaic, or a scattered type. This is an interesting slide. So this study was done where they combined both. They combined looking for amplification as well as the protein overexpression. And here this is a homogeneous tumor. You can see that the HER2 IHC is 3+, and you can see the amplified signals here. Whereas this is genetic heterogeneity, because you can see here are the amplified HER2 signals, but they have not expressed the protein. Whereas there are some where there is protein expression and the signaling. And this is non-genetic heterogeneity. So the ASCO CAP guidelines, Dr. Vinita explained to you how the ASCO guidelines progressed. So the recommendation is that unusual pattern, this is the current one, 2018 HER2 recommendation. Unusual patterns of HER2 expression can be encountered, including strong and complete staining, but in less than 10% of the tumor cells. These heterogeneous cancers would likely benefit from retesting at recurrence or metastasis. So what we do is if we see a different area, we do a separate count of at least 20 non-overlapping cells. And then we mention that in our report, that a separate area showing this was seen. And this indicates tumor heterogeneity and that this patient will benefit from retesting. Now, the 2023 guideline basically came up more to discuss the HER2 low issue, the 0 and the 1. And as of now, CAP is not supporting the 0-1 issue. They say for pathologists who want to report it, they can report the 0-1 on IHC. But they have said that there is no change in recommendations from CAP as of now. One reason why tumor heterogeneity, okay, I have told you this. Yeah, so what are the important things to remember? The cold ischemic time, the time from which a biopsy is taken and placed in formalin. This is repetition because it's applicable for IHC and it is very true for fish as well. The cold ischemic time has to be less than 1 hour. The duration of fixation in 10% neutral buffered formalin should be at least 6 but not more than 72 hours. The 72 hours become crucial when you're talking of weekends, like a long weekend like this. You have to figure out a way in the lab that the tissue doesn't stay in formalin for more than 72 hours. And even for busy labs, however much they'll say ki we've done the biopsy now and take it right now for processing, please ensure that, so we have our way in which we have counted our cutoff where minimum 6 hours the tissue does stay in formalin. Decalcification, I told you, it can be negatively affected. And this is how the heterogeneity can, affect the patient treatment decisions. So if you see in heterogeneous cancers, there is a higher chance of, this is complete pathologic remission after neoadjuvant chemotherapy, whereas here pathologic remission is not happening. And the chances of distant metastasis and death are higher in these patients. This is one of our recent cases. Dr. Vinita had reported it. So you can see there was a single amplified nodular area which formed more than 10% of the tumor volume, and that had a ratio of 2.79. You can see here, what I was telling you, the clustering of signals or many signals. The rest of the tumor area is not amplified. This is how the rest of it was. Here. It was not amplified with a ratio of 1.36. So this went with a comment of tumor heterogeneity. And the other problem that we have faced from time to time is the polysomy 17 issue. So what is a polysomy? Polysomy is where it's not just the HER2 signals, but even the CEP17 signals are numerous. So what happens is, although your average HER2 signal number may be high, the ratio itself doesn't go high because even the CEP17 signals are high. But when they are actually tested, only 1 to 2% of these carcinomas have true polysomy. So nowadays the recommendation is, instead of saying, when we get a finding like this, in the report, instead of suggesting that this is a polysomy, they say that you can write that this indicates an abnormal copy number of the chromosome 17. And this is one reason why we get HER2 equivocal protein expression reports, and sometimes this can also account for tumor heterogeneity. These are the references. I think now you should take a look at the slides.
light color will be different. And emitted light color you will see from the objective lens.
Okay, that is what you are telling.
Yes,
Exactly.
two
that I
different
know.
colors. You remember I was telling you?
Yeah.
That is it.
It's
You need
okay.
mic.
Okay. నేను ఆఫ్ చేస్తున్నాను
ఇప్పుడు అవునా
ఏంటి సౌండ్ ఏంది కానీ దీంట్లో మొత్తం సారీ సారీ దీన్ని బ్రైట్ ఏది
Yes, it's focused.
And this one is which from here?
Now it is. Oh, I'm sorry. This is our slide PMA with the 1+.
So I think this they can start seeing. Put it in.
Okay. Actually, dual I need to show you. This the filter using this separate. So whatever the blue signals that represents the cell. And if you're seeing the cell in a ring mode, that is the donor cells where you have the over-digestion of the vaccine.
Try to just see only one single at a time, not all the cells. Just see single cells so that you understand whether the cells have
One blue cell. Blue color.
That is because of your DAPI count state, and you are observing on a DAPI filter. So that's why you're seeing the cells in blue. Since it is in DAPI filter, you're seeing blue in color. But ultimately, you see the objective lens color that is violet in color. You remember in the presentation I was telling you there are two different colors with the DAPI filter. The excited light will be violet, and the emitted light will be in blue. So the same is here. The sample, the light is striking the sample in excited light that is violet in color, and the field of view that you're seeing is blue in color. That is because of your DAPI filter. And the counterstain that you have used is DAPI. That you can adjust according to your highlights.
Yes, it's blue.
The objective lens color is blue, but the field of view that you see that will be green in color. Yeah, that will be fixie filter because of your fixie filter.
Set 17 change. So it's a kind of green.
The green signals that you have seen is the centromere of chromosome. And now she is shifting it to TRITC, where you see orange color signals, that is HER2 gene. Centromere is different, and the gene that is coding for protein is different. The orange signals that you see now is the gene expression of HER2.
So ideally the sequence in which you do this is first you see things when, I mean that's how we do it. We first see things when the damage is a bit slower. That's how we focus. The other fear is always released in just like because you're worried you're going so close to it. So you focus it in DAPI and then you can again see how the nuclei are arranged. After that, so you look at the SEP17, yeah. So here you can check what filter that is. And use your fine focusing because it will not always be in focus. This. So that gives you an idea of the SEP17. Then you see the HER2 and then you see both of them together. Are you able to see? What slides are these? These are the whole tissue or a microarray?
Micro.
Okay. So now you move to the...
Now it's in TRITC. You want me to show you the
No, no. She's seen the SEN 17. Whatever is your color, huh?
Yeah, but the amplification here is orange.
Yeah. I see. What did you see? Are they how many signals are you seeing per nucleus, or are you seeing those grape-like clusters? What are you seeing? You have to train your eye because our eye is so used to bright field, na? So fish take some time to get used to. Shall I see? What magnification are you on? Can you go higher?
One more higher.
And every fluorescent microscope is different, so you have to get used to a particular microscope also. I need to go higher than this.
Next is 100x oil immersion.
Is there oil? You're putting oil?
Not getting put yet, but if you want, I can give you the order.
Yeah, please.
So we need to see an oil immersion.
The initial scanning you can do under a lower magnification, but the fish signals we
have to read in the oil.
We read in oil. This next one is oil, na? Shall I put oil now? Yeah, this is 100.
Just once the field is focused, then we can put the oil.
Whatever we are seeing.
Not. Can I move it to the SEP 17 filter? Yeah, to this.
Just this. It's 5, right?
It's fine.
This is 5.
This is fine. No, it's dark.
This is in 6. What is there?
This is the new one only.
We have to change there also, no?
Here, I don't know.
Change to B.
No. Which one now?
SEP 17 volumes.
SEP 17 is you need to keep 6 filter over here and you need to on blue.
Blue, no? That's what.
6 over here.
6 over here.
In focus.
So
This was what now? SEP 17.
The signals are in orange color.
no, green.
Green.
Now I'm seeing green. But I'm wondering if I can go on a higher.
And you can increase the light intensity also. Let's try.
So can you just see? Yeah, you can see how the cells are looking. I'm not able to get a good signal in there to show. This is a microarray, you said, no?
Yes, ma'am. Halfway out.
Somewhat here they are, but I don't know whether they are in the nucleus or not.
Green dots are there. But some are inside the cell, some are like, so we will count only the nucleus.
Yes, whatever. But we have to see it in every cell.
Is there anything chemically that we should just adjust?
Hazel?
Can we move to the sub-70? And the HER2 is
Orange color. Have to change to
Yeah, we'll change it. But at least if you're seeing some orange color, then
no.
nothing?
We have to change to that means HER2 is amplified more, is it?
you can see that clustering kind of. Again, you have to train your eye to look at it. Within the outlines of the cell, you can see dot dot dot. Each dot. Sorry. Here they are seen as clusters. Where they seen separately.
Cluster means the entire thing will take as
Some people count. Okay, this cluster has 12. This cluster has 14. It depends. So one of my colleagues they count. And say amplified and amplified signals are seen as clusters.
This is a
When it's more than 6, they say it is all right. Because, 6 is your 6 signals per cell. So if anything above 6, that is in a cluster more than 6.
the slides will be like this only, or it will be better still.
No, if we are able to see both together, no, then you will get, I don't know how to set it, you will get both. So then you will get to see a green signal, which is your reference signal, 1 or 2, and then you will get to see these positives. They will have, okay, that will happen, yes.
And here in the center is the cluster.
In our system, we see 1, 2, and then we overlap both, and we are able to see the microscope only. No, that is a non-specific. Because you can see something like a membrane, and this is not a good area to interpret also. Because if you see on the left side, the cells are kind of overlapping, and also I wouldn't count it in this. That other area which we were in was good. We are at 100x. Others can.
already complex cases. So there we can't really do the cost cut. But यहाँ पे ऐसा है कि sending from a medical college, we're sending us extra patients. Then because we are associated with Tata Trust and so then we can do it on a cheaper rate. बहुत ही गरीब patient होते हैं, patients होते हैं हमारे government hospital में. तो उनके पास poverty card रहता है depending on काफी disadvantage. But otherwise that's the charge. But people are sending a substantial amount. We can speak because of course when you have more workload, the cost per test comes down. The cost per test comes down. So for you are also from a medical college. So then I can speak with the medical colleges, the patients are more and see the IHC also what we might do with the IHC also is not many platforms. So we do it on media and we use part of the and अभी जो हम टूल वो आती है what you are trans-to-somal plus society which they are using in metastatic. So it is the same antibody which they are validating and we have been doing it on quite some time. So if we give you that tool, then you as a clinician know that you can use even that score 1, you are very sure that it is low HER2 and you can use it for other therapy. Now there are so many platforms. People are doing manually also manual ka to recommendation. But the recommendation is you should not be doing it manually. You should not be doing it. It should be but then this is for inside the matter and ERPR COP2 is 3,500. That is a competitive rate that I think is over here. And you add an AI, then it is good. But if you're sending in 10 or something like that, then I can speak, but you have to get because to present to the management about why should they give you discount. And of course, you can write a mail saying that you're from a medical college and you're patients. Something like that. Then I can work with you and speak. We have to present that. आप लोग का स्कीम्स का मोस्टली लाभ टाइम पे आप भेज सकते हैं बट वहाँ जो ये सब we are not corporate. हम standalone है, but we are not corporate. We are a Tata Trust. It's a trust. It's a cancer foundation trust and it's a focused oncopath center. तो हमको profit नहीं बनाना है. चल रहा है और fellows उनके centers establish करने में मदद. That's why we are not corporate. We are dance. All these are we have to make that business. If you, yeah, we can pick up and drop now from the third city to get it done with many of our clients. So what we do, we ask Blue Dart to pick up the samples for us. If you are arranging a pickup, unless Blue Dart does it for us, so they fix some time and they reach at that point and tell us where Tata Vanuji के साथ हमारी बात चली थी और लॉजिस्टिक पिकिंग अप एंड लाइक दैट विद Vanuji तो फिर तक लॉजिस्टिक थोड़ा स्ट्रीमलाइन हो जाएगा पर अगर आप एक सब्सटेंशियल नंबर इफ यू सेंडिंग टू अस देन courier pickup and all I can just I put my people on logistics how they can help you. Sure, you calculate your thing and let me know and I'll see what I can do from my end. This is my card. Send you the centers for We are actually all Tata trained people. I have the list which is amplified and which अपना भी area Similar to that on the slide which you have seen first.
It's like flow cytometry, no? They show you something is red, something is green. You have to know what that particular.
So that particular normally for the heterogeneous crop type. So just have to find it. See, the cell outline is not again the same. The focus. Everything is not actually cell in one cell as one cell. Some scattered cells. That is not basically replicated. But if you have a nodule like this, like 20, 30 cells, more than 10%, so it will proper nodule. And the rest of the entire vaccine is then this is cluster. So this is a proper flow. This is clearly so then we are
Mosaic is a pattern of heterogeneity. Cluster. But it's not clinically relevant. Mosaic is not because it doesn't form a cluster. So for us, we plan, like, now we have to come here and it's a overnight procedure.
that's what I'm even that way checked on, but there was no
Even Thursday, mentally, we have to be prepared for Thursday afternoon.
because there are no cells as such. There are impact of free.
Reporting me was also calm.
No, it is not focused on the tissue. It is on the slide.
was an amplified data, this was negative, so on higher part, this is how the amplified versus the, this is like autofluorescence, how it looks.
So this
So
is
do
all
not
like
misinterpret it like a cluster. That's
all
what.
because this is all clumped.
Correct.
That's why.
You were showing something
No
that,
red
no, that
nuclei
was,
but
this is not
initial
the
focus
interpretation.
was-
So this is how an autofluorescence will look.
This is
Sample,
Gaussian.
cell, sample rejection,
This
no
is all
red taken from our actual cases. This is a group 1 positive. You can clearly see. Okay. Group 1 is clear positive, 5 is clear negative. This is group 2 and this is the comment that goes with all our group 2s. These are just examples. These are group 3 negative cases. Group 4 negative group 5. Can you just take this one? Yeah, there is one with autoclaves. This is the one. This is the one. Yeah, this is the one with autoclaves. I have given them the pictures clicked from the same cases. Okay. So she's going to go and study them and ask the test. It will take you 55 to 60 minutes.
step